फोटो खींच ले सीधे यार। इतना क्या सोच रहा। हेलो 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 हेलो। माइक पे बोलियो यार कुछ। फोटो खींच ले सीधे यार। ठीक है। इतना क्या सोच रहा। शांत रहो।
सब हाथ ओपन कर दिए हैं।
तो भी
कर रहा था तो सब ओपन कर दिया, शेयर नहीं हो पाई है।
शेयरिंग जस्ट अ सेकंड, लेट मी चेक क्या दिक्कत है।
And actually, after this approach of actually giving phototherapy to all infants being 11 to coming down, actually decrease the exchange transmission from 24% to almost 5%. Now we are actually looking into the side effects of phototherapy in extremely low birth weight infants. And yes, when we are getting little sensitive about the side effects of phototherapy among low birth weights, we are still quite concerned about the bilirubin neurotoxicity. This was a very good study which where you see if you are looking at the cases of palliators, as the gestation age decreases, so as the gestation age decreases, the cases of palliators will increase. And historical risk factors. So, these were the factors. Baby had hypoxia, had acidosis, had hypothermia, had low serum albumin, having sepsis and some duration of shock. So these were the risk factors, and they increase the bilirubin neurotoxicity. Yes, in preterm, the neurodevelopmental impairment, which is that even modest total bilirubin levels can have neurodevelopmental impairment in babies when followed up at 18 to 22 months, and they have increased mortality and neurodevelopmental impairment with some auditory, neuropathic, or visual motor processing disorders known as bilirubin-induced neurologic dysfunction (BIND). Some preterm babies are relatively resistant to even relatively high bilirubin loads. If they are not actually not having increased production because of increased hemolysis. If RH, जैसे हमने RH cover कर लिया, RH और other hemolytic conditions को हमने cover कर लिया है. So the effect of toxicity in these babies is getting lesser and lesser. And what is important is unnecessary or over prescription of phototherapy may compromise the ability of bilirubin to serve as a protective antioxidant from bilirubin neurotoxicity, which may occur at even very low total bilirubin levels. So bilirubin, अगर कम लेवल का bilirubin भी है, तो it may be neuroprotective at some time. This was the theories, and there are some studies even from India which can prove that. What is the incidence of connectors in preterm babies? पुरानी स्टडीज 1955 वाली जो है वो तो बता रही है कुछ, उसके बाद से ढंग से कोई स्टडीज हुई नहीं है. We don't do those autopsies, we don't do those. हमें अभी कनेक्टर्स क्योंकि एक पैथोलॉजिकल टर्म है, सारे बच्चों की ऑटोप्सी नहीं होती है, तो we don't know जो बच्चे पैक कर रहे हैं इन प्रीटर्म्स उनमें कितनों में कनेक्टर्स के फीचर्स थे कि नहीं थे. एंड पोस्टमार्टम न्यूरोपैथोलॉजिकल स्टडीज जो टैली हुई उसमें this is again an old study, 4% in 81 preterm infants who died after 48 hours of life. But there is no prevalence of connectors in preterm survivors. And yes, the incidence is also limited by the timeliness and aggressiveness of the intervention. Now we are already so aggressive, and there are so many risk factors which can modify. There are so many internal modifiers which can actually change the outcome of conjunctivitis. Moreover, hyperbilirubinemia and hearing loss relationship is significant, but it is again modulated by the other risk factor which has been told. Those with high total bilirubin levels more than 14 and those with birth weight less than 1500 grams have a higher risk of deafness. That was in studies which was seen. And the mean duration of hyperbilirubinemia was significantly more in deaf infants. In those infants with hyperbilirubinemia, where they had more acidosis. So babies who are not managing, they have some cardiovascular compromise, they were more likely to have deafness with jaundice. And acute signs which we know of acute bilirubin encephalopathy, like mental behavior status, which is changes from lethargy to hyperactiveness, crying to various degrees of drowsiness, poor feeding, lethargy, hypotonia, excessive muscle retrocolis causing an oppositonus, and then maybe getting increasingly severe show of seizures as well. These are seen in more of hemolytic conditions, more in preterm infants. Most of these signs may not be easily seen. Connectress, which is interchangeably used with chronic bilirubin encephalopathy, is actually reserved for irreversible classic sequelae. We see dystonia, acetoid cerebral palsy, paralysis of the upward gaze and sensorineural, hearing loss of varying degrees of severity. And as many of you, the young ones must not have seen conductors, sir, the old timers must have seen कि बच्चा एकदम acetoid palsy ऐसे करके आ रहा है, एकदम doodling कर रहा है, सब कुछ कर रहा है, but बात करने में एकदम ठीक है, mental faculties cognition काफी better है. So this was a striking feature of acetoid CPs because of connectors. These signs are also not very clearly discernible in preterm babies, and since preterm babies have already brain injury because of periventricular recombination or other conditions, so it is very difficult to say what is causing the CP in preterm babies, whether it was because of jaundice or not. Bilirubin-induced dysfunction is actually a wide spectrum of disorders, which something has been proved. Mainly, we now focusing on auditory neuropathy or auditory dysynchrony, where there are distinctive findings on the ABR, but you have normal cochlear function and normal OAE without severe hearing loss. And this is some kind of a dysynchrony. And the subtle signs are awkwardness, minimum fine and gross motor coordination, some gait abnormalities, fine tremors, some accelerated extrapyramidal reflexes, and some this. So this is something of a different kind of a mind which can occur in preterm. Auditory dysfunction is now more specifically called as auditory neuropathic spectrum disorder, which is again the outer hair cell function and the auditory transductions are relatively normal, while ABR testing is abnormal. So it is more certain neurological manifestation of this. So this is something which we may encounter when we see our patients who had suffered hyperbilirubinemia of a significant degree. And a good visual-cortical dysfunction. So a number of interesting and potentially worrisome findings. The visual cortex function in healthy bilirubin exposed infants. So they did not have very sick children. And there, the measurement, which is known as the SWEP parameter, visual evoked potentials, was seen over a wide range of क्या light का contrast क्या था, क्या frequency थी, and whether the क्या vernier offset sizes जो आपके size होते हैं letters के जो बच्चा पढ़ रहा होता है कितने size के थे. So those were seen, and the responses were all enrolled infants at 14 to 22 weeks postnatal age were seen, and infants who had hyperbilirubinemia showed lower response amplitudes and worse or immeasurable swept vernier effect thresholds. And this shows that yes, the vernier offset for thresholds were correlated with the total bilirubin levels. And this is with the body activity. So बच्चे की कितनी visual activity होगी, वो उसका close, which we test the Snellen और opto type of activity जो test करते हैं, उससे वो dose related है. तो bilirubin जितना ज़्यादा होगा, हो सकता है visual activity में कुछ फर्क पड़ सकता है. Again, apnea is related, has been found to be a manifestation of wine. And when we do MRI, interestingly, आपको कुछ दिन पहले आपको टीबल में इमेजेस में कुछ हाइपरटेंसिटी दिखाई दे रही है ग्लोबल पैलेस के अंदर, जो ठीक हो जाती है. फिर जब आपको फ्लूइड एटेन्यूएटेड इन्वर्जन रिकवरी इमेजेस में आप देख रहे हैं, हाइपरटेंस हो जाते हैं, and then they may change and may come later at some point of time at variable duration. तो nobody can just say कि इसको 40 हफ्ते पे करना है, एक महीने पे करना है, एक साल पे करना है. कब MRI में चेंजेस आएंगे which can be attributed to hyperbilirubinemia are not very conclusive. A normal image does not eliminate the possibility of bilirubin-related brain injury in preterms, and an early add-on pattern followed by an apparent resolution, and then it can be visible. And obviously there is a periventricular leukoplasia kind of and other preterm-related MR changes which can occur, which may confuse you with the because of jaundice also. Now, bilirubin is beneficial. Mildly elevated TB may be associated with lower morbidity and related mortality, which could be attributed to the antioxidant properties of bilirubin. So this is something new which has come up in the last decade. Dr. Pankaj, this is what you wanted me to focus on, that bilirubin may be useful. I remember my professor, Professor Faridi, used to speak in उस जमाने में 90s में जब बढ़ते थे, हमें क्या पता कुदरत ने क्यों बिलिरुबिन को दिया है. कुदरत भी काम गलत नहीं करती है, तो हो सकता है कुदरत ने कुछ काम तो सही करा होगा, बिलिरुबिन का कुछ तो फायदा होगा, नहीं तो 90% बच्चों को का तो बिलिरुबिन नहीं बढ़ने वाला है. हर चीज किसी मकसद से होती है. तो I think we are coming to something like that. I'm not saying that it's a good thing to have baby lack of bilirubin because it is proven that you can have bilirubin-induced neurotoxicity. But yes, so there is some antioxidant properties of bilirubin, and this is attributable to hemoxygenase 1 enzyme, which is enzyme which converts heme into equimolar iron and carbon monoxide and bilirubin, which and responsible for the HO1 expression of cytoprotective properties. Now, people in adult cardiology actually are looking on this HO1 enzyme very carefully because it has been found that it prevents atherosclerosis, coronary heart disease, and strokes also. So this is something which was सबका bilirubin बड़ा देना है. In fact देखा कि adult ICUs के अंदर जिनका bilirubin जिनको ज़्यादा था उनको stroke कम हुआ, उनको heart attack कम हुए. So maybe some reason that bilirubin may be a good thing in adults. Actually, there are studies which are going on. So from there I'm coming to Mazur's this study, and he is actually giving an observatory study कि अब हमारा क्या trend चल रहा था. 1985 में हमने का प्रोफेटिव फोटोग्राफी देखते हैं. उसके बाद से क्या ट्रेंड चला, इन्होंने दो यूके सेंटर से नॉटिंघम में जाके, so they were actually following the same, and they were managed with the same almost group of neonatologists, same guidelines over 4 time periods they said, and infants who had more than 7 days of this, and this is how they did. 4 टाइम पीरियड्स में करा उन्होंने, एक 2009 से 2010 के बीच में जब बर्थ क्राइटेरिया उन दिनों बर्थ वेट अलोन का चल रहा था. फिर दूसरे में बर्थ वेट एंड जेस्टेशन एज का क्राइटेरिया था, 2010 से 2011 के बीच में करा. 2011 से 2013 में जेस्टेशन एज आई थिंक नाइस गाइडलाइंस वर कमिंग, एंड दिस इज द कंसेंसस इन द नाइस गाइडलाइंस which followed in 2013 to 2015 where gestation age was used. And they found over these 4 time periods, if you see, जो मीडियम टाइम है स्टार्ट करने का फोटोग्राफी, तो पहले 35 घंटे 46 घंटे 70 आवर्स 52 आवर्स होता था. People started giving phototherapy much earlier. 26 hours, in fact the total is 42.6 hours paid phototherapy सब ज़्यादा बच्चों की चालू हो गई. And the median duration of phototherapy actually increased from 49 to almost 80 hours in extremely preterm babies, less than 28 weeks. So people actually were giving early phototherapy and they were giving more phototherapy. Is phototherapy harmless? Again, significant short-term side effects. These include it can have some DNA damage, alteration in cytokine levels, and oxidative stress that leads to an increase in carbon monoxide production, which are good in the skin and possibly internal organs as well. Light is also absorbed by hemoglobin and it can impart a heat load, which may be harmful. And large epidemiological studies have found that there is some relation with cancer. Myeloid, not leukemia, but myeloid alterations have been seen in babies who were given phototherapy. Not that I'm scaring you, I really want phototherapy to be in every place in all essential life. It has been associated with light, has been associated with epilepsy. So, in the Neural Research Network studies, they found between the aggressive and phototherapy was compared with in very small babies who were 500 to 750 grams, there was a 5% decrease in neurodevelopmental impairment and a 5% increase in mortality. So, whether it was because of phototherapy aggressive, they can be because of other reasons as well. And actually, those who are on aggressive phototherapy receive almost 88 hours of phototherapy compared to only 35 hours in the conservative groups. So this is a study from India, KMC Bangalore, where in Indian study we have actually tested the oxidant, antioxidant status in preterm neonates who were treated with phototherapy, conventional as well as LED phototherapy. And in this, venous sampling was done prior to and at 48 hours after phototherapy to determine the total bilirubin, कितना ऑक्सीजन स्ट्रेस था उसका टोटल, कितना ऑक्सीजन कैपेसिटी थी एंड ऑक्सीडेटिव स्ट्रेस इंडेक्स था। तो ये इंडिया में पूरी स्टडीज हुई हैं अभी और ये 2015 की या 16 की स्टडी 2017 की स्टडी पब्लिश है इंडियन डाटा। So and they use this method, Adams method, I don't know what is this, but they calculated it. So and you see the baseline characteristics between the two groups, the convention and the LED was same. Nothing to the total antioxidant status, total oxidant status, and the oxidative stress index were just the same in the two groups, and even the bilirubin were just the same. And post phototherapy, yes, the conventional had lower antioxidant status and their higher total oxidant status and higher oxidative stress index in conventional LED, but दोनों में ही बढ़ जाएगा। प्री एंड पोस्ट में अगर इस डेल्टा अगर आप देखते तो प्री फोटोथेरेपी पोस्ट फोटोथेरेपी में दोनों ग्रुप्स के अंदर ऑक्सीजन स्ट्रेस बढ़ा। Phototherapy increases the oxidant stress in both groups. Obviously, conventional phototherapy, I think almost all units have stopped now conventional phototherapy. Is anybody using phototherapy which doesn't have LED right now? सबके पास LED है क्या? I think everybody is using LED. तो कहीं पे भी conventional all SNCs have also LED phototherapy. So conventional phototherapy is actually increase more oxidant stress compared to LED, but both has increased. Phenobarbital. मैं तुमसे पूछना चाहता हूँ क्योंकि मैं कल दीपक शर्मा को फोन कर रहा था। ये मेटा-एनालिसिस और सिस्टमैटिक रिव्यू निकाला 2009 में पब्लिश किया गया। I don't know whether it stands the truth of the day or not because this was the only thing which was available there and they reviewed and 2009 का सिस्टमैटिक रिव्यू कितना सिस्टमैटिक था मुझे पता नहीं, but yes, this was a systematic review done at this and 3 RCT देखे गए थे मेटा-एनालिसिस में और yes, phototherapy was so good. Actually, the mean difference in decreasing peak serum bilirubin was -1.78. There was the total duration of phototherapy was decreased by almost 15 hours. The need of phototherapy decreased to one-third or 60%, two-third, and the need for exchange transfusion also decreased to two-third by giving phenobarbital 10 mg per kg per daily dose दिया था उसके and it was done. But I don't know whether this was done or not. Transcutaneous bilirubin is another thing which I wanted to. I think many centers are using. Compound TCP use कर रहा है anybody? Apart from anybody? अभी this using I think. So अभी transcutaneous bilirubin available है, अलग कंपनी के available है. This study was done by Dragar GM 103 and they did the phototherapy जिसको मिलती है उसमें आप जिसने नहीं देखा एक बिल्डोमीटर होता है जो आपका नॉन इन्वेजिवली आपको मेजर कर सकते हैं. Very good.
You can wind up perturbations on times.
Your delay charts are to the last one. So this is the one, and they found that there was the transporting is actually underestimated by almost 3 milligram per deciliter, and the overall correlation was very good between the transcutaneous and the total serum bilirubin. And if you see the chart, this one there was no difference between the total serum bilirubin and the transcutaneous, and there was a good correlation between the total serum bilirubin and the transcutaneous bilirubin. Very good correlation. And this was done, and this was before phototherapy, no difference. During phototherapy, no difference, and even after phototherapy, there was no difference between the transcutaneous and the total serum bilirubin. Only that there was a difference, underestimation of 3 milligram per deciliter. अगर आप उसको अकाउंट कर लेते हैं, तो you know कि आपका ट्रेंड आपको पता चल जाएगा कि कैसा चल रहा है, बढ़ रहा है कि घट रहा है. So that is very much you know. So this was what was the key which I gave last Pcni. So this 2019 to 2020, I think this is the new reviews where they have and Akash Pramita is from SCPJ Lucknow, and this is the some guidelines which have been published, and I think I will just rush through them because TSB is not reliable as the only thing. There are many other factors which play a role, which is low immune level, presence of comorbid conditions, such as sepsis. All those have been alluded to. Now that Cockington start way back, which we were using, no more use. Sangeeta, we were using GTP and the Cockington start. No more use. Outdated है. Weight-based start से. Nice guidelines and operation threshold. These are the commonly used ones, and I think why it happens. So this is how it happens, and I think again this is what was known. The risk factors, and there is some innate resistance of babies also to have this. So there are some transporter. So this is the last chart. Yes. Now since we have LED phototherapy, क्या आपको देना चाहिए? अब तो हम सबसे अच्छी फोटोथेरेपी लेंगे, सबसे बढ़िया फोटोथेरेपी लेंगे, जिसके अंदर 50, 60, 70 माइक्रोवाट पर सेंटीमीटर पर नैनोमीटर का आपका इंटेंसिटी रेडियंस आ रहा है, ऐसी फोटोथेरेपी लेंगे. Now the evidence is saying that you don't use double phototherapy in preterm babies. You start if your babies are double 1 month, not with very high risk factors. Probably you should start with single phototherapy and keep it around 10 or 15 microwatt. So वो आपको phototherapy आपको use करना पड़ेगा. बहुत high intense phototherapy आप नहीं use कर सकते इन बच्चों के अंदर. And this was the thing. And these were the Pcni charts which were referring to. Now these are the charts which can be used according to these reviews. I don't know how good they are, but this is the latest evidence over there. Other things about IV hemoglobin, no role in preterm, albumin transfusions, they have more harm than good. Phenobarbital, according to these reviews, not good evidence. Deepak Chawla, I was contacted by them. And other therapies like methyl oral agar and aspartic acid currently not. Thank you.
Thank you, Dr. Bliss. So it's very clear that overuse of phototherapy is there in premature babies. All of us see a lot of phototherapy used in the first few days because of nice guidelines. So we should know that bilirubin is an antioxidant. God has made it for some purpose. And it has also been shown that prophylactic phototherapy in newborns, premature newborns, increases mortality, which you very beautifully showed. That is why I think it's time to switch from NICE to Pillai guidelines so that we can cut down phototherapy. And we also have better grades when to use single surface, when to use double surface, when to use LED, especially when to use high irradiance in premature babies. With these, I thank doctors. This is a difficult topic. It's reviewed it very beautifully. Thank you so much.
No question.
By the time the organizer is coming, if there's any question, you can.
We can have questions.
By a comment more than a question, but yes. Thank you so much.
Okay, with this wonderful session in immunology, we proceed to our next session. There's a slight change because of emergency. We have changed the topic. It is again related to neonatology. The topic for the next session will be newborn birth defect registry. And I now invite Dr. Harish Chelani, Professor Pediatrics, BMMC and Safdarjung Hospital. Sir has over 40 years of experience in newborn care, and he has been ex-HOD of BMMC College, and he is in charge of NICU at BMMC and Safdarjung Hospital. Welcome, sir.
Good morning, and thanks for the opportunity to chair the very important session on the newborn birth defect surveillance. In fact, we all know that with the improvement in the neonatal advanced care and the more of the institution deliveries which are happening, the proportion of the neonatal sepsis which has come down, and as well as also the birth asphyxia issues. If you see in the developed and some of the states where the infection and asphyxia rates have come down, the problem of the birth defects and the premature and low birth weight babies, particularly the extreme low birth weight babies, numbers have gone up. Now, when you have these numbers which are going up, particularly of the birth defect, we need to know how these numbers are there, what are their patterns. Unless we know the pattern and their progression at the time at which you can pick up, only then we can have the preventive strategies. So it's very important that we must have the birth defect surveillance program, and we are fortunate that the Delhi started as a pilot project as a birth defect surveillance strategy, and then the experience of that has led to the culmination of the national strategy. So how the making of all this thing has happened, we will listen from Dr. Shobhana Gupta, and no other person could speak on this because she is the nodal person at Safdarjung Hospital looking after the newborn birth defect registry, and she will in next 15 minutes she will talk about this birth defect surveillance. Over to Dr. Shobhana.
Thank you, sir. Thanks a lot for giving me, thanks to the Delhi IIT for giving me this opportunity. And this actually is very near to my heart. And Dr. Chelani is always a mentor and the founder of right from the start when we started this journey in 2014. So I will be taking you forward towards what the journey we went through and how we culminated from a small pilot study. We are going towards a national program. And what we did study in between the small studies, which actually helped us in seeing the pattern of the birth defects. So as we all know that birth defects account for the 7% of the neonatal mortality worldwide. Gradually, the relative proportion is increasing because of the better outcome of the other predominant diseases like the prematurity, asphyxia, which we are getting improved over the last few years. So, and especially the developing countries, because of the more number of birth defects as such, the 29 million births occurring alone in India, we are actually amounting to quite a proportion of birth defects overall. So, the reported prevalence in the live birth is around 1.6 to 3.2%, but this is actually tip of the iceberg because many of the birth defects, as we know, many of them are internal and many of them are in fact terminated. So, they might not be counted in our setup where the facility for autopsy or the antenatal detection is not there. So, the proportion might be much more than we are actually seeing in the data. The most common birth defects in India we see till now are the congenital heart disease and the neural tube defects. In the external, they are being reported majorly. and these are the one. Followed by we have the hemoglobinopathies as an internal defect. So as Sir rightly said, it started as a pilot project and it started initially in Delhi and Chandigarh in 2014 in few of the tertiary care hospitals. And for this, we collaborated with WHO, CRO supported this, and the pediatrics department and the obs and gynae department actually came along. And initially, the primary objective was just to collect the birth defect prevalence data, because till that time, actually, we did not have any national figure or national estimates available for developing countries. So Southeast Asian region and WHO took that initiative, and in consultation with the Ministry of Health, it was started in few of like PGI Chandigarh and the Sufficient Hospital in Delhi. They were given the responsibility of starting this. So at that time, the hospitals we selected were the government hospitals and the private hospitals also initially we included, which have a high number of delivery load, because it was a hospital-based surveillance and the purpose was to select the maximum amount of the data which was available. So the initial experience at the newborn actually birth defect surveillance actually gave us, help in many things. First of all, there was no standardized procedures or the methodology available that how to collect the data. So actually it helped in the collection, that how when to collect the delivery areas, the high delivery areas, OTs, who will collect the data and how to upload that data. And share further with the WHO as well as the ministry. So for that we developed the single pager, easily designed performer design for the birth defect, where the person can collect the initial few important demographic data along with the description of the birth defect. The photograph was taken and uploaded, and then it was sent and shared with the WHO. For that, actually, with the personnel involved, there was a training was arranged for them. So initially, the nodal persons were identified in all the hospital sites. In Delhi, initially we selected the 8 hospitals of Delhi, which were the major government hospitals, including the Sufficient Hospital was the nodal center. And after the experience of 2 years, we extended it to 20 government and private hospitals. So that's how it gave us the overall view that how the pattern is going on. So nodal officers were selected at each of these sites and they were given training on the collection and the reporting of the data. For that, capacity building, actually the orientation workshops was done in our hospital, Sufficient Hospital as well as the other sites, so that the people were trained that how to collect data, and the important emphasis was put on the quality, that is not to miss. So initially there was problem in the completion of the data. It was an incomplete data because if the data quality is not maintained, it's like a junk. So how to completely describe it and accurately code it and then timely upload it. So the CAT has to be followed. That completeness, accuracy, and timeliness. All the 3 factors were given emphasis while training the data. So there were initially a lot of challenges were faced because people did not know how to code it, how to describe it, and what is ICD-10 coding. That trend is still not there, at least in government hospital, that ICD-10 coding is very essential when you are actually looking at the data at a larger aspect, or when you have to comparatively see at the whole world. So that ICD-10 coding is really important for the accurate detection and retrieval. So for that, trainings were arranged. And with this, having emphasis on the CAT, we were actually able to reduce the error, which was initially 40% till around 5 to 7% after the recurrent trainings. Simultaneously, we developed, after this exercise, we were able to develop the tools for the birth defect surveillance. That 2-day training was devised, and the how to initiate a birth defect surveillance in a tertiary care hospital, and the facilitators guide, they were devised along with the nodal center, WHO, and the WHO collaborating center again. So all of them get along, and those tools were devised, and they are being accepted by the Ministry of Health also, and they are available on the Sentinel by the name of the Sentinel surveillance at the Ministry of Health site also. So this we were doing this registry for 2 to 3 years, but this was all these things are happening in isolation. Like the Chandigarh was doing for the North India, Delhi was doing for all the Delhi hospitals. So there were individual groups. It was going on an individual basis. So the need was arised how to develop and integrate and scale up the whole of the system, so that we are able to develop the national birth defect surveillance system at the national level, and we can have a uniform inclusion criteria, and we are able to systematically collect. And ultimately, we want to link it with the national program of RBSK, which so that the services can be provided. The ultimate link was to estimate the prevalence and then link this to the service delivery, so that the patients can be provided the how many surgeons and what all facilities are having the neurosurgeon, cardiac surgery. So ultimate aim was to link it with the services, along with yes, the preventive factors which we can inculcate in our programs. So this data sharing and networking among the different hospitals and ultimately the teamwork which we all learn led to the successful daily newborn birth defect registry. And now the purpose is to develop a national perinatal birth defect surveillance program. So that we are actually able to understand what is the public health burden and design the further programs. So the objectives for that the National Perinatal Database Program remains the same, to generate now the stillbirth. Again, is a very important factor, because we were looking up data for the live births only. Now we are also in the later on phase, we also started looking at the data for the stillbirth, because they form a major chunk for the major cause for stillbirth still remains the birth defects. So the stillbirth prevalence data was also collected, and to know the patterns and the trends we are dealing with. And the remaining things remain the same, which I discussed now. Along with that, we learned a very good thing about the very important thing along the journey, which we learned to have a good quality control data. So how to have that quality check? So that quality check is really important to know, to ensure. So for that, actually, there is a quality check. One is a hospital which upload the data. It goes to the regional center or the nodal center, and then it goes to the national collaborating center. So there are quality checks. The data is being seen by the first person, uploaded by a data entry operator. Then online, when it goes to the regional center, he can see it through the database, and he checks along with the photograph is uploaded. He checks for the description and the coding of the birth defect. If the form is the description and the coding does not match, or there is sometimes the syndromes are missed, then that form can be rejected and sent back from the regional center itself to the hospital site with the comments. There is a column for the comment that what is the fallacy and how it can be improved. The coding is deficient or the description is deficient, so those details are given. And even if they pass it, verify it, it again goes to the national collaborating center, and then they do again a verifier check, and so there is a double check at the nodal center, regional center, and at the national center, so that this quality check actually improves a lot of rejection and gives a good quality data. So for the all hospitals at national level, what is basically the hospital design? That it would be longitudinal or prevalence study for birth defects, stillbirths, as well as the congenital infections were taken care. During that study, Zika virus came. So the association of Zika virus with the microcephaly, that needs to be reported to the ministerial side. So that association was taken care of, and even the other congenital syndromes like congenital rubella syndrome, they all present with different birth defects. So all three things needs to be taken together: birth defects, stillbirths, and congenital infection in a hospital-based surveillance. And even the stillbirths more than 22 weeks of gestation, or at least 500 grams. So that was the inclusion criteria, and the clinical screening for major birth defects. So now from external birth defects, we came to the major birth defects, because now with time we got wiser, and we are able to detect the major birth defects, which affect the mortality and the morbidity of the baby, like the critical congenital heart disease, tracheal fistula, CDX. So we included all those also, and this thing was kept as they were followed till birth or till at discharge or before discharge at discharge or before discharge from the hospital, or the final outcome. So till now the follow-up is still discharge, but hopefully with time passes, if we have a good follow-up facilities, we might be able to extend it till more time. And along with that, we propose to study of risk factors of birth defects in stillbirth as well as the biological and cytogenetic studies. So these studies are being carried out in selected cases depending on the facilities available and at the national centers. During this 5 years period, along with that, we did a small study to see how the pattern was changing of the birth defects and as well as what is the risk factor association. So we took the control of the risk factors, we studied the risk factors for 1 year. So we took 2 groups. One was a study group where the babies were born with structural birth defects and a control group were taken as 2 live healthy babies which were born immediately after the study case. And all cases were followed till discharge and death. And the details of the baby were put on a pre-designed performer, which we designed for the risk factors, and the baby clinical examination was done at birth. All the risk factors which we took, the maternal, neonatal, and the demographic, they were analyzed using the SS strata, and the chi-square test was applied and after the logistic regression. Basically, primary outcome we kept was the risk factor associated with the occurrence of birth defects. So during that study period, the overall prevalence for the external birth defects come out to be around 1.07%. And the spectrum came out to be where the congenital heart disease predominated with around 18%, followed by the neural tube defects. Here I want to emphasize on the changing pattern of the birth defects which we saw. When we started the registry in 2015, for almost 2.5 years, predominantly we were dealing with the neural tube defects. But gradually as we moved towards the our surveillance, we saw there was a gradually increasing pattern in the congenital heart disease. The critical congenital heart disease, they kept on increasing, and there was a declining pattern in the neural tube defects if we compare the two. We also analyzed the different risk factors for the maternal, and here it was seen in the risk factors that birth defects were more associated in a singleton baby, and where there is a history of previous birth defects, which we already know. And they were also seen in the spontaneous conception. Though no reason could be found, but probably one reason could be that probably IVF pregnancies are more monitored more cautiously with a proper antenatal care, so they might be terminated if found in birth defects. On multivariate analysis, we found that mothers having poor antenatal care was associated more with mothers with poor antenatal care. Babies with birth defects are more prone to be growth retarded and born prematurely. As well as there was an association with maternal hypothyroidism, maternal fever, and the maternal smoking, both active and passive. So with this primary outcome, we had concluded that there is a changing spectrum of birth defects. We see from the daily newborn birth defect registry with congenital heart disease predominating over the neural tube defects over the years. We could not prove this, but we thought that the probable reason could be that over the years we had the screening of the critical congenital heart disease, and people have become more aware. So now at the delivery room level only, they are able to put a pulse ox and they are screening for the birth defects, critical congenital heart disease, and they are sending more for echo facility. As well as in our hospital, like there were more echo facilities, and in the other hospitals also. So we thought of one possibility that. And secondly, with the more awareness and government programs coming of the folic acid fortification, even many of the districts doing that. So probably increased awareness and periconceptual folic acid would have contributed to the changing spectrum. So identification of important risk factor which we actually identified, as I said, is the poor antenatal care, maternal hypothyroidism, maternal fever, especially in the first trimester, and smoking during pregnancy were found to be actually very significant, even on the multivariate analysis. So, which I described, the work plan we actually kept for the national perinatal database after these risk factors is actually, we want to establish the hospital-based neonatal perinatal database across the country. That is the way forward to scale up this registry across the country to have a uniformity. Secondly, to include the surveillance of Zika virus congenital rubella syndrome, and other intrauterine infections. So that should be made a part of this so that we are able to capture more and more pregnancies early and to promote the genetic diagnosis and research on these risk factors. So to involve all this, we have to have a collaborators have to be there. So like ICMR, WHO, ministry, so they are all involved in this so that we can achieve these targets. And ultimately, we can have a national and regional coordination to achieve our targets. So for this we have a 76. There is a proposal. There are ICMR site 76 government medical colleges are there across India. So there is already they are reporting weekly on the birth defects. So there are all the HOD, there are obs and gynae people and the pediatrics is involved. And we have the field unit of the NIRRH ICMR at Mumbai, which is also a national collaborating center for this. And it is proposed to have 6 medical colleges as regional collaborating center. So this is a design which we propose at National Resource Center, and this proposal has been sent to the ministry with the regional collaborating centers, and these will be attached to the 7 to 8 district hospital at each state. These are the tools we developed during our ministry, the facilitators guide and the initiation of the birth defect surveillance and the standard operating procedures for the initiation of the birth defect surveillance at medical college. And now we are in the process of creating this training package for further training. Thank you.
Thank you, Dr. Shobna, for highlighting the importance of the counting the stillbirth and also the birth defects among the stillbirth as well as the newborns. And I think this was a pilot experience where the government as well as private institutions participated, and then now they are scaling it up to the national levels and then integrating, of course, with the RBSK program. I'm sure there will be questions and concerns. So we have 3 to 4 minutes since you have finished much time. So if there are any questions from the house, she'll be too happy to answer. Okay. Thank you, Dr. Shubha. Thank you.
Dr. Shobna and Dr. Jalani. After this, we have another session on neonatology only, cooling of babies, where we stand today. And the speaker is ever enthusiastic and dynamic, Dr. Avneet Kaur. To chair the session, I invite Dr. Ravinder Sihar. He is the director, Sihar, Newborn and Children's Hospital, Sirsa. Dr. Sihar, please. His special interest is in pediatric pulmonology, neonatology, and infectious disease. Over to you, Chairman.
Topic is cooling of babies. And speaker, I invite Dr. Avneet Kaur. Cooling of baby, where do we stand today? We will be talking about therapeutic hyperthermia, what are inclusion and exclusion criteria, monitoring of the baby, and some latest some controversy regarding cooling in low and middle income group countries. He consultant neonatologist and in charge of Apollo Hospital, Moti, Delhi. India contest in neonatal.
Good morning, everybody. I'm really thankful to the PCNI organizers for inviting me for this neonatology session. I really thank Dr. Pankaj for inviting me for giving me this topic. And as you know, the topic today is going to be the cooling of babies. Where do we stand today? This topic has suddenly come into a hot discussion, and we all have been cooling, but this topic is suddenly raised because of our latest trial which has come into the picture, which we'll be discussing in detail. So, we all know that the burden of asphyxia, as per the last NNPD database, that is 14 per 1,000 live births, which is almost accounting to almost 3,64,000 babies per year. That is the burden overall of India of the asphyxiated babies. This amounts to almost 28 to 30% of the neonatal deaths. So it's a huge burden which we hold on our shoulders. So the burden of asphyxia is just not related to its mortality, but it has long-term implications. It leads to high rate of cerebral palsies, which we have seen in the studies which are prior to the hypothermia. There is severe, moderate to severe neonatal encephalopathy, which leads to decrease in IQ at even 2 to 6 years of age. This poor school performance resulting in problems in reading, spelling, maths, the autistic spectrum disorders, and also the Finnish cohort also showed us that it is also related to late onset schizophrenia. We have seen that the only evidence of the therapy which has shown us to be promising is hypothermia. The therapeutic hypothermia was extensively studied in animal models before it came into the book, and it was found to be very promising. So unfortunately, till now, it is the only therapy which has shown some promise in neonatal asphyxia. There were various trials which were done from year 2000 to 2010 across the world. After the animal experiments, there were trials which were done in US, Canada, UK, Europe, Australia. So all these trials, if we show the meta-analysis of these trials, really suggested that hypothermia is definitely a proven therapy. This is a meta-analysis of 11 trials involving 1,500 good odd babies, and it showed that the therapeutic hypothermia definitely reduces the risk of death and major disability, and it also reduces the neurodisability at 18 months of age. But does this translate into the later better outcomes? Yes. So there were the follow-up trials of the same trials, follow-up data was collected, and it was shown in the TOBI trial that there was a good reduction, like improvement in the IQ more than 85 in babies, 1.2 times than the babies who did not undergo hypothermia. And there was a 15% reduction in cerebral palsy in babies who had moderate to severe disability. So the similar thing was discussed in the NICHD data, which showed that the death and severe disability was reduced, and it was significantly reduced from almost 53 to in the other group to 41% in the hypothermic group. So we know that it is a promising therapy, and it is being followed across the world. It shows a good long-term data as well. So how do we implement that in Indian scenarios? So that's where the journey of hypothermia started in India. In 2007, when Dr. Niranjan Thomas, who was in Canada, when he came back, he was a participant of the ICE trial. When he came back to India, he thought, let's use this trial in India and see if that is feasible in our Indian scenarios. So this was the first feasibility trial which was done by Niranjan Thomas, that is the CMC Vellore group. And they did the whole body cooling in perinatal asphyxia in the low resource setting using the cool ice gel packs. And they found from 2007 to 2009, they recruited almost 20 odd babies, and they found that they could cool the babies with the desired temperature and reaching the temperature in the desired time without much of fluctuations. And this data was presented in 2009 in Indian Pediatrics. Though the equipment which we were using, they were cool ice gel packs. So does these low-cost devices, did they have any concern? Yes, they did. There was intensive nursing care which was required because they could lead to sudden fluctuations in the temperatures. There was increased shivering which was reported, and they could not be precisely controlled of temperatures. So in view of these, using the same cool ice gel pack, the Gipna cohort, they did their first randomized control trial, and they recruited almost 65 babies in both the groups, and they showed that there was a reduction in the death and developmental delay at 6 months of age in the hypothermia group. So we showed that in low-income countries, we were able to, or it was like possible to do cooling, but the cooling, the way we were cooling, were using the ice gel pack. So after the ice gel pack usage, we thought that since there are some issues with the ice gel pack, the Niranjan Thoman group tried that is there other ways where in the low socioeconomic status countries, how we can utilize other ways to do cooling. So that's when they devised something which is called as phase-changing mattress. Phase-changing mattress are basically, they have specific melting points, and they can either absorb or they can emit heat and come down to a natural servo control mechanism and maintain the temperature on the desired values. So they devised this phase controlling thing, they tried in their babies, and then this whole thing went on from 2011 to 2013, where finally they were able to devise this two-phase changing mattress with a different melting point, and a device called Mira Cradle was prepared, and this was being used by the CMC Vellore team for cooling the babies. This found to be like more feasible and more like better than the cool gel packs in the Indian studies which were used before. During that time, the servo control machines like Techotherms or all were available, but however, they were very, very expensive. So none of our Indian studies were ready to use those equipments. So after the cool gel packs and the use of this Mira Cradles as a phase-changing mattress, there were a couple of studies which you can see that CMC Vellore was almost able to produce 137 babies. The Gipna did baby-like trial on 320 babies. The Sri Ramakrishna Medical College did 73 babies. So almost a lot of centers started cooling. But in 2015, there was a commentary which was passed by NICHD workshop, which showed that there are some concerns about the use of hypothermia in low resource setting. Rather than using it as a standard of care, we should consider about these shortcomings of hypothermia in our low resource settings. The reasons were that we had a limited window of hypothermia within which we have to cool the babies, that is 6 hours. But however, our babies have like trauma or the asphyxia, which is ongoing even in the intrapartum period. So is it that we are missing that 6-hour golden period? Second, our babies had more chances of acquiring infection, and hypothermia in infection can be deleterious. We have more chances of MAS leading to perinatal asphyxias. So these babies are notorious to get into multi-organ dysfunctions, PPHN. So is our system ready to handle these kinds of high intensive care babies and do cooling and manage them with multi-organ dysfunction? The cooling devices which had servo control mechanisms were expensive. So they said that we need more careful randomized control trials to prove the safety and efficacy of cooling. And the most important thing before cooling was a better access to the obstetric and the newborn care before the cooling could be started. So this was very well accepted by our forums, and we did give a reply to the NICHD that yes, these things are important. However, there are a couple of trials which are the feasibility and the safety trials which were done. So it should not be this that we cannot use cooling in our kind of scenarios. So in order to answer these questions and answer these things, we raise some question. Is cooling feasible in our setup? Are our facilities or settings ambient enough for doing cooling? Is it safe? That should we cool these babies or not? And who should be cool? Are there any differences from the Western world in the selection of our patient population? How should we cool? Are there alternate ways of cooling these babies in low resource income settings? Should cooling be a standard of care in India? And should its efficacy be proved in India? And can cooling be done in the secondary settings? And are there alternate strategies for those who commonly are outbounds, who come late to our setups, that is beyond 6 hours? So these are the questions which we want to answer in this presentation. So let's first take the feasibility of cooling in Indian scenarios. So there were a lot of studies, that is by Chipmet, by CMC, Vellore, and Sriramachandra, which showed that, as you can see in NICHD trial, the temperature, the level of temperature which we want to reach was 33.5. So how the trials like the NICHD, the TOBI trial, the ICE trial, they were able to reach that therapeutic temperature in a therapeutic window. So did we reach? Yes, our studies were able to show that the phase changing mattress, the temperature which we reached was 33.4 with a standard deviation of 0.28. We want to keep it closer to 0.2 to 0.35, not more than that. So if we were able to achieve that. What was the time to reach the desired temperature? When we used the cool chill pack, we were able to reach in 90 minutes. The Chipmet study showed it took almost 2 hours. When we started our trials with phase-changing mattress, we were able to reach it in 45 minutes. And the temperature outside the target with cool gel pack was 9.8 as compared to the phase-changing mattress was 3.8 as per the CMC Vellore study. So this was a multi-centric study which was done in 10 centers in India, which showed that, as you can see, that the age of cooling, initiation of cooling, the temperatures desirable which we could reach, and the readings outside the target values were all as per the Western data. So we say that yes, it is feasible, and as you can see, all these centers were able to recruit almost more than, as you can see, 654 babies, where we proved yes, the cooling trial is feasible in our kind of setup, and we can reach that temperature without much of deviations. So is it safe? So in order to prove the safety, we need to see what were the adverse effects. So if we see the adverse effects of various trials like NICHD, TOBI, cool gel packs with the Chipmet and the phase-changing mattress, as you can see, the chances of sepsis is almost comparable in all these trials, and the only parameter which was different in our trial was the coagulation parameters. Somehow we found that the coagulation parameters which was assessed with the CMC Vellore trials was slightly much higher than the other baseline trials, which probably they said that since they lost 2 babies initially because of the lot of bleeding, so they started doing coagulation profile in all babies even before starting cooling, and that is why somehow their coagulation profiles are much deranged, or much pickup rate of deranged coagulation profile is much higher. So now we have seen that it is feasible, it is safe. Now what about the devices which we are using? So there was a meta-analysis of low-cortex methods which were used, and which showed that out of these 3 trials recruited 467 babies, there was reduction in neurological morbidity at discharge by almost 54%, and there was a reduction in mortality or severe morbidity at 24 months by almost 23%. So that's what we want to say, that even the alternate mechanisms of cooling which we are using in our kind of setups is fair enough to lead to results. Now, where should we cool the babies? So we definitely want to convey that these cooling should not be done in smaller setups. We should do these coolings if we have the right setup, that is the level 3 NICUs, because these are the babies who will require intensive care. They will require ventilation, they will require to go on to high frequency ventilation, they may require centralized access, inotropes, and they require continuous monitoring of the vitals with involvement of the blood products and excessive monitoring by the nursing team. So is it that amplitude EEG and MRI is warranted? If possible, yes, but it is not something which is mandatory. Now, who should be cool? Is it that our case population needs to be different from what the Western world has done? So there are some criteria which were laid down in the clinical trials which were done in our part of the world, where they suggested that we should try to keep them limited to babies who are more than 35 weeks of gestation, more than 1.8 kilos of weight, and we should try to do it within 6 hours. So if we met the mandatory criteria, we should do these babies. The physiological criteria, we try to make some changes in the physiological criteria entry for the babies who should be cool. The inborn babies can fulfill the criteria which is laid down by the Western trials, that is the Apgar scores, that is the ABG criteria, that is the base deficit, and requiring the need of bagging for more than 10 minutes. We changed some things in the outbound criteria because we may not have the Apgar scores or we may not have the blood gas parameters. So if there was a history of not cried at birth, or if the baby was not breathing for more than 5 minutes of age or required assistance in the form of bagging, or the baby was limp or flaccid. So these were the subtle changes which were made in that entry criteria so that we do not recruit those babies with mild encephalopathy and we take the babies who have moderate to severe encephalopathy. And the third important criteria was the neurological criteria. So we should, as I suggested, it was like the moderate or severe encephalopathies with seizures if we have. So they were the same as which were taken with the TOBI or the NICHD criteria. So we need to have the mandatory criteria, the physiological criteria, and the neurological criteria. All three should be fulfilled, and we can make some changes as per the inborn versus outborn scenarios. We should not cool the babies who are less than 35 weeks, less than 1800 grams, more than 6 hours, or having major congenital anomalies, or having multi-organ dysfunctions with PPHN requiring ECMO or high-frequency ventilators, and extreme preterm babies. Should we cool these babies in secondary settings? The meta-analysis by Prakash Shah showed that these babies are notorious to have a lot of multi-organ dysfunctions and adverse effects in form of arrhythmias, thrombocytopenias, coagulopathies, and pulmonary hypertension. So yes, no, we should not cool them in secondary settings. Now, the cooling beyond the standards which we have shown in them, that is the role of cooling in like deeper cooling. So should we go for 32 degrees? Should we go for cooling which is beyond 72 hours? Should we go for any passive coolings or cooling which is between 6 to 24 hours? The trials have not proved that these kind of cooling mechanisms should be adopted or should be done because they were not efficacious. So now coming to the efficacy of the clinical trials, whatever we have seen in these previous trials, what did they actually lead to the outcomes? So the major clinical trial was by the JIPMER group, which they did like 2 trials. One was done in 2000, presented in 2012, and then now latest one in 2020. And as you can see, that the normal survivors were 1.454 times chances as at 18 months of follow-up, and in the previous study it showed that it was 1.357% chances of normal survivors in babies who received hypothermia. And another major trial which is being published by the Niranjan group or the CMC Vellore group, which is called the THIN study. And this study used basically the MRI parameters, and as you can see, the plic, the thalamus features and the lentiform nucleus features which were shown with the hypothermia, which were much better in the hypothermic group as compared to the non-hypothermic group. And the secondary outcomes, as you can see, that the death and disability reduced, and on conventional MRI, the changes, the moderate to severe abnormalities also showed a significant reduction in the group which received hypothermia. The patterns of MRI changes which were seen in this study was mainly involved, were both comparable between the pooled and non-pooled group, and they were better normal MRIs as compared to the pooled group. So this RCT showed that the pattern of MRI suggested acute injury. That sentinel events were more as compared, which was similar to ones which were shown by the high-income countries, and less injury happened on the conventional or fractional anisotropy MRI, and decreased composite outcome of death and disability at 18 months of age. Now, this is the meta-analysis of, or the pooled data of all the trials of the low and middle income countries which have been put forward by Sita Shankaran group in an article, which they have shown that there was a reduction of almost 34% in the neuromorbidity and combined mortality outcome in the hypothermia group. So these are all studies from our countries and low socioeconomic countries which prove the safety, the efficacy of hypothermia. And now came the twist in the whole marathon which we ran from 2007 till 2017. Then now the Helix trial, which was just have 4 slides more to go. So the Helix trial, which was the robust RCT, which was planned for hypothermia in moderate to severe encephalopathy in low and middle income countries, which involved 5 centers, the public hospitals in India, 1 from Bangladesh and 1 from Sri Lanka. So Tayal et al. Had a research question that is the role of therapeutic hypothermia in reducing the moderate or severe disability after neonatal encephalopathy used in Southeast Asia. So the study population was as like we have used in the previous studies, and what it showed that though the baseline characteristics were same, but a lot of babies had clinical seizures at the random assignment at the onset. And what they found was that death or moderate severe disability was comparable in both the groups. However, in their secondary outcomes, they saw that the death up to 18 months were higher in the pooling group. The death before the hospital discharge was higher in the pooled group, and the hospital stay was higher in the pooled group, and also some other secondary parameters like coagulopathies, like thrombocytopenia, the gastric beads were more in the pooling group. So where do we stand now? So they came up with the conclusion that therapeutic hypothermia should not be offered as treatment for neonatal encephalopathy in low middle income countries, even when the tertiary neonatal intensive care facilities are available. The pros of this study was it was multi-center randomized trial. It was a well-balanced trial with like baseline characteristics, minimal protocol deviation and loss to follow-up. In fact, in the COVID time also they ensured that the follow-ups are done at the homes of those babies. They went to the rooftops to follow up these babies also. They had masked outcome assessors and they used MRI parameters as well. However, there were downside of this study. The population which they used were mainly the population, 70% of their population was outborn babies. So maybe that these outborn babies, when they reached to our setup, they were already undergone an asphyxia, and the intrapartum care which was given at those centers and the transport were probably they had already gone into secondary energy failure, where after which we know that there has to be a failure of neuroprotection. So also they said that the babies who came had more SG, like the SGA babies, which probably lost the window of the therapeutic use. They gave the outcomes which were unadjusted for the centers, and so the data does not have generalizability. And they gave these specific reasons for the loss of the efficacy of hypothermia in our kind of population. So my questions again come that is the hypothermia safe in our country? The pooled analysis of the data before Helix trial has clearly shown that there is good efficacy of this. However, one large RCT has questioned this, but this large RCT is primarily in the public care setups. So is it that like the private NICUs which have like or the tertiary care setups, which have better equipments, better sources of handling, or better provision of the supportive care for these babies. Is it that we should stop cooling based on one RCP? I would say no, because we have previous data, if the cooling has to be done, it should be done in the right environment, it should be with that right population, more better with the inborn babies, and we should try to continue and come up with more robust data. Is it feasible to start and maintain cooling within the right therapeutic range window period? Yes, in inborns, still an issue with the outborns. Do we change our protocols? Yes, the inclusion criteria for inborns and outborns can be different. Cooling in resource poor settings, the alternate methods which have been shown to be efficacious in the trials. And is cooling can be a standard of care? Needs more randomized control trials? Can cooling be done in secondary settings? No. We need good nursing, ventilation, blood products, intensive monitors, better equipments. So, to summarize, I have always heard Durari sir's talk, and sir has always said, for anything to be successful or anything to have good quality, we need to have good infrastructure and we need to have good policy and protocols. So, without good policy, good infrastructure, nothing is possible. We need good antenatal and obstetric cares. We need better neonatal resuscitation trainings. We need better transport systems. We need improved quality and supportive care in our NICUs, better training of our nurses, improved devices for monitoring, our indigenous devices. Good follow-up program is the key for the success of any of our trials. So we need more robust RCPs, we need national registries, we need NNF-driven protocols at regional centers if we want to use hypothermia as our therapy and we want to show some success and not be compared as a low middle income countries. We also know in past that antenatal corticosteroid trial, the ACT trial, showed that there was increased mortality, but there were some flaws. So we haven't stopped using antenatal steroids, and we all know that antenatal steroids have turned the whole RDS theory for us. So that's what I want to convey out of my study. Thank you.
Thanks, ma'am, for nicely covering both the studies involving therapeutic hypothermia and latest controversy involving this topic. And you nicely explained all these things. However, if there is any question from audience.
Just want to say that we have established cooling in our NICUs for last I think 7-8 years, and whatever follow-up we have at our center, the mortality in this group is 45-47%. So we have not lost any baby. We have only around 20 babies up till now in last 6-7 years. The enrollment here in outbound babies are also 2 hours. Inborn was only 1 hour. So I don't know, there must be some issues at the time of enrollment also. Most of babies, even if they are outbound, inborn is 1 hour is fine. Outbound, we enroll them at 4 to 5 hours, cooling starting in the way. So there are a lot of things which don't match, but what we are doing. These are of 75% at the time of enrollment, mortality of 45%. All these things, baseline characteristics don't match with what we are doing cooling in our babies. So we think we should continue cooling, and definitely there is definitely no harm in collecting data. With Dr. Dinesh Chilla has data of more than 100 babies who have been cooled. So let us all collect data and keep on doing it, and then let us see.
Thank you, Dr. Pankaj, for your comments. Devani sir. Thank you.
Actually, I run a small center where I have 8-bedded NICU. Can you hear me? So I have tried cooling for about 10 babies. But unfortunately, to be very honest, and I have all those parameters that you told, except I don't have an EEG or I don't have an MRI. Other things I am able to, and I did it myself. But unfortunately, none of them, outcomes were not really good. So I am not very pleased to, I don't know,
Yeah, I think we should not take a setback with small data collection. I think
Yeah,
we
it is a very
need more
small data.
robust, and we need to first prove it in the tertiary care settings and then look for a generalizability in the other setups.
My dilemma is to do it in 11 maybe or no. That is the confidence boost.
Thank you, Dr. Amin, for trying to take the heat off of the very hot and controversial topic of the reverse name cooling of babies. It was really very informative analysis. And next session is on preterm package. And for this, I invite Dr. Ashok Devdani. He is the professor and head of Department of Pediatrics at AIMS, and he is also the head of WHO Collaborating Center for Training in Newborn Research here at AIMS New Delhi, and he has been the visiting professor of multiple universities, resident NNF 2020, and received multiple awards. And he has been also involved in capacity building and training in COVID care by Government of India. So further,
thank you. So thank you so much for letting us connect to a lot of pediatricians who would be logged in virtually, and many of you who are sitting in this room. First of all, I'm thankful to the organizing committee for giving us the opportunity of sharing something which is going to be of immense value for most of you who run nursing homes and small hospitals. And I would say, even if you are running a tertiary care unit, the things which are going to be shared with you are going to be huge importance, and they will have a huge big impact in improving care of our preterm babies. You know, most of us may be doing more harm to preterm babies by not following the best effective practices. And it is on us as a senior pediatrician or a neonatologist to train our team. Train our team of nurses, resident doctors, medical officers, or anyone who is involved in the care of those preterm babies. It may be the family. May I request people who have to talk, please get out from the room. Sarji, namaste. थोड़ा बाहर चले जाएंगे तो अच्छा रहेगा गप्पे लगाने के लिए. अच्छा, आलोक भंडारी सर हैं. अरे यार, तुम बाहर चले जाओ तो अच्छा रहेगा. हाथ जोड़ रहे हैं तुम्हें. भैया, लोग टाइम खराब करके आते हैं, अपना वेस्ट करके आते हैं यहाँ पे. So what I was saying was, even for tertiary care unit, your nurses need to know all this. The families need to know all this, because these are best practices which each one of us can implement in our life. So it all relates to creation of a team. Team is with your people, and creation of a system. System is by having SOPs, protocols, so that babies are not getting infected. Babies get mother's milk. Babies don't get extra oxygen, because these have impact on those premature babies. And I can tell you with my experience going across the country and Southeast Asia region, majority of the babies who enter many of the tertiary care unit, they are first harmed by providing bad practices. And then they get admitted to a tertiary care hospital. And then the doctors manage those babies. So let's see and learn from what we have developed in the last 6-7 years, a package which is meant for preterm baby care best practices. And I would urge all of you, this knowledge has to be implemented. Implementation is in your hand, not in my hand, not in people who are going to teach you that. because you need to teach people the skills which are going to be required for implementation of this. Knowledge exists in this world right and left, but the challenge is implementation. Implementation is by the team, which includes the family, the mother, the parents, the nurses, your sanitation staff, your resident doctors and medical officers. So I am so happy that with this philosophy, this package is created, and how we have disseminated this in the country is going to be shared by no one else but the people who created and shared with large number of people. So may I request Dr. Annu to make presentation first for maybe 22 minutes, and then Dr. Pratima for another 10 minutes, 12 minutes, and then we can do questions. Over to you, Annu.
A very good morning to all of you, and thank you, sir. It is my privilege here to stand before all of you, and actually, on behalf of good morning, everyone. So it's my privilege to stand before all of you and to stand on behalf of the team of preterm care package developers. And I'll actually take you through the journey of last 6 years. What did the team actually envision? So how did they implement it? How did we all disseminate it? And where do we stand today? So this was the year 2015 when our team actually planned as a part of a quality improvement program to improve the healthy survival. And I would stress on the word the healthy survival in double quotes of the preterm neonates without severe retinopathy of prematurity. Now herein, severe retinopathy of prematurity is a surrogate marker of the quality of care that you and I provide to our preterm neonates in our neonatal intensive care unit. The objectives that I run through today are: how did we create this package? What are the domains? They are simple domains which you and I would actually, in our daily care for the neonates, may try to. This is the share thing. Yes, sorry for the delay. So the teaching methodology was different from the other normal rote learning that you do. After that, there was the development of an online platform that is a self-certificate generating platform. Doesn't require a mentor. Followed by that, there is skill testing and simulation exercise that you actually run as a team. We disseminated the package. We have feedback to share with you from the users. We developed an app, and finally we'll talk about field experience, hands-on experience, what happened in the state of Madhya Pradesh and in Shivamogga. This slide is not to overburden you, but just to take you through the steps. So going and just developing a book is something different. This package had these defined 5 steps, which you can all see. The first one was formative assessment. Go to the users, go to the doctors, go to the nurses, ask them what do they want. Understand and do data analysis. That means transcribe their suggestions to a coding, to an analysis. Followed by that was a stakeholders meeting, 35 of us meeting and designing the content of the workshop. The content that has to be there in the preterm care package, and what are the requirements of that content. So this was year 2016 formative research, and again about 2 to 3 months later we analyzed that. We actually went into step by step, how should the information flow be, and where should the learning corner in the special newborn care unit be. The participants there, the nurse and the doctor said, we get 10 pages of PDF on the mobile phone. We're not used to reading 10 pages. Even for people like us, 1 page and we are done. So short attention span, we need short videos, we need short text material, not more than 1 pager. We need some areas which we lack in. So what are the areas that they lack in? They actually came up with those areas. Sepsis prevention, unnecessary antibiotic administration. Doctors wanted a hands-on experience on surfactant administration. Nurses wanted the ability to not to ask doctors for initiating CPAP, monitoring saturations, availability of pulse oximeter, more about feeding, less about IV and ROP screening. So domains were well defined. So this is something which you would have heard, and it's called the SWOT analysis. So when we went back, and this is just one of the domains, we actually ended up making the package on 10 major domains. So what does this SWOT mean? The first thing is strength. The nurses and the doctors knew that oxygen is a risk. So that was our positive point. Yes, they knew that the oxygen is a risk factor. They did use pulse oximetry readings. However, they were not aware of the optimal range. The nurses were not aware about the optimal range. They were not setting alarm limits. Some set low alarm limits as appropriate. The others were setting high alarm limits as appropriate. So what were the opportunities we had? They were all willing to learn. There was an existing software in the Madhya Pradesh system, but they actually, because of their busy schedule, they ended up putting mute on the pulse oximeter, and there was shortage of pulse oximeter in the Edison's use. So the reason that I put up this domain is there were similar 9 domains on less antibiotic usage, on talking about feeding, on talking about less IV fluids, and they were all done through the SWOT analysis. So we actually had to ask them, what are your strengths, what are the weaknesses, where do we have to build in the package, what are the gaps that we have to address. The final circle on the right hand side that you see was our content development workshop, and there were 10 teams for 10 domains. You see a few members sitting all around, and we had to make 10 modules. It was not an easy task. It took us almost a year to complete this task. In addition to that, we needed an assessment methodology in place. You cannot give out the material without having assessed what actually the person has gained at the front end. So these were the deliverables. So each module, and there were 10 modules, I repeat again, had a set of webinars, had a set of videos, had short reading material with key messages. The user had to undergo the multiple choice question after that. And then we had the skill stations, the simulation exercises, discussion on the job aids and the role plays. This is the physical format of the learners and the facilitators guide. Learner's guide for the learners and facilitator guide for you and me being trained as facilitators. How do we go and teach our learners in the unit? So facilitator guide of course for the facilitators, and learner's guide for the learners that they're going to teach. These are the 10 domains that I was referring to. 2 parts of the guide, part 1 and part 2. All the talking that I was doing till now, Kangaroo mother care, optimal oxygen, thermoregulation, less blood products, less antibiotics, optimal management of sepsis, delivery room care, it's all there. So best practices for preterm care, and you see the topic right here in front of you. How are we different? There is so much of material which exists left, right, and center. So this is different because this is participatory learning methodology. And when I say this, I mean that it is competency-based learning as well. So you and I sit together, we share our ideas, we share our experiences in a small group, and we would teach this package, or the participants would learn this package as doctors and nurses do. Small group reading, seeing the webinar, seeing the videos, seeing the role plays, participating in the role play, doing the multiple choice question, and finally hands-on skill stations right the next day, and participating in simulation exercises as a team, thus reiterating and emphasizing the same understanding again. So a lot of material was created. Just to name a few, we had 65 webinars and about 130 plus short videos. This is a structured OSCE. So after having done and read the material on a particular topic, you would go to your facilitator. The facilitator would tick mark you on the points which have been correctly done. This is not to penalize you. The answer is that once you're not doing the steps correctly, immediate feedback is given that these are the 4 steps that have been missed. So I then go back to my unit. I remember that these are the things which are important when I have to do it for a newborn. Simulation is something different. It is the buzzword these days. So it was a part and parcel of the preterm care package wherein the doctors and nurses participated as team and managed a given case scenario right at the time of the workshop. The focus was always on self-learning, and that is why this self-learning website was also created simultaneously that the package was created. For majority of you have actually gone through this, have been our participants in the different workshops that we did. For the others, it's www.pretermcare-eliminatingrop.com. Does not require any money investment, it just requires your quality time, and you have an automatic certificate generation. This is a basic infrastructure of the website. You can see all the logs right there. They'll open once you keep on maneuvering through the modules, and you have to attain a pass mark. So 4 workshops in Madhya Pradesh, 6 in Delhi, in Odisha, Chhattisgarh and Telangana. So we actually delivered it as a part and parcel of first day quality improvement, formation of teams, and the second and the third day dedicated to preterm care best practices. The final day is skill learning and simulation for the teams. For the nodal center for medical college, the medical college would act as a hub, and the other spokes would be the different SNCUs attached to the medical college. So this has been the outreach till date in the last 4 years. Multiple colors, multiple hospitals. You can see the lead institutions right there. Last year was the COVID year, so we did have some online. We could not do the skill stations and the simulation, but this was something that we did over a period of 3 months under Sir's able leadership and National Neonatology Forum. We were able to disseminate the same practices though in an online mode, and the weekend there were virtual live sessions with the experts, which were complementary to the baseline package learning that these participants were undergoing. So this was the month of August, September and October. 20 hours dedicated to spending over the weekends for all the participants. We took feedback from the users of the platform that I mentioned. 90% of them felt that they were confident after undergoing a self-learning on being able to practice these best practices for their preterm infants. They had an improved learning experience. In addition to that, they felt that the content, the course materials, the modules and the learning objectives were very well defined. They were reasonably satisfied with the course delivery. Subsequent to that, as all of us would like to not sit on the laptop, we wanted an app. So these are the apps which are available. So on the Android, it's AIMS WHO-CC PTC stands for preterm care. And on iTunes for my iPhone users, it's preterm care. So again, AIMS WHO-CC PTC and preterm care respectively. So the same material, you can user-friendly, you can log in, create your own ID, and then remember your ID. So just to summarize, 2 field experiences, one state of Madhya Pradesh. So this is a picture of the formative results after the quality improvement work and the preterm care package. On the left-hand side, lower down, you see the special newborn care units in Dhar, Sipur, Vidisha, Ujjain, Chindwara, and Bhopal. And what are we doing? What we're trying to achieve is just do no harm. Don't try to harm the babies and then manage the complications. So you can see there was increased feeding in initiation. 3 SNCUs actually ventured on reducing antibiotics, which was Ujjain, Chindwara, and Bhopal. And you can see that there was significant drop in the antibiotic usage, and concomitantly there was no increase in mortality. So this is from the SNCU database. This was not collected by us. The green ones are areas where we actually did the preterm care package and the quality improvement intervention, and the other is the baseline data. You can actually see the difference with your own eyes. The next one was done by Benu, our DM student in his own medical college, Shimoga Institute of Medical Sciences, under Sir's able leadership. We just wanted to see whether it's actually feasible for the facility care workers to do this quality improvement and preterm care package best practices for their healthcare providers. So it was remote mentoring with some physical mentoring as well, hands-on, the year 2019 and 5 quality improvement projects. Breast milk intake, the first one on the left. Below that, increase in the enteral feeding intake, not only in breast milk, decrease in antibiotic duration, which you can actually see in the center. And then there is increased KMC duration, and you can see that there is decreased phototherapy usage as well. With that, just a slight glimpse of all our 35 faculty colleagues, and that's all from my side.
Thank you, Anu. You can come here for taking questions also. So I think here over in the last 15 minutes, she gave you a glimpse of what this package is, how this is created, whether it is making an impact or not. And you must have noticed there are few things which are very special to this package. Number one, it is self-reading, self-learning, small group, and then with demonstration and written demonstration for skill learning, and then evaluation by doing objective structured clinical examination. Even if you do that, those skills which the healthcare professionals will learn, you know, there is a law. There is a law which is shown that if the skills which you teach are not practiced, there is a forgetting curve. Whatever you teach, you don't take it to practice, 25% of that you will lose in 6 days, and in 1 month, 75% or 80% you will forget. And that is the reason, you know, teaching people newborn resuscitation also has to be done very, very frequently while they go and attend delivery room, because people forget even the skill of doing bag and mask ventilation for a baby who is going to be asphyxiated. So it is called as low dose and high frequency training for the skill which has to happen. And as Anu said, you have knowledge. Knowledge has to be translated into action. And that part can be done only by neonatologists, pediatricians who will train their nurses and healthcare professionals, by doing demonstration, written demonstration, assessment, and then doing hand-holding while they practice those things. See, a neonatologist, pediatrician can't disappear unless he or she is able to supervise what is happening by their nurses and the other people in the workplace. So that is very, very important. And second point, which is very critical to understand, is people have shown you attend workshop, you attend training, you attend lectures and webinars, you forget very, very quickly. But if you inbuilt into it quality improvement methodology and ask people to take it back to their unit, what are the things they learned, which they will not do, what are the new things they will like to implement with the team they will like to get implemented, then what happens is the gains are nearly 10 to 12 times more as compared to attending a training and a workshop, which is all alone for the people. And I'm so happy to share with you that Government of India has now embedded quality improvement methodology into the Lakshya program, which is meant for improving labor delivery room practices. And also into FBNC facility on care training, which will happen in a large way. Quality improvement methodology has to be taught to all healthcare professionals because it is not taught in the pre-service education for all doctors and nurses. Okay, so very, very important. So two messages. One is a forgetting curve. The second is embed all your trainings and workshops with quality improvement methodology, which has to be embedded into it. And third is the methodology by which it is taught. It is an adult learning principle. Small with demos, that is the way to go. Now with this, I would request now Pratima to come over. Pratima? Yes. To make a, so she will share with you another methodology by which she has disseminated this pre-term package to large number of healthcare professionals, took the feedback from them, and she published a paper on that. Over to you, Pratima. Pratima is a neonatologist at sorry, I forgot Safdarjung Hospital, and Dr. Anu Sachdeva is my colleague. She is Associate Professor, Department of Pediatrics, and she is working wholeheartedly in neonatology. Sorry, I forgot to introduce both of you. Over to you.
Thank you, sir. Thank you, Deroy, sir, for giving me the opportunity today, and thank you, the organizing team from Pcni. My wishes to everyone. Good morning. Good morning, Chilani, sir, my parent institute mentor. My association with preterm package actually begins right from its conception, I think, because I joined AIMS in 2015, and The idea was being concepted then only. Although actively I got involved in the trainings and skill building from 2017-18 when the package was released and inaugurated. We used to go across India to various centers, including Calcutta, Odisha, Bhopal, to actually implement these modules. But then COVID struck, and we were also struck. Then how to actually disseminate this module? This module we have ourselves tried and tested, and the videos are excellent, and they are basically based on basic concepts and on-floor skill building. It's very important as Sir and Ma'am has actually reinforced. So I'll just take you through when COVID struck, we actually thought it was Sir's idea. Now we cannot stop sharing the knowledge. As we know, the 3 steps of actually improving the quality include, first of all, knowledge acquisition. So how to basically disseminate the knowledge and then improve upon those by inviting going on 2019 and 2020 through Zoom and WebEx. We had WhatsApp as social media and then Telegram, which was an upcoming app. So what we did was, in 10 modules, we tried to to a wider geographical area across India. It was just an upcoming app. The objective of our team was to disseminate the standardized package to a larger group over a wide geographical area through an online interactive platform. So why Telegram? Unlike the other social media like WhatsApp, the Telegram has a sort of unlimited sharing capacity. We create a group of up to 2 lakh members on it. It has an option of inbuilt assessments and quizzes, and it also has options of sharing links to these assessments like Google Forms. So at one point of participants, the resources Dr. Anu has already elaborated upon. These were based on the Freedom package only, and it consists of webinars, pre-recorded webinars, PowerPoints, PDFs, job aids, standard operating procedures, treatment protocols, along with videos, short videos. So experience with Telegram has been in the form of 3 courses. It began on 26th October 2020, where we started the first course for nurses. We enrolled around 4,623 nurses from across India and also from Sierra region, Nepal, Bhutan, and UAE. And we could sustain, our concern and our apprehension was whether we will be able to sustain the attention of the participants to an asynchronous form of learning. It's a kind of chat only Telegram, and it will be, we thought that it will be an asynchronous part because participants had to go through the material at the self-paced manner, and they would be then asking questions on the chat only, similar to WhatsApp. And the faculty which was selected, I'll be showing it, around more than 70 national faculty used to answer the queries on chat only, and followed by immediately live sessions. So our concern was whether we will be able to sustain the participants' interaction at the end of 10 weeks. It was a long course of 10 weeks, but we could sustain 90% of the participants by the end of 10 weeks. The second course was conducted for doctors, which included the postgraduate students, fellows, medical officers from SSUs, and it was conducted from December to March 2021. We had 700 participants and again the same faculty members. The third course again for nurses has recently been completed on 19th September, and this time we had 3,234 participants and again 90% were reading. This was a strong team of faculty members from across India, and many of them are present here also, Dr. Page and others. And there were more than 17 national faculty who helped actually, who were the foundation for this, carrying out the interactive sessions with the participants. The third course, we actually added 2 more partnering organizations in the form of NNF was always supporting us, along with the AIMS WHOCC, which had the content, which was a content provider, Indian Association of Neonatal Nurses, IANN, and the Delhi Nursing Council. We could involve them as partnering organizations, and we also could get 50 credit hours for nurses for this particular course, for the third course. The registrations were done through Google Form, and more than 5,000 responses were there. We had a challenge to enroll all of them into Telegram, and approximately 80% we could enroll. because of the inaccessibility of the app to some of the participants. The structure was, the course structure was planned in such a way that each week one topic was covered. As Dr. Anu elaborated, there were 10 modules on 10 basic topics of the neonatal care, and it is a comprehensive module in itself, the 10 weeks course. The topics included thermoregulation, delivery stabilization, nutrition, prenatal mother care, and ended with the follow-up and ROP screening. So each week one topic was covered. At the we used to track the weekly discussions. You can see there were more than 100, 200 chats which were happening. Participants used to ask questions, and the faculty used to actually answer those questions on the chat. And these questions were not based on really very high evidence base, but they were basic clinical, practical chat discussions which were happening. How to actually regulate the flow of the oxygen, when to actually allow the baby to have bath, how to counsel the parents. The simple, basic, implementary questions, they were used to be answered by the faculty. These were again the chats and the discussions per week, and average was around 100. We also monitored, remote monitoring by the central team was done of the chats and of the participants who were participating in the Telegram chat. We also had weekly live sessions in all the 3 courses. So 10 live sessions per week, per course. There were 30 live sessions in total. And in the 3rd course, we actually added demonstrations, skill demonstrations through Zoom meetings and Cisco WebEx live interactive sessions. The good part which we noticed was the sisters and the nurses who were involved in the 1st course. They actually brought about their friends and they became the mentors for the 3rd course participants. So Ira, she is the nurse and she was a participant at the top scorer for the 1st course, and she became the mentor for her own unit and for her own colleagues in the 3rd course, and which used to actually demonstrate these skills. So we could see the change, a small change, but definitely there was a change in the practices in the units which actually participated in this module. We conducted assessments also, weekly assessments, and we tracked the scorings. 60% of them actually attempted all the assessments. Interim and final feedbacks were taken, and the course was modified as per the feedback received. Some of them felt the contents were a little more for 1 day, so we divided them into 3 days or so. Live sessions were also modified as per their feedback. What would be the way forward? It's a good app and a good mode to harness for dissemination of a standard package resource material. It may be any resource material, it's a preterm package. We can use this mode for dissemination of standard practices or standard package for any other education purpose. Uniform messages can be conveyed to a larger group of participants at a single time. However, the strong point to be noticed is it's a must to blend it with in-person skill building. The cohort which we have got, 3,000, 4,000 cohort, we need to now channelize those cohorts to basically build the skills in them with the regional champions and the local national faculty. We have to involve them and instill skill building into those. So I think this is a...
Thank you. Pratima, come over here. So I think what Pratima presented is use of a social media. How do you reach more and more with discussion forum, with the contents and a large number of enrollment which can be done. And I think the beauty in this is hard work by Pratima. It involved enrollment of people on a Google form. It involved planning, involving nearly 8 to 10 faculty members each week to participate in discussion forum, and each week arranging a virtual session in which there is a demonstration also. So it is a huge amount of organization which got involved. But the best part was she was able to create a lot of champions and leaders who were able to join as a facilitator next time, and we are very hopeful they will do a blended learning and skill learning in their centers for at least their nurses and medical officers who are working in their unit, and that will make a change and improve the care in the learning for the people. So it is not only knowledge but the skill part which has to be translated. And I think during last year in 2020, while the pandemic was there, we tied hands in February with NNF India, Indian Association of Newborn Nurses, and in February 2020, we came out with an app on mobile phone and then started rolling out the packages on Telegram, while NNF and Indian Association of Newborn Nursing also were partners to it. So with these words and these two presentations, because I have seen how they work so hard with a lot of people in the country who are tied down to improving practices of preterm babies, we are very sure in times to come, babies will be free of ROP, screening will happen up early, and the best practices will even prevent babies will not get infected, babies will get mother's milk, they will thrive well, they will have no hypothermia, they will have no morbidity, which will lead to that they need to be managed in a tertiary care unit. Because many of the things which you are able to do in golden 1 hour for preterm babies, if your setup has water, sanitation, hygiene, and good practices, and knowledgeable healthcare professionals, I think a lot of care for preterm babies, level 2 type of care can be provided. So I think we have 3-4 minutes. We can take questions from the floor. At least people who are present here in this hall B can ask questions. Or maybe Lallan or Vish, you will like to ask question to Pratima and Anu. Sir, Pankaj या अजय है या IAP दिल्ली IAP लीडरशिप प्लीज आपने बुलाया हमें हम आ गए तो आप बताइएगा क्या करना है
Pratima, we have 10 modules, right? Anu, we started with 10 modules. Are we venturing into more modules also? We have actually kept it to the good, essential newborn care and some care for FMC. CPAP तक तो हमने कुछ कर लिया था किसी तरह से.
So I think his question is, अभी तो आपने 10 ही बनाए हैं, अब आगे और क्या बनाना है? तो अब जब तुम बनोगे सेक्रेटरी NNF के तो हम आगे वाले भी बना देंगे. आपको वो टीम बनानी पड़ेगी, लोगों को इकट्ठा करना पड़ेगा, काम हो सकता है. It is possible. And to me, my take is the FBNC whole program should be converted into a digital platform so that all the nursing home doctors and nurses also can do it on their own, and the skill building part of that can be shortened only for 2 days or 3 days rather than 14 days.
Sir, with this, because we have just changed, IAB has changed the basic NRP and NSS module. After going digital and after just showing the videos, I've done 2 PODs right now, and we see a marked difference in the training pattern because that digital content and the reading and the testing already done by the computer and the digital media, and only the skills that are being transferred now. So that is making a good difference.
So I think once you create a content which is high quality digital content, which has effective practices, which is peer reviewed, it will capture majority of the things which you want to give to your participant or the learner. Otherwise, what happens is dependent totally on the teacher, what he or she will teach at that point of time while he is present there. Okay, and then you can inbuild skill learning to that package, which can be e-learning. Yeah, so I think COVID is something different for children and newborn and 7 thematic areas. The packages, e-content are getting created. That is totally different. It is a huge, big task, different, which will have blended learning. But I am telling about the FBNC training or NSSK training. So if you can create e-contents which are very high class and then inbuilt, these are the skills which have to be taught and to be demonstrated, given a feedback to the student, that can be a value addition. I think the greatest task in front of us is implementation. Implementation is changing behavior of individuals who are working. And you know, at this point of time, resident doctors and nurses who are younger generation, their behavior is totally different. They want everything to be done very, very quickly. No one wants to work hard. उनको चाहिए पकी पकाई खीर, जैसे कि उसमें आए तो सब कुछ हो जाए. मेहनत नहीं करना चाहते हैं लोग. इवन ई कंटेंट देखना नहीं चाहते हैं. सीधा ही MCQ करेंगे, सर्टिफिकेट निकालेंगे. पढ़ेगा नहीं पूरा स्टूडेंट आज के. So I think how do you change and impact that behavior of people is altogether different ball game. So for that, I think artificial intelligence is going to come very soon. It will track each learner कि उसने वो कंटेंट 80% देखा या नहीं देखा. अगर उसने वो देखा नहीं है तो वो MCQ भी नहीं कर पाएगा. So I think AI will come in a big way to sort this problem out for the younger generation.
So I just have one thing to make. There is no limit to the content that we can create. I mean, gather 35 people, it's a Herculean task. But please remember that 85 to 90% of the newborns keep these practices in place and they can be well managed. I mean, when it comes to cooling in babies, Dr. Abhi just told us, and we have the tertiary care facilities are there. This package does not cater to term babies with asphyxia, does not cater to ventilation. There are facilities for that, but then less than 5% of the newborns require that. What about the other basic practices? This was a demand-based package. The nurses and the doctors in the newborn care units, and they actually desired something like this. Don't the other packages exist? Yes, they do exist. Don't we have bundles of information, evidence, everything? Every next minute, everything is changing. New evidence is coming up. But 85% of the newborns don't require the new evidence. These practices have to be in place. Do no harm is the motto. Ventilation करना है करिए, tertiary care में करिए, जहाँ सब कुछ है वहाँ पर करिए. But the basic premise should be do no harm. And 85-90% of the newborns minded, we are sitting in a tertiary care facility. हमने क्यों किया ये सब कुछ? Because we realize the requirement is this. The requirement is not the high-end ventilation. That's it.
So even if you are doing high-end or top quaternary or fifth guna intensive care, immediate skin-to-skin care has to be done for the baby. Early initiation of breastfeeding has to be done. Hypothermia has to be taken care for the baby. Baby must get mother's milk. Infection has to be prevented. Otherwise, what is the fun in doing high-end neonatology? Because that will do more harm rather than doing good. So best is to have basic minimum standard of practice, which is effective practice in place. Even you may be doing high-end of tertiary care. किसने मना कहा IKMC नहीं करनी, early initiation of breastfeeding नहीं करनी, बच्चे को माँ का दूध नहीं मिलेगा, किसने मना किया है? AMC नहीं मिलेगी बच्चे को, किसने मना किया? Temperature ठीक नहीं रहेगा, किसने मना किया? Because if we don't do this, baby lands up in complication. उसके बाद high frequency दे दो या INO दे दो या ECMO कर लो, कुछ नहीं होने का बच्चे, कुछ नहीं होगा.
Thank you, Dr. Devari, for these nice words. It's important to make packages, but my only request is to still keep on investing in the youth, keep on believing the youth, and I sincerely feel that youth are doing hard work. They are getting more Olympic medals are getting broken every time. This over centuries is increasing. So younger population is also doing hard work. They are also equally improving. And seniors like you are important to guide them in the right direction. So I think that is amalgamation.
So देखो हम क्या कह रहे हैं, ICU जो करते हैं उनको भी अच्छे बच्चे दो, उससे आउटकम अच्छी हो. अगर हम म्यूटिलेटेड बच्चे देंगे एक्स्ट्रा म्यूरल वाले तो आपकी आउटकम ठीक नहीं हो सकते.
So आपका विश्राम और हमारी हिम्मत और हमारा जो हार्ड वर्क है साथ साथ चलना चाहिए. जो यंगस्टर्स हैं यहाँ पे रेजिडेंट्स हैं या जो फेलोज हैं उनको भी डिसर्टन नहीं होना, वो भी बहुत हार्ड वर्क करते हैं. बस हमारे को थोड़ी गाइडेंस बेटर करने की जरूरत है. थैंक यू सो मच.
हम ये नहीं कह रहे हार्ड वर्क नहीं कर रहे हैं,
है ना सर, वो करना नहीं चाहते.
बेसिक चीजें जो है वो इन प्लेस होनी चाहिए.
हाँ जी सर, वो बिल्कुल आई एग्री विद दिस. थैंक यू सो मच. थैंक यू फॉर दिस. यस
40 जनरेशन को बिलोंग करते हैं, इसी वाली एक वाली. बोलिए सर.
No, I was just saying, Dr. Devari, the COVID has brought us the opportunity now where we can utilize this platform. And there were days when we were doing the IMNCI and these trainings, going to the places, it used to take a lot of time. So now this is a hybrid thing. We can utilize the e-platform to learn the theory component, and second most important component is the clinical skill component. Now that the centers which are trained in the different parts of our country, district level, or even the medical colleges, so the people can get those skills to those places. So as Professor Devari has said, the these are the essential newborn care packages, which are important once, I mean, you give any, the training for any part. Those basic components are going to be there. And now let me share with you this, as Dr. Tiwari said, pre-term package, they are now taking it to the FBNC. Even FIMNCI, with the support of the WHO, it is already being worked up, and the training of the facility-based IMNCI, the older child also, is going to come on the similar format. But the important thing is how to take it forward. The packages are there, but I think we need the people who are there to sustain that. That's what I think is the message which is coming up.
Changing behavior of implementers,
yeah,
frontline people.
Yeah.
Moving to the next session, which is on role of biofire in pediatric practice. It is sponsored by Biomedics, and I now invite Dr. Chandra Khan, who is a senior consultant pediatrics medical superintendent at SRRC Hospital. He has been awarded WHO Fellowship and is a national trainer for
So the speaker will be Dr. Neeraj Goyal from Sir Gangaram Hospital. So as far as this biofire is concerned, it is one of the easiest, fastest multiplex PCR testing. It has been recently come into vogue, and it has been found that in clinical diagnosis, we depend upon the history, we depend upon the examination, and then for the investigations. And investigations at present, what we are doing, it may be quite time consuming, but with the array of these new tests, we can get a speed, we can get accuracy and comprehensive target. Investigation is late. What happens is average length of stay of the patients in the hospital increases, adverse outcomes are there, and patient dissatisfaction is also increased. And with biofire, what we'll find that it avoids guesswork. We are always thinking कि कौन सा bacteria होगा नहीं होगा. So guesswork has come down. Cost of serious testing will come down, and antimicrobial increase. So
thank you, sir. You have actually a brief of how tests are important and how these tests can be used. I feel very privileged actually to be the
you can kindly remove this. Why should we get clear?
So I feel very privileged to be only microbiologist in this August gathering of pediatricians. So I hope I am going to justify my presence here. So the hard truth is that more than 70% of the clinical decisions in the healthcare are based on the laboratory results. But unfortunately, less than 25% of these reports are actually used for guiding the therapy. And the primary reason is that, so by the time we send our reports to the doctors have already started the patients on empirical therapy. They are not waiting for the reports. Why? Because the early appropriate therapy is important, which was shown by this landmark study by Kumar et al., in which it was shown that there is a in survival rate to the institution of appropriate antibiotic therapy. So now we have got recently Wildfire, a new diagnostic tool which helps in giving the early diagnostic results within that golden hour, where actually our reports can actually make a difference to the management of the patients. So what is this film area of Wildfire? It's genomic diagnosis. It can identify up to 25 pathogens with one single test. It's very sensitive and very specific because it's a nested PCR, which means that there are two rounds of amplification. One first after the amplification, there is a second round of amplification of these amplicons. So this makes it very, very sensitive. In fact, 10 to 20 times more sensitive than the normal PCR. It is very fast. It identifies the organism within 1 to 2 hours, and very importantly, it is a cartridge-based system, which is in the format of the sample in and sample out. So there is a continuous processing of samples into 24 samples, not like conventional PCR, where we are waiting for the batching of the test samples. Theoretically, they give you result in 6 to 8 hours, but we all know that we don't put this test every day, every hour. And then this test, they require very small amount of the samples because these are based on the microfluidics. So what is film barrier? Basically, this is this cartridge is made up of 2 sheets of polypropylene, which is welded with the help of the heat, and they create blisters in between, and each blister is meant for one specific functions. Blister is for the sample extraction and preparation. The second set of the blisters two out of the 3 wells must be positive. Now, the melting peaks must fall in their specific range, which is very specific for each bacteria. All in all, what I want to say, it is a very, very tightly controlled, quality controlled, and it is very sensitive and specific. Now, I'm going to go through this various syndromic panels which we have today at our hand. These are the GI panel, meningitis panel, respiratory panel, pneumonia panel, and the PCID. And I'll be taking it to a case-based approach, and these cases are truncated because of the limitation of time. So I'm going to just present very, very pertinent, features of this case histories. So first case is a 12-year-old male, a known case of a connective tissue disorder presented with loose watery stool, fever, vomiting, and in the drug history, this patient was on steroids. Now, a provisional diagnosis of infective diarrhea was made. Now, infective diarrhea in immunocompromised patients, they can deteriorate very fast, and they can go to sepsis. So immediately, these patients have to be treated, and this patient was put on IV ceftriaxone pending the workup. Now, after the stool microbiology workup was done, routine microbiology was negative for oocyst, immune staining was negative for cryptosporidea, the antigen test was negative for the rotavirus, and the routine culture was also negative for any enteropathogenic organisms. Now, this is the dead end. Most of the clinicians or most of the pediatricians, they find that they're working for the infectious cause of the diarrhea when they're going by the conventional route, and you
6, 10, 14 or 2, 4, 6, whatever you want to follow. Then a booster at 12 to 15 months. After 2 years, you can give single dose of PCV13. If you want to have Synflorix, then schedule is same 6, 10, 14, one booster dose. But if you want to give a catch-up beyond 2 years, still you have to do 2 doses of Synflorix. Mimosil up till now is only recommended till 2 years of age because the data beyond 2 years of age is not there. So if the child is more than 2 years, then you have to use only PCV13 or Synflorix because DCJ approval is only for that. Less than 2 years, you can use either of the vaccines, and they seem to be doing better. And IAP is recommending 3+1 schedule only. So IAP is thinking about the office-based practitioner, individual responsiveness for that particular patient is coming to me. So I want to give the complete protection which is possible. That is why 3+1 schedule is being recommended. And it has been national immunization program. Many states got launched the pneumococcal conjugate vaccine. It was initially in the Bengal states in a pilot basis. Then Himachal was included, Haryana got included, and now even Delhi has been included. Up till now, whatever is available is PCV13 into the national immunization pilot project, but it has been informed that now maybe the Serum Institute vaccine is going to be, this pneumococcal is going to be there in that schedule also. So that is summarizing my talk here that first of all, you should use a pneumococcal conjugate vaccine for any baby less than 2 years of age. You should always say it's a pneumococcal vaccine. You should try to highlight all the points: pneumonia, meningitis, otitis media, tonsillitis, ear infections, to emphasize upon that you should use this vaccine. Whatever vaccine they use is fine, but at least they should use a pneumococcal conjugate vaccine. That's absolutely good. Option should be given to the parents. Whether they want to choose PCV13 or they want to choose PCV10 is their choice. That is what I do in my practice. Don't try to force upon that you use this or that. They should be explained that there is some difference between PCV13 and 10, but all vaccines are shown to be of major impact has been shown on pneumococcal disease. This is a new vaccine. We must keep our eyes and ears open about the side effects, about the trials which are going on, whether they are going on in India and abroad. But definitely it's an Indian vaccine. We are proud that we have now facilities of manufacturing Indian vaccines, and that is why in Corona times also all over the world it has been shown that we have manufactured vaccines at such a mass scale that closer to 100 crore people in our country are already been vaccinated by most of the time vaccines are manufactured in India. So I take proud in saying that, and also I say that whenever you choose a vaccine, you must appraise little bit of side effects which are there. Definitely consent is an informed consent whenever a patient is coming to you, but tackle those side effects because beneficial effects are much more. Thank you so much.
Thank you so much, Dr. Pankaj, for an elaborate discussion on these various types of vaccines. Now the house is open for our discussion. If there is any question, please raise your hand and ask the question. Yeah, at the back, Dr. Anupam, please. Please provide the mic to him.
Just an update on which, you know that for the last 1 year I've been involved in the sickle cell project of the Government of India. And we had a discussion on this, and in the scheduled areas, which are the tribal areas, we shortly pneumococcal vaccine will be introduced for all people in those areas like Chhattisgarh, Jharkhand, Odisha, parts of Bihar and Maharashtra, parts of Maharashtra, which are tribal area, Gujarat, etc. So we are going to see the rollout of conjugate vaccine in a big, and this means that nearly 15 crores is the population in these areas which I'm talking about. And 15 crore people will be able to get the benefits of the PCV. And what our thinking is that for the children, maybe the Serum Institute vaccine, and for the adults, the Pfizer vaccine is what we are thinking of.
Thank you so much. Sickle cell disease is a real menace, especially in the middle India. And if you can provide a pneumococcal conjugate vaccine to children, definitely morbidity, mortality associated with pneumococcal disease in this children is going to be less. That's a welcome step for the country that we take care of the disease as well as the morbidities associated with that type of disease.
Dr. Pankaj, with this coverage of PCV10 as we showed, you think in future PCV10 will replace PCV13 with more data and with better cost coverage and testing that the patients are getting?
So it will all depend on that whether the serotype coverage of 4 and 18C remains at present low levels, or they show catch up, or they show rebound because you have stopped covering them in national immunization program. Suppose if I take this vertically that the whole country decides to take pneumocell and all the eligible population is covered with that, then maybe after some time, maybe 2, 3, 4 years later on, the known serotypes which are not covered in the vaccine will come up. That is a natural process which has happened with most of the vaccines. So at that stage, maybe 4 and 18C and maybe others also may come up, and we may have to modify this vaccine at some point of time. Because ultimately, you must understand that PCV13 was never meant to be for our country. It was an American vaccine. It came for protection of America. 2006, it came to us, and then Synflorix was also never manufactured for our country. It was for Belgium, and they manufactured it there. It was useful for our country, no doubt. Now, this vaccine has been manufactured keeping into account the serotypes which are prevalent in our country. Serotypes may change tomorrow. We may have to go back to maybe PCV15, maybe PCV20 vaccine, and that is why Pfizer is already decided to make a PCV20 vaccine. So this question is very right. This is a dynamic phenomenon. You keep on seeing the prevalence of a particular strain, and you keep on chasing the strains, and you keep on modifying your strategies. But as of today, it appears that this is going to be the vaccine which we will be seeing in our national immunization program, and then future will be of more serotypes.
Dr. Pankaj, I think out of these 3 vaccines, only PCV13 is indicated in elderly people.
Elderly people. So the reason is that pneumocell up till now is not recommended beyond 2 years of age. And the Synflorix is not recommended beyond 5 years of age. So elderly people, its only choice is PCV13 only. And right now, my adult physicians, they use PCV13, and then 2 months later, they give PCV23. So suppose the COPD patients, chronic asthmatics, or heart patients, and it is actually recommended if you look for Indian, many committees, they recommended all adults beyond 50 years of age. So for that, the only choice is PCV13.
So I think we are doing a study at PCni, and there are 4 sites with us. One is Indore, one is Bhopal, one is Jaipur, Agra, Delhi. So 4 sites are there. 5th Calcutta we have taken, wherein we are looking at pneumococcus, which is grown in kids who have got the vaccine versus kids who have not got the vaccine. So Delhi was a non-PCV site, Calcutta is a non-PCV site, and out of these 3 sites, 1 site is non-PCV. So our aim is to look at what are the prevalent now strains in non-PCV sites versus prevalence in PCV sites, those kids who have received the vaccine. So that data will come in another 1 or 2 years. Till now we have grown around 50 odd serotypes, and of them 19A is the most prevalent. So this vaccine is an Indian vaccine which is covering 19A. So it's much better than the next vaccine. The 3rd vaccine, which is 13 type, is pretty costly. So you're paying 3 times more for a vaccine which is giving you, which is doing a similar job. So that is the logic behind this vaccine. Other than that, let us wait for the data to come. Let us see what strains shift, what happens. 18C we are getting in some numbers, और जो एक strain जो absent है, इस 10 में वो तो बिल्कुल grow नहीं हुई अभी तक, around 50 samples.
Thank you.
So that is why we say that ultimately the government also have to have data that those states where they used pneumococcal in the national immunization program before and after, whether some impact really on the mortality of pneumonia and other disorders related to pneumococcal disease has been there or not. So that is another thing which will show us confidence in using this vaccine in a much larger scale.
Thank you so much. Any other question?
Yeah, Dr. Satish.
I think our Prime Minister already announced this a few months back about including in whole of India, because there are 5 million deaths below this pneumonia. And the government of India scheduled, there are 6 states like Himachal, Bihar, Madhya Pradesh, Uttar Pradesh, and Haryana, and now coming to whole of the India. And this is to see the cost affordability also for the government. In this less amount, more coverage. And this suits more of a national immunization program like 6 week, 14 week, and 9 months. And they found with this incidence will be less. If we give 3+1, those who are in practice and they can afford, they go over 3+1. But as a country, we have to see the interest of the whole of the country rather than a small percentage of the patients.
Absolutely. It appears to be the India specific vaccine.
Thank you, Dr. Pankaj. I thank the audience, to make it a very interactive session. Thank you very much.
Thank you, Dr. Pankaj and Dr. Nath. And now, like we all know that we are living in the COVID era, and children are suffering first because schools are closed and there is no access to playgrounds. So children are getting lots of psychological, psychosomatic problems, what we can call as COVID blues. So we have a panel discussion on unlocking COVID blues in children and adolescents. And the panelists are leading adolescent experts, Dr. Harish Pemde, Dr. Latika Bhaza, and Dr. Deepa Bhaza. And the moderator is Dr. Chandra Mohan. I invite Dr. Chandra Mohan as the moderator. And he is additional professor at pediatrics in Scotland. Keen interest in adolescents. He has many publications on his web, and he has been the Journal of Pediatrics and Adolescent Medicine. So, what we panelists and
thank you. At the outset, I will thank the organizers for giving us this opportunity, and I will now invite my panelists on the dais. So please welcome Dr. Harish Pemde sir, Dr. Deepa Pasi ma'am, and Dr. Latika Bhalla ma'am. Dr. Pemde sir. So first I will introduce the panel. Dr. Pemde, as we all know, needs no introduction to this crowd. He is the Director Professor of Pediatrics at Kalavati Saran Children's Hospital, and he has been Joint Secretary IAP 2021, and he is Vice President International Association for Adolescent Health. He is General Secretary to the IAP Medical Education Chapter, and his areas of interest are adolescent health, and he has more than 65 publications in journals and more than 20 chapters in the books. So, Dr. Pemde sir, please join us. Our next panelist is Dr. Deepa Pasi. She is a practicing pediatrician at Noida. She is Senior Consultant and Chief Coordinator of Pediatric Child Development and Adolescent Clinic, Apollo Hospital, Noida. She is into adolescent pediatrics full-time, and her presently she is Joint Secretary AHA Delhi, Adolescent Health Academy. She is trainer in AYA and Awesome Aya, trainer for MKU 2018-19. She has been trainer for BLS and the ALS modules, and she has contributed to the Central IAP Women's Week teaching modules. And she has been placed in the excellent report for the Apollo hospitals for the 4 consecutive years. Our next panelist is Dr. Latika Bhalla. She has been a senior consultant at Adolescent Health, and her present affiliation is she is affiliated to the Sir Gangaram Hospital, Institute of Child Health, and her major area of interest is adolescent and developmental pediatrics. And she has been a diploma of national boards, pediatrics, diploma in adolescent pediatrics, diploma in MSc fellowship in endocrinology from New South Wales, London, and fellowship of pediatric endocrinology. She has been in Gangaram for last 10 years and taking care of children with the health problems and non-communicable diseases. So let's introduce the topic, the COVID-19 pandemic. We all have been well versed with it and we all have felt the dance of it. The say that COVID-19 pandemic has deteriorated the health key determinants of health and caused major upheavals everywhere in the world. No country, no island, no community has been spared. And the children, although directly less affected by the virus, are paying a heavy price for it. Why? Because children do suffer from many aspects, even though as a disease has been less severe in children, and the number of hospitalized children accounted only for 3 to 8%, even though their population is between around 20%. But the lockdown that has affected children very dearly, and parental loss. Many children lost both their parents, some children lost one of the parents, and the parental stresses like loss of household income, loss of job opportunities, stress to the parents, single parents taking care of children, those stresses are finally affecting the children. So these changes in the lockdown, these have affected education, physical activities of children, and opportunities of socialization, which are very important aspects. Education, schools have been closed, physical activities, parents were not allowing their children to go out and play, and the social activities, for a development, the child needs a peer interaction. So when the peer groups are not there to play with, the children have suffered a lot. So as per the UNICEF report, the 195 countries in the world had school closures. So almost every nook and corner in the world where there is a law and order, there was a school closure. Around 290 million children were out of school. So they were out of school, and many of them were dependent on their nutritional aspects also from the schools, and the midday meal schools program was also affected. COVID-19 accelerated violence and poverty. The violence, household violence increased against children, and children suffered from physical as well as some children suffered from sexual violence too. And as there is the data shows, that the World Bank data shows, 70% families, they had reduced income during this lockdown and COVID pandemic, so that poverty has also affected children adversely. Child labor, child marriages, and child institutionalization, when they are being taken care of in institutes, they all were affected. So what are the some COVID blues? When we talk about the term blues, it means it has affected us adversely. So there are some headlines like social anxiety to temper troubles, and the pandemic is affecting the kids' behavior. The behavioral issues in children are the making headlines in Hindustan Times. In the international state, Vulnerable Children's Hospital chief says COVID-19 is spurring the mental health crisis in the kids. So this is an unprecedented crisis of last 100 years, and this will unfold over another 5-6 years when these children grow up. And the anger issues to suicidal tendency. Children's mental health suffered severely during the pandemic, claims experts. So today, we will see these blues under the preschoolers. In the preschoolers, they are reduced interactiveness and delayed development of speech. Some children reverting back to thumb sucking, bedwetting in the previously toilet trained children, anger and hyperactivity. Some children prefers to stay alone and don't want to be intermingling with the people. Separation anxiety, while the parents are in isolation and quarantine, the children have been clinging to their parents and having excessive dependence when they are doing everything under parental guidance and not able to take their own decisions. Fear of darkness. This has proven a very difficult situation for many of the parents. For school-going children, there has been anger and hyperactivity. There has been violence either due to excessive screen time, and they are exposed to the watching violence and or abuse of any nature of the home. Unexpected abnormal behavior due to boredom or excessive time on mobile phones. Anxiety due to lack of certainty. The periods of uncertainties, there are the big stresses for children too. Stigma of the disease. They are afraid that if they catch the disease, they will be outcast in their friend circles and they will be having stigmated. Sleep disturbances, children are finding it difficult to put to sleep, and nightmares being withdrawn from the society. For the adolescents, the anger, temper tantrums, conflicts, nightmare, insomnia, panic attacks, and most important, anxiety for lack of certainty about their exams and their futures. Many of the children who were to go for the board exams, even though they passed exams without giving board exams, but they had a harrowing time. I believe their experience is more difficult than what we experienced as a students when we appeared in exams and got our marks by our performance, not by the board's gracious courtesy. So today we will see some case vignettes. So the first case is for Dr. Deepa. A 5-year-old girl came to OPD with the chief complaints of the mother says after the reopening of this office, the child is not allowing her mother to go out for the office. Is always clinging to a mom and has started thumb sucking again. The child is fearful in the dark, starts crying, and has recently started bedwetting when the child was toilet trained properly. Now, how to deal with it? Dr. Deepak, can you explain the situation and what is the outcome, how we can manage it?
There has been a lot of influx in such type of cases coming to the OPD, and there has been a seafold rise in signs and symptoms of depression. Those kids who had already achieved the bowel and the bladder control have suddenly regressed, and they have started bedwetting.
So the regression has been a diagnosis for this child, as this is due to the COVID blues. Yes.
So there is regression of the milestones. So for bedwetting and all, we can keep a check on the intake of the fluids during bedtime. And for potty training, we have to start from the very basics. For the thumb sucking, we should avoid the situations which may exaggerate the situation, like if you scold the child more or criticize the child, that will lead to further thumb sucking. So that has to be avoided. Reinforce healthy behaviors like rewards and praise when the child is not thumb sucking. And if the child is old enough, little higher than the age group, then you can apprise the child what effect it will have on the oral health of your, if you do with the thumb sucking. And for this, we have to realize that there are not only these stages, there will be excessive clinginess, excessive crying. So you have to soothe the child. The child may go on to baby talk. There will be fear of the dark. For that, you can have a night lamp. You can accompany your child to a dark room and then switch on the light and tell the child that there is nothing around to be fearful about. There may be separation anxiety due to isolation, because now for so many years, for a year or so, the children have been staying with their parents in close association with the parents, and when the parents have to go back to work, there will be separation anxiety. Now, I'd like to pair the regression with the idea of progression. Most children have a very strong urge to move forward in development, that means progression. And there is a natural energy in the children to explore, to manipulate, and master their world. Regression can vary, but in general, it is acting in a manner or for a needier way. So remember, when they are stressed and distressed, they will regress. And rest assured, regression is common and it can happen at any age. It can happen in children, in preschoolers, toddlers, young adults, and even in adults. That is just to feel safer, so that the person likes to go back into an environment which is sane and familiar and predictable. So behavior is a communication, and it's their way of showing us, usually not consciously or intentionally, that the brain is trying to handle a lot. There's a lot of stress they have to cope up with, and regression is an unconscious way of telling us that they need extra love, security right now. So don't punish regression, but don't even reinforce it. Reinforce only the positive behavior and shield your child from the various news coming for the COVID-19. Turn off the television news, because, and whenever you have to discuss about the problems arising because of the COVID-19 in the family, then you should be away from the children, because the children are the antennas for their parents, and they try to internalize things then and set up a family routine so that the kids have a range of activities during the day. You can play with them, even hide and seek in the house can help. So, and During this time, the screen time has gone haywire. So you must put a check onto that. Video chats with the family members can establish good, positive, healthy relationships. So this way you can deal with it. Now, coming to the regression, I'd like to go back. The punchline is that you have to approach these children with a lot of compassion and support. So the various things which you can do is to follow a schedule, because during the pandemic, it was treated like an extended holiday. The children had started sleeping late at night, getting up late in the morning, the breakfast went haywire. So make a schedule, but you cannot be totally stuck up on that. You have to have little leverage. Acknowledge that is hard for the child. In front of the child, you must tell them about your own thoughts process, whether you are feeling sad, lonely, and tell them to validate their emotions. It's very important for the children to validate the emotions. Offer them comfort, and that can be provided by snuggles, the pat on the back, and providing praise to them. Physical touches will help them a lot to tide over this period. Give children something to control. Remember that when children get in control by knowing what the rules and expectations are in the home and in their relationships and having a routine for the days and the weeks, you can also add it in by building choice into their day. For example, they can have the choice of the outfits, or the choice of the television programs they can see, for the books they can read. So give them choices. Secondly, you should also understand that to let them make connections with your family, with video chats, the Snapchat, you can have Google, Zoom meetings with your grandparents, with your cousins, with your close friends, so that they feel connected. Making them feel connected will make them realize that they're not alone facing the situation, and you can, everybody else is also in the same situation and they can tide over it. Stay positive, very important, because positive reinforcement can help turn the things around. Last but not the least, the parents have to assess their own stress, because if they are aware of their own stress and anxiety levels, it will give them, they have to give themselves a break, and a break can be in the form of, sitting in a corner, sipping a cup of coffee or reading a magazine, and this can be done when the entire household gets up. And the daily interactions with the children with caring adults will provide a comfort time of stress, and big or small, these everyday moments have the potential to build resilience, not only in the children, but also the parents, and this will be a buffering act and provide a safe, stable and nurturing relationship, helping children thrive. So the thing is that you have to support your child during mental health, give unconditional love to them, give them support, let them validate their feelings. Exercise is very important because it will produce the good hormones and they will feel happy. Education about the COVID and also their own curriculum has to be followed. You should allow them, teach them the coping skills, breathing exercises or relaxation exercises should be taught over. Conversation, that means you have to one-to-one talk with the child is very important. Tell them you're also feeling lonely, and similarly, the child can also relate to you. Listen to them. Do not always interrupt them. Try to be in their shoes. Behavior is very important, and rest time is very important. You have to have a curriculum fit for their activities and for their rest time. Last but not the least, with the self-care and the mental health, share the 6-second module of self-awareness and self-direction is very important. For that, you can share your feelings, encourage them to develop self-awareness, set aside time for low-stress activities, find social groups which will help them to tide over, articulate their feelings, encouraging journaling and articles. This means that you write down what you have gone through the day. This will help them to retrospect at the end of the day, and you can provide solutions to them. Establish a self-care routine that they get up in the morning, sleep nicely, at 7-8 hours sleep is there, and they should switch off their gadgets about an hour or so before sleeping. So children have a great antenna, and we have already said, and sometimes this gives them a reassurance for your children.
So thank you, Dr. Deepa. You have nicely elaborated the points, particularly the most difficult ones to deal with are the preschoolers. Because the parents themselves go with a lot of anxiety and they don't know how to interact with. With your guidance, they will be able to do it. So now that we come to another case, Dr. Latika will take this case. So Rohan, an 8-year-old boy, has presented with showing excessive anger and violent attitude. The header throughout was web series and was always on the iPad. Was irregular, is having irregular sleep habits, remains irritated almost always all the time, and is unwilling to go school after the physical classes have started, and complains of headache every morning. So parents are anxious about his behavior as well as about studies. Now what to do, Dr. Latika?
Good afternoon, everyone. It has been a great talking to everyone, and it has been a
I should can be a bit louder. Yeah. Yeah. Sorry.
Yeah, good afternoon, everyone. It has been really nice meeting everyone after a long hiatus of 1.5 years. This problem, which we probably are witnessing once the school children have started coming back to the OPDs. So this child is an 8-year-old child. Last child, what we had followed is a 3-year-old child. They are showing some different kind of symptoms, but once the children become preschoolers, or you can say pre-adolescent, they tend to have different kind of symptoms. So basically in this, the child is showing all the anger and violence. So anger and violence is a way of showing the kind of frustration the child is feeling at home. So basically because of that, since the parents are not there all the time to control the situation, so all the behavior has been channelized into watching this excessive use of screen media. So child has a violent behavior, and then there is another thing which is a problematic media use. So in these kind of children, we have to assess the child right from the beginning. Maybe there are some kind of things like ADHD or maybe autistic behavior, or there may be a loss of family members, both busy parents. And whenever we have seen the children are very petrified, or all the time they are seeing the parents are there all the time, but they are not talking to us. So both the parents are working and they are on their work from home routines. That also can be disturbing for the child. So we have to investigate the child for anemia. So there could be an associated vitamin deficiency, any chronic illnesses which probably must be missed initially. Managing the child will be for the better coping strategies. Next slide. Yeah. For that, we already has been discussed how to judge about the mental health issues of the children. So in this child, it is where the most important thing is the problematic media use. So screen time for classroom activities has to be noticed. Parents also have to become more monitoring for children. So because if the children are using some kind of things, they normally have that kind of behavior from the parents. Because, or maybe from the grandparents also. Sometimes we see the children coming with to us that they have a headache. Probably if you ask them what is headache, they probably will not know what is headache. So this is what they have been hearing from their grandparents, and then they feel, so probably they are getting attention out of that, then they should also get attention out of it. So some app-based exercise activity as family, as a happy walking, kind of a cycling or walking, or if you want stuck at home, then maybe there's some kind of a skipping or yoga classes, and exercise, the hand exercise can also be taught to the children. So basically you have to change the behavior of the child. So behavior can be changed according to the age, should be age appropriate. If the child is a younger child, or once the child is becoming adolescent, pre-adolescent, or then they're becoming to the pre-adolescent also. So adolescent have a different kind of a behavior than the pre-adolescent. So they would always not like to be treated like a child. You have to give them an appropriate education, as well as the behavior change should also be appropriate to that. Next slide. Yeah, what kind of a joyful activities can be done at home? There could be a responsive creative activities, and there has to be a parental involvement. So these are the various activities which can be done inside home, like singing, dancing, paper craft, painting, home decorating, and involving the child in the daily household practices, sharing childhood days of parents, or for children it could be story narrating, playing with the colors, or dancing, or maybe you can arrange it for some kind of a pencil test, or maybe paper board one there are rainy season now. Outside the home also can be done, but they can be done in the compound only, gardening, flying kites, or the terrace gardening. And then very important, if you're walking with the parents, so that also will be very comfortable with them. These kind of things which can help the children to get over these classes. Thank you.
So these are the this type of scenario is the most common. So take a good history, look for the physical elements like anemia and those things, and then take a proper decision. Now the third case is for Professor Pembe sir, as you are the adolescent expert and the most difficult cases to deal with are adolescents. So this is a 17-year-old girl. She has been preparing for her NEET exam, but she has been always anxious. No one knew when the NEET exam will happen. So she has gained excessive weight during this lockdown, too much indulgence on the fried food and soft drink. She shouts back and starts crying when asked to do some physical activities and household chores and remains withdrawn for days and has poor self-care. Now, how to approach it?
Thank you, IB Delhi, and thank you, Dr. Mohan, for creating this space for me. See, whenever we deal with a child who is more than 10 years of age, especially this 16, 17-year-old child, we have to follow certain procedures that we are dealing them in the situation in our field. It's very, very common to have more weight during their board exams or when they prepare for boards like in 11 and 12. Most children, they will gain weight. There's nothing unusual about it. There are some features in this scenario which are not normal. Like this shouts back and starts crying, this should be a new behavior in this child. That is why it has been highlighted. Some children may be having this behavior since very early childhood, and it may be accepted as a routine behavior for them. But if some change in behavior which has occurred, then this is important that we must consider it, then why it is happening and how should we deal with it. So, friends, whenever we are dealing with a child who is 17-year-old, we should always do an alone interview. Alone interview means that talk to the child, talk to the parent, then talk to the child alone when parents are not there. This is very, very important and it changed from other practice. For pediatric practice, we always see child along with the parent. Here, we have to see the child alone as well as with the parent. This is one thing. Why alone? Because you have to provide some privacy. There should be an audio privacy and should also be a video privacy. Then comes the confidentiality part. We have to ensure that child understands them. You have to tell that whatever transpires between you and me will remain confidential between you and me only. Unless I find something which may harm you or which may harm others, then I will have to talk to your mother with your permission. Such statements are very, very important and necessary. Then only child can. Because you are dealing with a behavior which you need to find out why this behavior is occurring. Many other things are also there. This may be because of something happening to the child, something happening to the environment of the child may also be there. Someone may be doing some kind of abuse, then also this kind of behavior may be there. That you have to keep in mind. But as far as in this case scenario say, preparing for NEET exam, and then she developed this kind of behavior. The child may have lots of anxiety because of exam and exam results and because of their career. And because of this perception of not good performance during exam, child can have a feature of depression also. Okay. Some of the features there, this is one thing that change in behavior is there. And child is not able to do any physical activities, change in activities is there. But this last line is very, very important. Remains withdrawn for days and then poor self-care. So this is a feature of depression. Whenever you find such features.
So this is very important, poor self-care and remains withdrawn. So this is a red flag sign, depression is there. So take this case very seriously. It's not only
we have to how to reach, how to find just the features over there. You cannot just talk of depression straightforward to the child or to the parent. You have to follow through a process. The process is by the acronym of HATS. If we need to learn one thing in adolescent medicine, we must learn the HATS. Okay. This begins that when you start talking to the child, talk about school, talk about home, how many people are there, what do you do at home. Something so that you make a good rapport building with the child. So when you have a good rapport building with the child, talking of neutral things like home activities and about education things, about the school friends and other friends, Then come to AA with activity. What do you do in the school? What do you do after the school? How do you do the entertainment? We can talk about the screen time, social media, and many other activities like this. Then come the features of depression or any use of any drugs. Then you have to ask some questions related to depression. How do you feel now? What is your feeling? It's even that I don't like anything. I don't like any activity now. I used to enjoy it. I used to see lots of social media. I don't want to look at the social media. I don't want to look at those cartoons or those series or those pictures. These are the feature of kind of a withdrawn behavior. Something the child used to enjoy earlier. Now the child is not enjoying that thing. It's a feature of change activity and maybe a feature of depression. So this child definitely requires a screening for depression. And in most likely scenarios, this child may have at least mild depression. All of us have such features for 1 day, 2 days because of many things happening over here. This is not depression. Unless these features persist for at least 2 weeks. 2 weeks is the minimum cutoff. If they persist continuously for 2 weeks, then yes, we should get concerned. This may be a feature of depression, but if this thing improves in 1 or 2 days, 3 days, then this is not depression. Okay. So in mental health, we have to assess what are the features and how long they persist and how they are changing the routine of the child. If this is having impact on sleep, this is having impact on study.
You will come into the guideline science that also.
So that we can diagnose that it is a depression. So this is the approach. Slides are there. No. So when we find that child is having some mental health issue, and if you are competent enough to diagnose and treat, go ahead and treat them. But whenever you find that you are not so competent and not so confident in treating that patient, then take help. Take help of your other colleague, talk to others, or take help of a psychiatrist or a psychologist. That will be very, very important thing. But identifying that feature is the responsibility of the pediatrician.
Well, sir. So in this scenario now, the blues are well explained to everybody, and stakeholders are parents, the schools, the community, and the doctors. So after understanding the blues, now Dr. Deepa, can you highlight what the parents need to do in such scenarios?
Yes, the parents have a remarkable role in controlling the problems the children are facing. They should speak calmly and firmly to your child if he or she has misbehavior or undertakes any risky behavior. Pick a calm, undistracted time and gently ask how they are feeling and make sure to respond to their outbursts in 3C. That is being calm, consistent, and in a comforting way. Try to understand the situation and the reason behind a certain negative behavior. Maintain a regular routine and give children specific responsibilities, which can be as simple as laying the table or clearing the table after dinner, or for that matter, doing little dusting, doing chores like gardening. So this can help maintain a healthy routine. Build your relationship with them as mutual trust and respect. Teach children about personal safety rules. Their body belongs to them, and any uncomfortable touch or gesture made by anyone which makes them feel unsafe is not acceptable. Teach them about the universal sign of help, that is holding the hand up, putting the thumb into the palm, and then closing the four fingers. This is the universal sign of help which should be taught to each and every child. And always trust and believe children if they report of any sexual abuse. Tell them about cyberbullying as well, because the screen time has gone very high. I would like to put over here, there's a raindrop therapy. Basically, this is like dropping little hints to your child, that child can reach up to you should the things become unbearable. So you just have to put little raindrops out there by saying, you know, I'm also around and I'm going to be in my study. If you feel like talking, please come. So they will put, if you give these small hints to your child, the kid will reach up to you when they feel comfortable. So give them some reason and let the raindrops flow. Let your child know that you're available to talk, but if they're not comfortable with you or for whatever reason, make sure they have someone, and trusted adult, who can be a family member, an aunt, or for that matter, an elder sibling in the family, but reassure them gently and gradually. And there are few activities you can do with them, like I'll discuss that. It is tell them that it is normal to feel fearful and anxious during this time. Someone with more or difficult experience like an adult might be able to suggest options for your child as a part of emphasize that your child isn't alone. You will be there whenever your child is ready to talk. Next slide, please. So the activities which I was mentioning is that the mindfulness, that is staying in the present. The past is already gone, future we don't know. So tell them to focus on the present work they are doing. There are very interesting activities you can do. That is box breathing. You teach them deep breathing, deep inside out, and this can be done easily with a balloon as well. Then they can be, give them a happy place area, so that they can calm themselves down. They can do some sketching, some painting, some activity in that area. Then there can be mindful coloring. There are many coloring books available with bright colors. Like aromatherapy can help them. So these are small activities which can help in allaying the anxiety and the stress in the children. And keeping a journal is very important, how you interpret your feelings through the day, because that will give you how to retrospectively you can act on them. Talk to someone you trust. So it is very important that you should be that person as a parent in the life of your child. If not them, somebody else.
So, yes.
The bereavement or loss is not necessary that it happens only in family.
Yeah.
News of this happening around the country can also be used. So PTSD is a very common thing which can happen in young children, post-traumatic stress disorder.
Yeah.
And parents have a great role in that. But it becomes again very difficult that parents themselves become very anxious.
So parents are pressurizing PTSD, and as well as now we understand the gravity of the situation. Now, Dr. Latika, what schools can do? How can they help the parents as well as the children?
So the school opening has been taken differently by different students. Some of the children have been liking it a lot, and some of for them it has been a very welcome situation. But some of the children still are not liking it also. So first we have to make the parents aware what the steps the schools are taking to make it a very safe kind of a stay for the children in the school. So first, the schools have to be very they have to make the parents feel that after your child comes to school, it is a very normal behavior, and they are going to be doing safe in school. So for that, they have to encourage staff to check in with the students on a regular basis and see how they are feeling. So second is encourage students to schedule activities. It can bring back a sense of comfort. Teach students the activity, coping skills, mindfulness, and mental exercises, which are all discussed. Support students to remote stay connected with their friends, or maybe otherwise, if they're not enjoying much screen time, since they've been using excessive media usage also, but since they need to be in touch with their friends or their family, and in the school days that may not be happening because of the children are not allowed to sit as they used to be sitting before. And the thing fifth is encourage students to support their friends.
So going with the gatekeepers concept, everyone has a role defined and everyone must contribute to it. Now, what else can be done?
Provide parents with the material and advice that will be helpful to them. As teacher, if you are worried about a student, provide psychological support by referring him or her to a mental health professional. So there are different kinds of situations that I mentioned the school have been taking regarding this school reopening and recovery. It could be engaging other communities in the reopening plans like the parent-teacher associations, targeting resources to where they are most needed. Getting children back to school is very important, and making school environment safe that we have already discussed. and recovering learning loss and building back a better situation what they are already in.
So now this is for the Joint Secretary Liaison, Indian Academy of Pediatrics. What is IAP's role as well as the community community of pediatricians?
The IAP is a stakeholder with a primary responsibility to its members and overall responsibility to the children and adolescents of the team. Right? For members, they have done large number of programs. We all know about this COVID program was there, not only for management of COVID in children, but also on adults. People have reported it was largely very, very beneficial. And all branches have participated in that. IIT Delhi also makes happen on it. Then IIT had guidelines for school reopening also. And I think one of the very, very important intervention by IIT was about dispelling the fear of third wave. It was very well covered in media. They said that children will not be more involved in third wave. That was a very important thing. And having the program in conferences is also one of our contribution. And I think IIT has always come out with guidelines and education and awareness of its members and the community whenever something new happens. So IIT was not behind during this COVID pandemic also. And I think more will be coming in next few months.
So IIT has done its lot, and this program is also aimed at that. So now we will come to the last segment, and many parts have already been discussed, but once again we will be highlighting the role of mental health professionals. So Dr. Deepa, when to seek help of mental health professionals in toddlers and preschoolers?
Well, when these symptoms last over a period of weeks and months, we need to seek the help of a mental health professional. So when just at enumerating, we've already discussed in great details, fussiness and irritability, startling and crying more easily, and it is difficult to console a child, falling asleep and waking up more during the night, feeding issues such as frantic nibbling, more reflux, constipation or loose stool, or new complaints of stomach pain, separation anxiety, which can be manifest in the form of clinginess, crying excessively, they become socially withdrawn, they're hesitant to explore, and seemingly to fear going outside. Temper tantrums in the form of hitting, frustration, biting the younger sibling, bedwetting after they have been have the bladder control and being potty trained, already potty trained. Urgently express needs while seemingly unable to feel satisfied, and when there is a lot of conflict and aggression, or themes like illness or death during play.
So Dr. Latika, for adolescents, the red flag signs.
So the same kind of things what we have always seen. Persistent sadness, withdrawing or avoiding any kind of social interaction, hurting oneself or talking about hurting others, talking about a death or suicide, outburst or extreme irritability, out of control behavior, which we had already seen in the case unit, and then the drastic changes in a mood, behavior, and personality. Or then eating disorders also, loss of weight, gain of weight, difficulties in sleeping, frequent headaches, difficulty in concentrating, and there is the loss of academic performance, or they don't want to go back to school. All these can be the red flag signs.
So now take home messages. Splendid sir, can you give your concluding remarks and take home messages?
Talking about the last issue you raised, that where should we take help of mental health professionals? Anything happening with the child, it can't be explained by any physical signs or symptoms or physical disease. This is an indication of having some mental health problems. And whenever someone feels not competent enough to manage that, we must take help of mental health. The second, whenever there is a mental health disorder, established disorder is moderate to severe, we must always involve the mental health. And whenever we are prescribing some medicines for mental health issue, we must take help of mental health. Whenever there is a history of self-harm or attempt to suicide or suicidal thoughts, we must always take mental health professionals' help, and we must document it in whatever way we are documenting it on the patient's paper, and help also child to and arrange for that mental health professional consultation yourself. Send them to safety and give some first aid for prevention of suicide. These are very, very important things. As a pediatrician, we all must learn and understand. These things can happen not only in adolescent, but prior to that age also. All of us practice up to 12 years of age, and before that also these things happen. Thank you.
So, in conclusion, recognize the blues, individualize the approach based on the child's symptomatology and the age group. Help parents, you have to handhold the parents because they themselves are having a lot of stress. Counsel children and adolescents as told about the head screening and individual counseling, interviewing. Reach out to the schools and community, what help you can provide. And one important aspect with Latika ma'am also told about the media fire, douse the media fire, the third wave pandemic, that was a bigger pandemic than the actual third wave if it would have to come, and the seek help of mental health professionals when needed. With this, we come to the end of the session. Thank you. Thanks to the organizers once again. Thank you.
Thank you, organizers.
Thank you, sir.
हेलो आप कभी समझ में नहीं हो आपको ना अभी कुछ ऐसे को हुआ इसको कनेक्ट करा था अच्छा अच्छा ग्रुप में मैंने देखा था प्रतिमा ना हाँ भेज दिया हाँ भेज दिया तो इसका डॉक्टर प्रदीप ने भेज दिया स्टार्टिंग
Don't tell me. आप 2 मिनट टेक्स्ट कर रही हो, Facebook अपडेट डालती हूँ।
आपकी न्यूट्रली देखती हूँ सब न्यूट्रल
अभी डिवीजन अभी फुल डिवीजन ही है ना अभी तो हाँ
जैसे हम आते हैं मतलब हमने खाली किया इमरजेंसी में अगले साल 2
नहीं वैसे कुछ नहीं अदरवाइज अगर इंटरनल वर्कलोड हम मतलब प्रोटोकॉल की बात नहीं कर रहे तो वर्कलोड क्या डिवाइडेड है कि नहीं
नहीं डिफॉल्ट वाले ओपीडी को जो करते हैं जनरल ओपीडी और अपना हाई रिस्क क्लिनिक हैं वैसे हम नर्सरी देखते हैं जैसे मैं मेरे को तो ओपीडी से भी वो किया हुआ है
नहीं वैसे कर रहा हूँ वार्ड पीरियड में आपका ज़्यादा होता है
वार्ड्स में नहीं इमरजेंसी में जाना तो कोविड में उन्होंने बोला था इक्वल होंगी तो हमने कहा चलिए कोविड में करा लो फिर कहते वो भी तो सस्पेक्टेड कोविड है वहाँ पे भी इनको भेजो तो वो मत फिर से आने लग गए अब फिर बहुत ज़्यादा कंफ्यूजन हो रहा है यहाँ की जगह तो अब ये हो गया है कि 3 फैकल्टी बना ली है फॉर इमरजेंसी
कौन कौन आप लोग न्यूट्रॉलजी में
मैं हूँ डॉक्टर सुवंदा आर्या डॉक्टर साइंस है डॉक्टर चिलानी डॉक्टर हरीश चिलानी तो इसमें लेकिन हमारे पास 3 नर्सरीज हैं ना तो हमने
डॉक्टर हरीश तो अवेलेबल होते नहीं होंगे ना
कोविड में तो सबकी ट्रैवलिंग
कोविड ट्रैवलिंग
एपीएनसी वो इंटरनेशनल वाला
हाँ तो कुछ ऑनलाइन हो गया ना अभी आईएमसी मतलब सब कुछ ऑनलाइन डॉक्टर हरीश चिलानी मैं और हम लोग जैसे एक तरफ देख रहे हैं मैं आईसीयू एंड एक नर्सरी फिर हम 3 मंथ बाद रोटेट करते जाते हैं दूसरी नर्सरी में डॉक्टर प्रदीप अनीता एंड सचिन
किसी को एक बार मिलना होगा
डॉक्टर प्रदीप देवता मिले होंगे
इलेक्शन में हम थोड़ा एक्टिव थे
प्रदीप अनीता है अनीता है
अनीता प्रतिमा अनीता
पैनल वोट करें
एक्चुअली जस्ट अभी ब्रेक हुआ
अच्छा ये ब्रेक को टाइम लगेगा
जैसे आते हैं लोग
अच्छा कोई
हम एक बार आते हैं
कैसी गैदरिंग की इच्छा है यहाँ पे काफी लोग आ रहे हैं
अच्छी आज थोड़ा सा वो सेशंस के ऊपर लोग बोल रहे हैं हम आपके रहते हैं ना तो और कल तो आपको 2 दिन आपके साथ फ्री लंच वैसे तो कम हो जाता है 2 दिन में रहेंगे मानस स्पेशली उधर गया कि मैंने एक बार बैग वाले में फिर बैठ जाते हैं ठीक है
क्या Agro was deeply here. No?
कोशिश करो तुम
हेलो हेलो बस सर मेरा है ना, इसके बाद तो मैं एक बार देख लूँ अपना।
देख लो देख लो।
क्या बात है भाई, लंच तो खा लो।
लंच का मूड नहीं कर रहा है।
क्यों? हाँ? आ जाओ ना, आ जाओ, तेरी थोड़ी फ्रेंच नाइस। मास्क के अंदर पता नहीं चलती थी। थैंक यू। फर्स्ट वन प्लस के सबसे बकवास है फर्स्ट। Sir, Dr. Manish, I need your camera for 1 minute. The most awesome camera he has.
सर मुझे यही बता रहे
दो तीन
अच्छा अभी नहीं, कल आओगे? आज में देखना कुछ
बोलते हुए जब बात में खींचोगे तो बेकार है। पांच खींच के आप उसे थैंक यू।
बता रहा था कि कुछ उसका प्लेट में कुछ इशू था, हो गया?
क्या चीज है मैं भाई 15.5 साल अभी ने मैथ्स शालीमार को दिए 15.5 साल शी इज बैक it should not better but yeah the feeling comes from uncertainty of I have to now put in effort again oh how is it going to be what is that no maybe 5 lakh more than what she's earning but I don't know that point अगर मैं नए से भी शुरू करूँ I want to reap the fruits of the seeds that I have sown sleep better tonight. नेताजी की मेरी लेटेस्ट कैपेसिटी नहीं अपडेटेड नॉलेज 15-20 साल से कटा कुछ हुआ नहीं अब खुद के जो हार्ट सोल ब्लड सब डाल देते हैं पेशेंट उसका हो जाता है पेशेंट में तो कोई एक जो टाइम देगा पेशेंट मेरे नाम पे उन्होंने भी तो सारे पेशेंट तो मेरे हैं तो मेरे नाम पर रहते हैं लेकिन एक ही दिन को जाता है कि मेरी आपके बाहर फेंक दिया 2 साल तक आप IEP का लेक्चर नहीं दे सकते आप IEP का लोगो नहीं समझ सकते आपको IEP की फैसिलिटी नहीं तो उनको जा रहे हैं मेरी कि तुमने मेरे को नहीं किया
हाँ सर मैं पहुंच गया हॉल बी में यूनिवर्सिटी नहीं सर गया था अरे सर लेट है कोई नहीं आपके तो पेपर मोदी साहब है यहाँ पे और क्या 40 की बात करो 40 दिन बात कर सकते हैं
I was thinking कि ये scrub में ही आएगा.
I saw him मैंने कहा नहीं scrub में मेरठ भी गया तो कॉन्फ्रेंस में ऐसे ही था मेरठ कॉन्फ्रेंस में भी तो गया हमारा टॉप
ये तो बचाना ही नहीं रहता.
The big guns come in casual.
But his hospital uniform looks very nice. That blue, very smart. It looks good.
And he has that cap, whatever you call it.
Bandana, bada smart side.
Bandana is really
swag hai.
See the designers. Made on special
order.
आपने वही वाली है तो लास्ट
है मेरे पास वो लंच पे ही खाने गए
अच्छा ऐसे 10 मिनट में
ये शुरू कर दिया बोलेंगे नहीं
पर हम तो एक बार शुरू करेंगे नहीं करेंगे
चार पांच
हेटोलॉजी पढ़ानी है पूरी नहीं हेटोलॉजी सी
तो मैं फिर अच्छे से फिनिश करके
फिर ही आपको दो ना स्टेज क्योंकि मुझे पता है आप लोगों ने तो हटना नहीं है
मतलब कुछ 100 स्लाइड्स है
4-5 क्वेश्चन की बात
नहीं 100 नहीं है 99 है आपको कह रहा 100 नहीं है 99 है
ना वो पता है इतना कॉपी पेस्ट करना मुझे लगता है ठीक है मैम थोड़ा सा तो ओवर डेवलप इंप्रूव था मतलब मैथ वगैरह कम हुआ था
कोई नहीं होंगे वो तो पढ़े लिखे डॉक्टर baby deteriorates and then actually they are not prepared. The longer the patient lives, sick patient,
it happens in cancer also every day because our sick patient becomes okay and they get that hope that okay now cancer is cured and they are living in their good happy healthy life. 2.5 years over, treatment stopped for leukemia and then one fine day it comes back. The day it comes back, our heart crashes as much as theirs because it feels like why did we put in all this hard work suddenly.
My sister-in-law had cancer and she used to say that her oncologist never smiled. He used to cut through dry. So I spoke to my son, Aditya, he's intensive. He said, Mom, oncologists can't be emotional. They have to be cutthroat and dry. And they have to tell the truth. They can't get emotionally attached to each patient. They don't do that work. That, in West we have psychiatrists, support people, we have 20 other people.
Yes.
Oncologists just
The
tell
clown,
truth.
the clown. You know,
Everyone. Is this no
he's the most important part of your team, the clown, who comes and dances every day. यहाँ तो सब कुछ हम ही कर रहे हैं ना इंडिया में.
नहीं तो हम आपस में डिस्कशन करके चले जाएंगे. मैं तो
कुछ नहीं आ गया. I'm looking at Dr. Sushma Kaul's story.
I used to go and meet her every week,
I
twice,
met
thrice.
you a few times in Apollo. जब आप
So
आए थे.
whenever I used to go, she used to tell me, "क्यों आई है इतनी गर्मी में?" I would say, "मेरा दिमाग खराब है." But we were friends from school.
School.
And then she would say, "Tell me, इतने सालों से मुझे जानते हो, what have I done that I
Suffer this much.
nothing? You can't ask questions. Something about destiny." She really suffered.
But she was so
15th
strong.
August. 16 August I was going to Russia. And मैं उसको 14 मैंने कहा मैं जा रही हूँ. 15th early morning, her sister called me out, Sujata. She's very sick. Just go and see her once she's admitted. We're just waiting for her son.
It's amazing, how during between the chemotherapy she would go for rounds.
Oh, she
सुबह सबसे पहले वो राउंड लेती थी. Cannot believe it. What a strong-willed woman she was. मतलब हमने तो देखा है ना उनको. I have accessed her port so many times. तो उनका port access करना मतलब it's not less than a cardiothoracic surgery. मैम तो खुद इतनी she was like pedantic. तो पूरा A सब से वो मुझे देख रही होती थी कि मानस ने hand कैसे wash किया है, glove कैसे पहना है क्या, and we used to do that. But she went through hell.
She went through hell. That's destiny. I had a friend, she was an oncologist. She was working still. Now she's working. So whenever I used to meet her, she used to laugh a lot and used to make fun of everything. So I told her once, I said, Asra, tu bhi cheez ki mazak udayi hai. Because we see
so
the bad
much,
truths of life so often that we feel that there is fertility in everything. We all suffer time.
And ma'am, I'll tell you one thing, pediatric oncology is one thing. Because I have worked with adult oncology as well. The most difficult part is this AYA, the adolescent and young adults. When they have cancer, you have to manage them. They have dreams. उनकी गर्लफ्रेंड्स हैं, उनकी शादी होने वाली है, उनका कोई कॉलेज का एग्जाम है, उनकी जो सफरिंग होती है ना, बच्चे तो सुबह मेरे को क्या चाहिए, वीडियो गेम चाहिए, आइसक्रीम चाहिए, लॉलीपॉप चाहिए, मुझे ये दे दो, इन माय हैप्पी वर्ल्ड करते रहो ट्रीटमेंट. ओल्ड पीपल का ये होता है, चलो भाई मेरी बेटी की शादी हो गई, मेरा ये हो गया. मतलब बच्चों की AYA पॉपुलेशन में जब हम कैंसर देखते हैं, दैट इज द मोस्ट डिफिकल्ट. तो आपको 25 साल के किसी को बताना है that you are not going to live because you have cancer. तो I worked in Apollo with the adult team also for some time. तो मुझे लगेगा pediatric oncology करना आसान है as compared to doing that. हाँ, पर pediatric के तो outcomes बहुत बढ़िया हैं as compared to.
Actually, pediatric oncology एक example है. Even in cancer.
Cancer is curable.
Pediatric cancer में और research भी हुई और पैसा भी लगा. West ने invest किया.
बहुत oncology में तो maximum.
जैसे neonatology में किया. Kennedy के बच्चे की death के बाद they pumped a lot of money into newborns. Surfactant treatment, ventilators, masks.
उस टाइम पे हम सिर्फ किड्स में वेंटिलेटर होता था. तो
You know, I met a guy, Richard Martin. He was the Boston में वो
I met जो उस टाइम पे respiratory therapist था
अच्छा, नहीं, I met this guy. He was the senior resident in NICU. He said that, you know, we said that, you know, he should be taken to space. And Leon Afghan said that, you know, if something is not available in America, it is not available for American children, my child should also.
So ma'am, I also heard this part of the story. When I met the respiratory therapist in Vancouver once, so he said that the new who was in sick kids, they had two ventilators. There were two kids. So he got a call that you need to transfer a ventilator there, but he refused to take the child out.
But you know, Americans tell
Americans tell this.
Richard
So
Martin
because
told me this story.
I also heard the same version.
When
That
Richard Martin,
John F. Kennedy said that, I think it was in one of the papers also, that if my son dies or lives, he will live on the soil of South America, American soil. But I don't know, but
Ganganath Hospital में हमारा एक मेडिकल सुपरिटेंडेंट होते थे डॉक्टर ओपी शर्मा उनके ग्रैंडचाइल्ड को वेंटिलेटर चाहिए था इसमें बत्रा हॉस्पिटल आया था बत्रा हॉस्पिटल में विद्या गुप्ता है बत्रा हॉस्पिटल है उस टाइम डॉक्टर बीके गोरा और डॉक्टर एससीआर है सर हमारे पास वेंटिलेटर न्यूबॉर्न बेबी के लिए हम अपने डॉक्टर के बच्चे को वहाँ बत्रा भेजेंगे After that, I joined. And Dr. Allen ने मुझे एक ही चीज पूछी कि अच्छा can you walk with the ventilators?
वो कर पाओगे?
बस एक ही चीज पूछी.
sometimes the people who are sitting at the top, then unless and until they come across their some relative, even Max also, there used to be Max Saket, Manish will always tell, it used to be a scenario with Manish Saket, no support from the people. Dr. Anand Singh का कोई मतलब उन्हीं family members से very sick. उसी दिन वहाँ पर निकल गए थे लोग.
The biggest NGOs and charities are run by people who have either lost their family member to those illnesses. So हमारी जो सबसे बड़ी charity है which gives all chemotherapy free. कोई भी हमारा कैंसर पेशेंट है अगर उसको कीमोथेरेपी चाहिए आई गेट 100% फ्री is run by the lady who herself is a non-Hodgkin lymphoma survivor. यही लोग रन करते हैं because they have seen that pain.
लैपटॉप रखी हुई इसको तो नीचे रख दीजिए carrying it on my shoulder. मेरा experience about my dog service. ज़्यादा लोग बाहर हाय दीपा क्या हाल है to see you very fine to see you same here same
That should be the particular. We'll show all at that workshop, neonatal workshop, Pcni. मैंने कल न्यूरोलॉजी भी रिवाइज किया. That's okay. बच्चे तो जानते हैं. चाहिए तो अपनी knowledge. That is the best way to learn. It's part of the. He's the HOD and the head of the other unit. He's the overall. Yes. All the best. Morning. It's always a pleasure.
बैठ सकते हैं
हुए थे हमारे इनकम टैक्स में सारी जगह जल्दी लोगों की फोटो आज कर है करना कैसे 100 साल से क्या नहीं 100% शर्त लगा लेते ना पाँच से दो ऐसे नहीं शर्ट मैं लगा रहा हूँ टाइमलाइन नहीं तेरी फोटो की नहीं बात कर रहे हैं फोटो की बात होती है टाइमलाइन कब तक नहीं आएगा मान लीजिए क्या बात मेरी बात ये है कि इतना काला तो कैसे एडजस्ट करोगे मैं समझ रहा हूँ शर्ट तो छोटी सी काला वचन बोला जजमेंट तो सुननी पड़ जाएगी
Very good afternoon. I hope everyone is again energetic and look like they will after having lunch. So let's get ready for another feast by a very knowledgeable talk by on hemolytic anemia. And for this session, I would like Indira Hospital and over to Dr.
Good afternoon and welcome all. Now we have a very good auditor and he's my favorite. I was just thinking that how can I listen to his talk? And he's none other than Dr. Manas Bala. And he's working as a consultant pediatric hematologist at Satyanarayana Hospital. After doing an FNB in pediatric hematology, and he would be speaking on approach to hemolytic anemia.
Thank you, sir. Thank you for the kind words and thank you for the organizers of Pcni for giving me this opportunity. Today I've been given the task of talking about approach to hemolytic anemias. It's a very vast topic, but I'll try to go through some important hemolytic anemias in the next 25 minutes or so and just give you some case vignettes and some basic approach to what a pediatrician should know about approaching a child with a hemolytic anemia. So we all know that a child who presents to us with pallor, jaundice and splenomegaly most likely has an underlying hemolytic process going on. This is the classic triad seen with a hemolytic process, and diagnosing a with this is relatively simple to say that, okay, we are dealing with a hemolytic process. But sometimes the evaluation is very complicated, and just by doing the basic simple investigations, we are not able to reach to a diagnosis. And thankfully, in the last 3 or 4 years, our diagnostics have improved to a great extent, and we are able to pinpoint a diagnosis for most of the patients. The other important clues can be a positive family history of recurrent blood transfusions, a history of splenectomy in the family, splenomegaly, and presence of gallstones in young children. Some children present with severe anemia, and they can have features of severe anemia. They can present with dark urine and are often evaluated by nephrologists for a possible hematuria. They may have left upper quadrant pain because of a dragging splenomegaly. They may have hemolytic facies, but they have never been diagnosed with an underlying hemolytic anemia. They can present with leg ulcers. Dactylitis, different types of crisis, and priapism is also manifestation of a specific type of hemolytic anemia, and you all know that it is sickle cell anemia. This is one of the patients with a chronic non-healing leg ulcer because of a poorly managed hemolytic anemia. So I just go back to the basics and your pathology and physiology days. When we talk about the RBCs which are circulating in the blood vessels, and the RBCs are getting lysed inside the blood vessel. When the RBCs are being lysed inside the blood vessels, LDH is being released, and you have high LDH level in an intravascular hemolysis. Now sometimes the lysis happens in spleen and not in the blood vessel, and that is the extravascular hemolysis, and I'll explain all this in the detail in the next few slides. When hemolysis happens, what is the next step? The kidney gets stimulated, there is more production of RBCs which present in the form of reticulocytes. Reticulocytes are the young RBCs that are released through the bone marrow. Now a low hemoglobin can be seen, elevated LDH is seen, and we see that the reticulocyte count is increased. So this is something very basic about hemolytic anemia. Now let's see this in detail. So we have an intravascular hemolysis happening there and an extravascular hemolysis here. So in intravascular hemolysis, the RBCs are lysed inside the blood vessels. There is free hemoglobin released, and it is picked up by haptoglobin, and that is why the haptoglobin levels are low. In extravascular hemolysis, the hemolysis happens in spleen. You have the whole bilirubin cascade being involved in that, and that is why you see a lot of unconjugated bilirubin, which is not very commonly seen in the intravascular hemolysis. So when we talk about extravascular hemolysis, splenomegaly is common because the hemolysis happens in spleen. We see unconjugated hyperbilirubinemia, we see normal haptoglobin levels, and we do not see hemoglobinuria or hemosideruria. Whereas in intravascular hemolysis, splenomegaly is not that common. We see unconjugated hyperbilirubinemia, which is only mildly elevated. We see hemoglobinemia, and we see low serum haptoglobin level, and you can see hemoglobinuria. So I think this is the most important slide. And if we understand this pathophysiology happening in our hemolytic anemia patient, we can make a diagnosis. At least we can rightly approach towards a diagnosis and then investigate the patient accordingly. So what are the common causes of intravascular hemolysis? You can have complement activation. We have PNH, paroxysmal cold hemoglobinuria, or a transfusion reaction. We can have microangiopathic hemolytic anemia like a DIC, TTP, or HUS. Physical trauma like a heart valve leading to hemolysis, or a toxic microenvironment. Whereas in extravascular hemolysis, the common causes are hemoglobinopathies, enzyme deficiencies, membrane defects, autoimmune hemolytic anemia, and hypersplenism. So if you have to differentiate between the two, you will have a marked elevation of bilirubin in extravascular. The LDH will be high in intravascular. Serum-free hemoglobin in intravascular. Plasma haptoglobin very low in intravascular. Urine hemoglobinuria in intravascular. And urine hemosyphin or presence of schistocytes in intravascular as compared to spherocytes in extravascular hemolysis. Based on this outline, how the hemolysis functions, we now need to understand the types of hemolytic anemia. And this is just the basics, so I will not go in detail. So in the intracorpuscular abnormalities, we have the basic classification, which is available to everyone in all the textbooks, so I will not go in detail. And the extracorpuscular abnormalities are again, highlighted in this classification. You can see elliptocytes, you can see target cells, you can see teardrop cells, you can see stomatocytes, you can see sickle cells, you can see schistocytes, or all these bird cells, helmet cells, and different types of schistocytes in varied types of hemolytic anemias. These are acanthocytes, and these are the classical spherocytes that you see in hereditary spherocytosis. So these are some of the images that we can look at in a peripheral smear, and that can help us make the diagnosis. Now, in most of the hemolytic anemias, you will see these bluish cells in the CBC peripheral smear, and this is called as polychromatophilia. So you might have heard this term that there is polychromatophilia in the peripheral smear. What does this mean? This polychromatophilia means that there is too much retic count being produced. Now, what are retics? Retics are immature RBCs. Retics are not normally counted by a normal peripheral smear. You have to specially ask for a retic count, and we need to do supravital staining to look at the retic count. So, we do a special type of staining. So, please ask for a retic count separately. Otherwise, just by a normal peripheral smear, you'll just hear about polychromasia, which just indirectly tells you that there is reticulocytosis. So this is how a retic count looks like, the reticulocyte looks like when we do supravital staining. It is very important that we calculate a corrected retic count. Now, what is it? So you have a retic count, your hemolysis happens, and you will see that the retic is a little bit increased, or you have whatever number you have of a retic count. Now, this retic has to be matched with the degree of anemia. If you have severe anemia and your bone marrow is working well, your retic count should be very, very high. But if you have severe anemia and your retic count is only mildly increased, that means your bone marrow has not done the job. So how do you practically know whether your bone marrow has done a job or not? You calculate a corrected retic count. So you multiply retic with the hematocrit divided by the expected hematocrit. So for example, a 6-month-old child, hemoglobin is 3 and the retic is 1%. So the normal retic count is 0.5 to 2%. So you'll say, oh, the retic count is normal. That means the marrow is functioning. But that is not the case. Because for this hemoglobin, the retic should have been much higher. So you look at the hematocrit, you know the expected hematocrit, you calculate the value, and your corrected retic count is only 0.28%. So it tells you that your retic is not enough. That means this is not a hemolytic process. This is some kind of a bone marrow failure because of which the retics are not enough in the body. So now I'll just show you some cases and at the end give you an approach to hemolytic anemia patient. So this was just a little background of how we understand the basics of hemolysis, and now with the case-based approach, we'll try to see what all we can diagnose in our patients. So you have a 9-month-old child who presents with poor feeding and fast breathing. There is severe pallor and there is mild yellowish discoloration of eye. There is splenohepatomegaly. Your hemoglobin is 4, TLC is 32,000 and platelet is 1.8 lakh. So in a 9-month-old child with such a severe anemia and a splenohepatomegaly, we should have some kind of idea as to what can happen at this age group that can present with such severe presentation. So you look at the RBC indices. So you now know that this is a microcytic anemia. When we talk of microcytic anemias and we have a splenohepatomegaly and a severe anemia in a young child, we are most likely dealing with a thalassemic syndrome. So most likely this is a thalassemia. your RDW is very high. So what is RDW? It just measures that the cells are all over the place. There are smaller cells, there are larger cells. It tells you the red cell distribution width. So in thalassemia, the slide is a dirty slide. You have cells all over the place. Some are very big, some are very small. And the retic is not very high. Why? Because thalassemia works with ineffective erythropoiesis. Your abnormal thalassemia cells start dying within the marrow. So unlike a typical hemolytic anemia, your retics are not very high in a thalassemia major case. So what is your impression? You have a rough impression in your mind. You look at the peripheral smear and you identify a nucleated RBC. Nucleated RBC is the hallmark of thalassemia major or thalassemia intermedia. You may see target cells, you will see microcytic cells, and you will see hypochromia. So this is a transfusion-dependent anemia, thalassemia, because the child is very, very young. So this is another picture showing a lot of nucleated RBCs. How do you confirm a diagnosis? You do a HPLC and you know that the HbF will be very raised. The HbF would have not gone down. For this, you need to have a knowledge of what is the normal HbF. So at birth, everybody has got a very high HbF, and as we grow up, you know, the HbF level goes down, and by 12 months, the HbF level is less than 2%. So if in a 9-month-old child you have a very high HbF, you are probably dealing with a thalassemia major. This is the normal HPLC pattern, and we may see this, you know, when we are routinely screening children for some kind of an anemia, and we just find a normal HbA and a HbA2 of just less than, I would say, 3% normally, but 3.5 is the usual cutoff for calling it as a thalassemia minor. So if the child has already been transfused, the child was transfused in a peripheral hospital, comes to you, you can't do a HPLC, you have to wait for 3 months to repeat the HPLC because that's the normal RBC life. So how we can do it? We can easily do by mutation studies, or we can do the HPLC of the parents, and if you do the HPLC of the parents, you will pick thalassemia minor in both of them. So we all should know that there is a concept of corrected WBC count, and we need to interpret that in the context of our patient. So this patient with thalassemia had a white cell count of 32,000. That is very high. Somebody would say, oh, anemia, there is leukocytosis, the spleen may cause thrombocytopenia. So you may think, oh, it is a malignancy, it is a leukemia, you need to do a bone marrow. Doing a bone marrow for a thalassemia child would be crying. So I don't want to do that. So I need to interpret why this WBC count is high. That is because the machine does not understand that the nucleated RBC is not a WBC. So all the nucleated RBCs are counted as WBCs, and that gives you a spurious elevation in the WBC count. So you need to look at what are the number of nucleated RBCs per number of WBCs, and just by the simple unitary method, you can calculate the corrected WBC count. Like in this case, suppose the WBC of the machine is 20,000, and the smear shows 20 nucleated RBC per 100 WBC, you can just use the unitary method and say, okay, what is the corrected WBC count, which is not the one that the machine gave you. Or you can use the formula available easily in Google and just put into that and calculate. So now you know what is thalassemia major and how you diagnose it, but it is very important to differentiate it from non-transfusion dependent thalassemia. NTDT or thalassemia intermedia is hugely underdiagnosed. These children have anemia, they have jaundice, they have splenomegaly, they come to you at 6 years or 7 years of life for some cough, cold, and you identify that there is some jaundice and there is a spleen palpable. How do you differentiate between TDT and NTDT? Your HPLC will be same. You know, you will have a very high HbF. Your peripheral smear will again show nucleated RBCs. So you know the picture is very similar, but the differentiation only happens clinically. TDT presents before 2 years with a hemoglobin of less than 7, whereas a thalassemia intermedia presents with a hemoglobin of more than 7 usually, and usually more after 2 years of age. The HPLC is somewhat similar, and that does not help us to differentiate between thal major and NTDT. So after the thalassaemic syndromes, I move on to the second case, which is again another important differential for hemolytic anemia. So this is a 4.5-year-old girl who presents with fever, abdominal pain and yellowish discoloration of eyes. There is previous history of being evaluated for anemia and jaundice. In neonatal history, this baby received phototherapy and the jaundice level was quite high. So neonatologists often have managed these patients in the newborn period for the neonatal hyperbilirubinemia, and later on these children come to us with a hemolytic anemia. So this child had mild pallor, there was a spleen, there was a liver, the weight for and height were adequate for age. So the pediatrician thought, okay, there is fever, there is jaundice, there is anemia. Why can't it be acute viral hepatitis? Why can't it be malaria? Rightly so, these are common illnesses, and we should always think that the common problem are much more common than the rare entities. But this all evaluation came out to be negative. So we looked at the CBCs, the previous CBC and the recent CBC. And something striking was there in both the CBCs, which helped us make a diagnosis, something that we don't look at when we are looking at the CBCs, and we ignore this value. And that was the mean corpuscular hemoglobin concentration, which was very high, a very high MCHC with a splenomegaly, with an anemia in a child, going on for a long time, unless proven otherwise, is hereditary spherocytosis. So concern was given for anemia, and see the hematologist made it look like very easy. There was just one question. The father was asked, and the father told कि हाँ मेरी भी तिल्ली बड़ी हुई है, मुझे भी बचपन में बार-बार jaundice हुआ था. So that was not something that he thought was important to reveal at this point of time. And the diagnosis was made then and there. So this was a hereditary spherocytosis, and we see these patients often undiagnosed or misdiagnosed till very late in age. So the typical spherocytes were seen. The retics are very high, like in any other extravascular hemolysis. There is a long list of DDs of spherocytes in the blood, but we need to fit it into the context of the patient. And by doing an osmotic fragility or an EMA dye binding test, both are available to us in-house. We are able to easily make a diagnosis. The EMA dye binding is more sensitive and specific because osmotic fragility is often associated with many fallacies, and we get a wrong report, and we can diagnose children with hereditary spherocytosis. One difficult hemolytic anemia to diagnose, for which we need to do a bone marrow. We don't do bone marrows for hemolytic anemia, is congenital dyserythropoietic anemia. We see few cases of this illness, and when we have ruled out most of the common hemolytic anemias, we go ahead and do a bone marrow and we can pick CD. The third case is that of a 3-year-old child who presents with pallor and swelling of the hands intermittently. He has 1 centimeter spleen, and this typical history of swelling of the hands. He has seen many orthopods. He's been given a lot of painkillers, analgesics. But when you see spleen, and when you have a history in a young child of painful swelling in the hands, please remember that this can be a serious type of a hemolytic anemia. This is hemoglobin of 7.9 on evaluation, an indirect hyperbilirubinemia. LDH was mildly increased, retics were increased, and when we did a peripheral smear, we identified sickle cells. So in the whole sickle belt, diagnosing sickle is very easy. But with the world becoming closer and closer, and people moving from one region to another, we see a lot of sicklers coming from different areas, and intercaste marriages happening. And now we have started identifying sickle more than previously in our patients. HPLC is a good way to diagnose. The Indian sickle is a mild sickle as compared to the African sickle, and it is because we have a high HbF variant of sickle cell anemia, because of which the severity is mild. Now, because there is so much thalassemia in India, thalassaemic minor parent marrying a sickle heterozygous leads to a sickle beta thalassemia. So that is also something that we have identified in many patients, where one parent was a heterozygous sickle, one parent was a thal minor, and we identified only when the child had a severe disease. So universal HPLC is something that we all should advocate. We should motivate our colleague gynecologists, obstetricians to do an HPLC at the right time for every couple who's wanting or who's in the early stages of pregnancy. Sometimes, rarely, we diagnose alpha thalassemia like this child who presented to us from RMN hospital with a microcytic hypochromic anemia. These children are just, on iron for years together with no benefit. And when you have children with iron who are on iron therapy and they are not getting the desired hemoglobin, a referral to a hematologist is very, very important. It's not a very common disease, but we do, once in 1 or 2 months diagnose a patient with alpha thalassemia. And based on the types, there can be hemolytic variants. With the availability of NGS, we are now being able to diagnose more and more cases of rare hemolytic anemias. Like we just diagnosed this patient, 36-year-old man, whom nobody could identify what type of anemia he had. He had undergone a splenectomy like 20 years back, but still was struggling with some kind of a low-grade anemia. With the help of NGS, we were able to pick. Now, this child is just from yesterday in my emergency, and someone asked me, why did you come late for the conference? Was because of this child who came to us from Agra with a hemoglobin of 3, and you can see the color of urine. Anybody would think that this is hematuria, and the child, but actually the urine RBCs were negative. So this child was on oxygen, was very sick. Within 2 days, became so sick with discolored urine. He was passing. So our DDs were either it is G6PD leading to a severe hemoglobinuria, or it was some kind of a severe autoimmune hemolytic anemia which led to a massive hemolysis. Black water fever, malaria, paroxysmal nocturnal hemoglobinuria. And we are still evaluating this child, and the DCT has come negative. The G6PD is normal, which can happen in these stages of acute hemolysis. The photograph is cut, but this child actually came with a blood bag. So, he had already received 2 units of blood, and that also can be a reason why we could not identify a G6PD deficiency. But you can see bite cells typically in these patients if you see the peripheral smear just at the time of diagnosis. And we all are aware of the drugs that we need to not give. We have identified a few children with pyruvate kinase deficiency. And I was just mentioning that to Dr. Garg the other day, that pyruvate kinase deficiency is one of the important causes which is very easily missed, because you may have some evidence of hemolysis, but all your investigations are normal. NIIH in Mumbai were doing the pyruvate kinase levels, and it was always a struggle to coordinate with them to do it. But now with the help of NGS, we have diagnosed, I think, 10 or 12 pyruvate kinase deficiency patients who present with hemolytic anemia. And this is one of our patients with a clear abnormality in the pyruvate kinase gene. These are schistocytes, and if you see them along with thrombocytopenia and renal dysfunction, you know that the diagnosis is a hemolytic uremic syndrome. And if they present with the classical pentad, the diagnosis becomes a TTP, and it is again a difficult and a challenging disease to treat for a hematologist. The next case, I'll be winding up very soon, presented to us in the emergency with fever for 7 days, cough and cold for 7 days, and again passing of cola-colored urine. There was pain in abdomen, there was yellowish discoloration of skin and sclera, and the child had severe pallor with icterus and had hypoxemia. The differential diagnosis, again like the previous case, was a long list. We identified anemia. We saw high MCV. Now, if you have retics, the retics are large cells. So the Coulter counts RBCs as having high MCV. There was platelet count was okay, TLC was fine. The nucleated RBCs were present. That is why a little bit increase in the RBC count. And then the DCT test was 4 positive. So this is autoimmune hemolytic anemia. We recently diagnosed a Hodgkin lymphoma, which was leading to autoimmune hemolytic anemia. So autoimmune hemolytic anemia can be just present because it is idiopathic. It can be a marker of an immunodeficiency. It can be associated with a malignancy, or it can be triggered by some environmental factors. We do a monospecific DCT for all AIHA patients. And based on the monospecific DCT, we are able to classify them as warm, cold, or a paroxysmal cold hemoglobinuria, and then the treatment is accordingly. Most of the pediatric patients are warm autoimmune hemolytic anemia, which respond very well to steroids. This is a 10-year-old child who had a cardiac surgery, presents with recurrent anemia requiring transfusion. So this is the cardiac valve leading to this hemolysis, and this patient, will have lifelong problems unless the cardiac issue is sorted. So at the end, there was a case of paroxysmal nocturnal hemoglobinuria, but I skipped it. Again, a rare kind of an illness which can present either with aplastic anemia or with hemolytic anemia or with thrombosis. Rare, but it is now, we are now increasingly picking up because of better diagnosis. So if you have a child with a hemolytic anemia, take a good history, do a good physical examination. Look at the lab criteria. Look at the CBC, the retic count, look for indirect hyperbil, and look at the peripheral smear for all the abnormalities that I showed in the previous slides. You may have high LDH or a low haptoglobin. Do a Coombs test. If the Coombs test is positive, we will go into one direction, and if it is negative, it helps to rule out many conditions. So if the Coombs test is positive, you are dealing with an immune hemolysis. For the newborn, you are experts, and you deal with that more than I do. And if it's not a newborn, do a monospecific ECG to identify the type of immune hemolysis. Look at the platelet count and manage accordingly. There can be warm, cold, or PCH as the DDs for autoimmune hemolytic anemia. Secondary autoimmune hemolytic anemia may be due to PIDs, malignancies, or certain types of infections or drugs. If the Coombs is negative, again the PS helps us. In the PS, if you have spherocytes or elliptocytes, please evaluate by doing an EMA dye-binding test or a osmotic fragility. Better to do an incubated osmotic fragility, and you can diagnose hereditary spherocytosis. If you see target or sickle cells, you may be dealing with a thalassemia or a sickle cell anemia, for which HPLC is usually the best way to diagnose the condition. Red cell fragmentation is seen with consumptive coagulopathy, so HUS, TTP, DIC will be the DDs, and if you have some other abnormalities, maybe malaria, sepsis, can be leading to hemolytic anemia in your patient. And if everything is normal, do a G6PD assay. Sometimes it will be negative. Repeat it once the hemolysis has settled, say after 1 month, 2 months, or 3 months. And if it is positive, it is a G6PD deficiency. If it is negative, you need to get opinion from a hematologist, where rare disorders like paroxysmal nocturnal hemoglobinuria may be leading to hemolytic anemia in your patient. With that, I would like to end the talk. Thank you.
Dr. Manas, for a very nice and crisp talk. Hemolytic anemia is very commonly encountered in our day-to-day practice. Now, house is open for discussion, and I would request to organizer, please show the previous slide, because that's very good algorithm he has shown. So, if someone wants to click a pic, he can. If anyone has any query, he may raise his hand, please.
Okay, sir, we can just discuss if there is any question.
Just one question, may I ask?
Just information of all these sections are recorded. They will be on IFP Delhi platform. They can be viewed anytime.
So anyone wants to? Just one question.
Yes, sir.
In G6PD, because you have just shown a case which you just received from Agra,
yes,
and in acute hemolysis, with this episode of acute hemolysis, and you are estimating G6PD, usually these are the neocytes, and they are usually sufficient in G6PD.
That's right.
And on various occasions, we found it is normal, although
Yes.
it is a case of G6PD.
Yes.
So how to actually?
So, sir, it's very difficult to say at that point of time that you are G6PD deficient. It's mainly the history and ruling out of autoimmune hemolytic anemia, paroxysmal cold hemoglobinuria, malaria. So these are the other common DDs which present with an acute intravascular hemolysis. So if you have ruled them out, I would just counsel the parent and say that, we can't make a diagnosis at this moment. Let's wait for a couple of months and then we will reevaluate.
Usually, after 4 weeks, again estimation.
So, sir, if you have received a blood transfusion, for a drastic anemia like this patient who came, with severe hypoxemia, you have transfused 2-3 units of blood. So I would just wait for 3 months to evaluate for G6PD. Let the RBCs go away, and then probably we'll get a good answer.
Thank you.
Thank you, sir.
For such a lucid talk and always he has been a great presenter, and he explains everything so nicely. For the next session is respiratory distress in units, how to make sure they are not intubated. And we are privileged to have Dr. Neelam Clare, Padma Bhushan awardee for this session. She has been the chairman of the Department of Neonatology in Garam Hospital. She has received various awards, Best Doctor Award and so many other awards. And she has been President NNF 2009 and 10. And I would just request her to moderate and chair the session. Dr. Neelam.
I also request Dr. Clare to come on stage because we have some prizes in between to be distributed. So I request Dr. Sonia to come on stage to receive the early bird prize for the EP category. The people who came first today, I mean, being awarded, Sonia came first today into the hall. In the delegate category here, Dr. Neeraj Agarwal is the most attentive person in the whole group, comes first, sits throughout the day and is very attentive. So for Dr. Neeraj Agarwal. All over to Dr. Neelam Clare for the session. You can introduce the panelists.
So at the outset, let me thank the organizers of Pcni for a wonderful conference, and it's very heartening to see after the lunch still many people in the hall. And the topic is respiratory distress in neonate, how to make sure that they are not intubated. So it's a little lopsided topic because intubation is a skill which pediatricians boast of, and so we're going to discuss that how we can make sure that we can avoid intubation. I will say that not make sure that they're not intubated, but make sure that we can avoid intubation. And I'm very glad that I have very capable and very knowledgeable neonatologist who are a panelist with me. And I would like to invite Dr. Naveen Gupta. Dr. Naveen Gupta is working at Rainbow Hospital. And are we going to show his CV or I can just, because I'm sure Naveen needs no introduction. I'm very glad to inform that Naveen was one of our first DLB Neonatology Fellow, and he's right now Senior Consultant at Madhukar Children's Hospital. And he also worked at Vancouver Women and Children's Hospital, where he trained in his neonatology. The second panelist with me is Dr. Kumar Ankur, and I'm sure he again needs no introduction. He's very active in both IAP and NNF, and I'm happy to inform that he also actually, can I move the slide from here? I have, yes, I have. So I think that they are with you only, the CV are with you only? The CV wait there, I'm sorry. So, okay. You have gone behind or what? So the third panelist with me, Dr. Ankur is working at BL Kapoor Hospital, and he neonatal chief at neonatology department at PL Kapoor Hospital. The third panelist with me is Dr. Manoj Modi. Dr. Manoj Modi is DNB in neonatology again from Gangaram Hospital, and it gives me a lot of pleasure in introducing that, all four panelists with me are actually trained at Gangaram Hospital, and Dr. Modi worked at Maulana Azad Medical College after that, and he worked as assistant professor. Then he went for a short stint to Middle East also, and but he didn't like the too much money galore, and he came back again to India, and he joined Gangaram Hospital. He's also trained in functional echocardiography at UK center with Dr. Sameer, and he's one of the very keen teachers, very popular with the postgraduates. And the third panelist, the handsome and the bright Dr. Anu Thakur, is also again a DNP graduate from Gangaram Hospital only. And he also, after doing his DNP, trained at various international centers in non-invasive, in ultrasonography as well as point of care, and in also in functional echocardiography. So with all the four panelists, can I stand here and do it, or should I sit down and then? Doesn't matter, I'm fine. I'm okay. This will be a very different kind. So am I audible? Right. So, as I started and I said that, if I say that, we can avoid intubation in a preterm newborn with RDS, what are we trying to achieve, and why we are saying that we really want to avoid it. So I thought, let's go back to the history and revise the history a little bit. And as you know, that intubation came actually almost 2.5 centuries before we started NRP. And this was this French scientist who devised this long tube which could be passed into the trachea of the asphyxiated or stillborn infants, and they could be revived. And as you can see that at the other end there is a kind of a pump also, so that you could push in air also into the lungs. So in other words, intubation has saved millions of lives, and it's a skill which I think every pediatrician should learn. So if we look at the history of neonatology and we look at preterm babies, you can see that the main survival of the preterm infants started once intermittent positive pressure ventilation became a standard of care. We were just talking and we were trying to revise the history, that how neonatology came into prominence. I was talking to Marx. So when President John F. Kennedy's son was struggling and he had respiratory distress syndrome and he needed a ventilator, the only place in the world where ventilators for the newborns were available were in Canada. And after that, there is a lot of research to promote newborn care, care of preterm babies, and ventilation. Another very breakthrough discovery has been the discovery of surfactant, and the first trial by Fujiwara to use surfactant in the preterm babies. Synchronized ventilation and use of antenatal steroids got approval by FDA in US in 1990.
And with this era of beginning of mechanical ventilation, some use of surfactant, and availability of synchronized ventilation and antenatal steroids, we could save many extremely low birth weight babies. But everything comes with a price, and with increasing number of saving preterm babies and with increasing use of mechanical ventilation, what happened was lung injury. And that led to chronic lung disease and PPD. So we started getting more and more incidents of PPD. So, as they say that, necessity is the mother of invention. And when mechanical ventilation was supposed to be, sort of more associated with chronic lung disease, came the vogue of non-invasive ventilation, and large trials like POINT trial came, the concept of gentler ventilation came so that we could avoid the injury to the lung. So when we are saying avoiding intubation is avoiding injury to the lung. And then came the largest trial on caffeine, the CAP trial, which proved that caffeine was a safe drug, and not only that it helped with reducing the ventilation and mechanical ventilation rates, but also that it was neuroprotective. Use of postnatal steroids to limit the mechanical ventilation. And with increasing use of non-invasive ventilation, we realized that where do we fail with non-invasive ventilation? It's the smaller babies, the babies who are less than 28 weeks. So is there a way we could non-invasively provide surfactant to these babies so as to protect their lungs? And at the same time, we can avoid mechanical ventilation. And other methodologies of giving non-invasive ventilation, non-invasive surfactant came into vogue. So you can see that, if we are talking about avoiding ventilation, avoiding intubation, we are probably talking more than half of the neonatology. And that cannot be dealt probably in a session, even if it is 1 hour long. No, it's not 1 hour, it's 35 minutes, right? So I'm going to shoot a few questions which are going to answer at every aspect, that how can we avoid ventilating a preterm baby with RDS. So let's start with prevention. And as you know that, apart from, sending your preterm babies to a center where they can, to a perinatal center where they can be taken better, they can be given better care and survival is better. One modality which has really made a major indent in the survival of babies with RDS is antenatal steroids. So, antenatal steroids way back started by Liggin, Professor Liggin in 1972, used in the preterm labs, found to be effective in improving the maturity of the lungs. So, we've gone a long way from 1972. So, Dr. Naveen, what do you think is the optimum use of corticosteroids, antenatal use of corticosteroids to manage or prevent RDS in preterm babies? What are the best gestation, where it should be used, and which steroids probably are best to be used?
Thank you, ma'am.
I'm sure there are no obstetricians, but obstetricians always ask neonatologists. At least at our hospital they do.
So, thank you, ma'am. So, when it's a panel for avoiding intubation in the preterm babies, I think antenatal steroids, they are one of the key interventions that have changed the outcome of these premature babies when we look at last 30, 40 years. As ma'am rightly pointed out that Professor Graham Liggins, when he discovered in the sheep model that antenatal steroids, they were, so basically he was, this topic was this regarding the delivery of the sheeps, and he found that they accelerate actually the lung maturity. So then steroids were all over the place, and there have been many RCTs which have been done, and nobody can debate about this, that 24 to 34 weeks or 24 to 33 plus 6 weeks, all the guidelines, they suggest that whenever a woman is at risk of preterm labor, she should be covered with antenatal steroids, and they have a lot of beneficial effect on the premature delivery which is happening on the baby. So beneficial effects in the form of decreased incidence of respiratory distress syndrome, decreased necrotizing enterocolitis, decreased intraventricular hemorrhage, and decreased mortality. So what antenatal steroids have not shown so much benefit is that they don't decrease the incidence of bronchopulmonary dysplasia. Now, for these premature babies, there is no debate. Now, in the past few years, what every unit or every neonatologist is encountering is that the late preterm babies, this entity between 34 to 36 plus 6 weeks, so they are also having a lot of problems with the respiratory distress because there have been a lot of incidence has increased of C-sections, so transient tachypnea of newborn, and sometimes they have malignant transient tachypnea of newborn, they have PPHN. So people have looked into this, that steroids, even at this gestation also, they will decrease the risk of RDS. So one society like American College of Obstetrics and Gynecology, they have come up with their statement that antenatal steroids can be given between 34 to 36 plus 6 weeks, provided that woman hasn't received steroids before 34 weeks, provided if she is at risk of preterm labor and she is having choreo, there is no tocolysis is given to cover her with the steroids. This I am talking of 34 to 36 plus 6 weeks. So then steroids can be given. RCOG is the European Society of the Royal College of Obstetrics and Gynecology. They have come even one step ahead that if even before 39 weeks, the women who the obstetrician plan to deliver elective C-section, then also steroids can be given. When we talk of Indian guidelines, the Ministry of Health and Family Welfare guidelines, we stand till 34 weeks, we need to cover the women at risk of preterm delivery with the antenatal steroid. The another question is that which steroid should be given, betamethasone or dexamethasone. Normally in the West, betamethasone is the preferred steroid, but we don't have the same salt or same molecule of betamethasone which they have. So in our country, dexamethasone is the steroid of choice. The 4 doses of dexamethasone should be given 6 milligram each dose, 12 hourly apart, intramuscular, and the last dose should be preferably covered 24 hours before the delivery, so that we can say that the women is completely covered with steroids and they will have the maximum benefit on the baby.
So in other words, we say that the ideal time is any time even less than 28 weeks to 34 weeks, provided the labor is going to happen within 24 hours and the effect is up to?
The effect is till 7 days. The maximum effect is seen till 7 days.
7 days.
And one thing I forgot to mention is that previously it was a debate that whether less than 25 weeks or so the steroids they work or not. Now in one meta-analysis it has been seen that they work even at the earlier gestation also. And when people were previously very apprehensive about the long-term effect of these steroids, at least a single course of steroids, even when these kids they have been followed up with long, it's not going to show any bad outcome. The repeated course next.
Yeah. So you're trying to say that even if the fetus is less than 28 weeks, it's 25 weeks or 24 weeks, and there is an impending labor, you think that the woman is going to deliver a preterm baby, it's an opportunity to give steroids, whether you're giving dexamethasone or betamethasone, and according to the availability. But tell me something, if the woman is fully dilated, and your obstetrician says that, whether I should give or I should not give, is there any advantage of giving?
So there is as such no, if the woman is fully dilated, I don't think so that we can prolong the delivery now. Eventually the fetus will come, but she can give one shot.
So anybody would like to respond?
I think if the patient is between 34 to 36 weeks, the evidence suggests that if the patient is in the labor, don't delay the labor, don't stop the labor, give the steroids.
Give a steroid. Yeah. So what I'm trying to ask is that even if the woman is fully dilated, tell the obstetrician to give 1 dose of steroid, use Maxserve, because use that opportunity. Because they may not be 100% effective, but some effect, some advantage probably can be drawn.
Yeah.
Second thing, you said that in late preterms, 34 to 36 weeks, but ACOG and RCOG have some reserved guidelines. But we know that risk of hypoglycemia is more, We know that we don't know about the long-term effects of steroids, and also that the NNT is really 20 babies, 20 fetuses you treat, one baby is affected. So rationally speaking, do you think that in late preterm pregnancies or in 34 to 36 weeks, is it okay? Because Ministry of Health doesn't give, but I know a lot of obstetricians do give, and I'm sure in the audience also a lot of people would say that a lot of people do give, especially if it is elective C-section. So, rationally speaking, you think?
I think, ma'am, that I try to highlight also, and that's what Ankur was saying, that less than 34 weeks, even we will try to prolong the labor. Suppose the woman is not too much in the active labor, we will try to give glycolysis so that we can cover her with the steroids. 34 to 36 weeks.
So use of tocolytics, yeah, you're right. So use of tocolytics to buy that time so that you can use another dose, you can use a dose of steroid and have prolonged the effect.
But after 34 weeks, there are two conditions that are very, very important in their guideline. That one is, suppose the woman has received steroids at 26 weeks and now she has reached 34 weeks, then there is no point for the 34 to 36 weeks. Second is that if she is in active labor, no point in giving tocolysis, just only to cover with the steroids. The third is, as ma'am you rightly pointed out, that there is risk of hypoglycemia. We don't know the long-term outcome, and the third is we don't know what happens in our country. So there are WHO trials going on, the antenatal, the ACT trial, and those trials they are going on, and maybe then we will have few more answers.
So I would request that if audience have any question in between, because we have half of neonatology to cover. So if you have any questions, please write down and pass on so that we can deal with them. So Dr. Manoj, all preterm deliveries may not happen when they are impending. So many times, 7 days pass or 2 weeks pass and the woman is again impending, is threatened with preterm labor. So what is the role of rescue dose of steroids? Do you advocate or not? With short evidence.
So as you had highlighted rightly, idea of repeat doses came by the observation that maximum effect of steroid is when it was given within several days of delivery. And observation was that more than 50% of babies remain undelivered even beyond 14 days of receiving steroids. So perhaps the benefits were not maximum when they were being delivered. So there came the role of repeat dose steroids, and we have already had almost half a dozen of recently planned trials, and results of those are available to us. And if I look at 2010 and 2015, as all of us were encouraged because we had early results of those trials where outcomes had neonatal outcomes and outcomes during early infancy were really promising. But when we followed these trials beyond early childhood, then perhaps we are not that much encouraged. And I have this list of major trials in this slide. One from Australia, where if repeat dose steroids were given to eligible pregnancies, there was reduction in early morbidity, there was reduction in RDS, there was reduction in serious morbidity as well in this trial only. But if we look at their birth centile, they were dropping their birth centile, which actually caught up by the time of discharge, but there was some reduction in fetal weight if they received repeat doses of steroids. But there were no significant benefit in any of the relevant outcome, which we say death or morbidity, or which we say long-term neurological outcome, which was followed up to 6 to 8 years. There was no benefit whatsoever. And in fact, there were some concerns, like babies who received the preterm babies who received repeat doses of steroid, there were more cause for their cognitive assessment. I don't say that their cognitive outcomes were worse if they were assessed objectively, but there were more cause for their assessment from their teachers. Right? So there was some question mark rate over there.
Right. So would you agree with me that giving one Yeah, one rescue course, that too before 32 weeks.
Yes, ma'am.
Is something
So
which
perhaps like that has built in a bit of vigilance and current stand by most of national bodies. So if we come to guidelines, as of now, the guidelines say one course of antenatal steroid can be given to neonates who are less than 34 weeks and who had received antenatal steroids 2 weeks back. So there is one rescue dose.
one rescue dose
can be
is.
given.
So if your obstetrician asks you, you can give one rescue course, especially if it is before 32 weeks and 2 weeks have passed before. So let's say that, we couldn't prevent a preterm labor and the preterm baby is born, and we usually preterm babies say that, we usually support their respiration instead of, sort of actively trying to do interventions. So you have different choices of devices in the labor room, and if you're resuscitating a preterm baby and you have a choice between the TPs and self-inflating bag, which is the better one if you have to use for positive pressure ventilation. And also, if you could just say that where would you like to start positive pressure ventilation? I know you've done a trial on TPs versus, so you would be having a lot of knowledge, but if you can shorten up the knowledge and just give us a sharp message as to which is the better device.
If you look at the evidence, ma'am, this was a trial which we did in our hospital and was published in this station. And we found that TPs helped us to decrease delivery of intubations both in term and preterm infants. And especially in preterm infants, babies who were resuscitated with TPs, they required lesser invasive ventilation. So it was beneficial in both terms and preterm babies. This TP is the advantage of delivering consistently and we cannot deliver consistent PIP with a self-inflating bag. If we look at all the evidence which has come up, although the ILCORE committee still in 2020 says that there is still lack of data to say that this device, one device has to be preferred over another. Now, there's a recent meta-analysis which has been published, which has taken all the trials together. And look at the outcomes, if you take all the neonates, it helps to decrease the need for intubation. And in preterm neonates, the observation study, which has almost more than 1,000 of babies, it shows that it is better in terms of cerebral discharge, to decrease intubation, and also to decrease chronic lung disease. Although the same has not been replicated in randomized control trials or positive randomized control trials. So still, the form is still open. It's not a closed question. In this case, in preterm babies, I would like to have a TPs if it is available in our unit, because it helps me to provide constant PAP. It helps me to give CPAP, and it might prevent intubation and maybe.
So can I ask in the hall how many people still use self-inflating bag and how many? I mean, those who are using self-inflating bag in your practice for the resuscitation of the newborn. Everybody is using TPs. So it seems that most of the people are using TPs. So, as I said that, in preterm babies, when we are resuscitating, most of the time, most of the preterm babies, they would have some respiration. They would have some whimpering cry also. And many a time, what they need is a little bit of support only, because their alveolization has not yet occurred, and probably they don't have sufficient effort or sufficient to breathe properly, and they just need a little bit of support. And you have different devices in the labor room to support the respiration of a preterm baby. So what is the role of delivery room CPAP in stabilizing the preterm infant and prevent intubation? Because that is the earliest opportunity you have to prevent intubation in a preterm baby is by, especially a baby who's already breathing, by providing some kind of non-invasive ventilation support.
True. So once you are going for resuscitations,
my panelists are really, I think they need a little coffee probably.
No, it's okay. I think so. Once you go for the resuscitation in the liver room area, so as per the NNF guidelines for attending resuscitation, we ask only one question, irrespective of the gestational age and the maturity. So if the baby is breathing or crying, you continue routine care, routine care include the delayed cord clamping for 60 minutes, 60 seconds. And then if any of the preterm who develops respiratory distress soon after birth, then you have two options, whether you want to intubate the baby or you want to give a non-invasive CPAP trial. So there are various trials which have found that, next slide. So these are three landmark trials, that is a COIN trial which was done, published in 2008, then support trial in the year 2010 and another one trial in 2011. They included almost between 24 to 29 week baby and all were less than 1250 grams. And all of the trials have used the CPAP of 5 to 8 centimeters, and what they found that then if you use fair amount of CPAP right in the delivery room to avoid intubation, you can prevent intubation rate in the range of 30 to 40%, and ultimately you can decrease the chronic lung disease and BPD in the range of 10 to 15%. What ma'am was telling in the initial slide, that the survival is not important, only it is the intact survival, and especially the lung and the brain, the two organs are important for long-term survival. So we should give a fair trial of CPAP right in the delivery room. By that way, we can prevent a lot of intubation and even surfactant delivery also, and probably chronic lung disease and neurodevelopmental impairment also.
Yeah, so all of us agree that if we start CPAP early, whether with the face mask or with the nasal prong, any interface we use, we can prevent intubation. But there will be some babies who will fail intubation, and probably smaller and more preterm the baby, more is the risk of failing intubation, failing the non-invasive ventilation. And probably these are the babies where you also want the advantage of giving surfactant. So as you said that, there is a rule of 30 that, if the baby is failing on CPAP on a FI2 of 30%, or if the baby has increased work of breathing, or the baby is apneic, then probably you have lost the opportunity, and probably that's the baby who probably would require intubation. So, if you see last 5 years, I think, there has been a modality which has been discussed among the neonatologists, and that is the sustained inflation. It is actually a way of providing positive pressure breaths, which is like to the tune of 20 to 30 centimeters for 10 to 15 seconds, so as to prevent intubation. So which is called as the side breaths or sustained inflation. But a lot of trials have come up, and I'm sure you're going to discuss a lot of trials. But one big trial, if you could focus just on the SAIL trial, which really looked at large number of babies, if sustained breath or sustained inflation could really cut down the risk of intubation and mechanical ventilation. Did it prove or disprove, and what is the status of using sustained inflation?
CPAP versus intubation in the delivery room, the CPAP comes out as one modality which decreases the bronchopulmonary displacement. But this intervention was done between 25 to 28 weeks. So what they found was that in the CPAP limb, eventually 50% of the babies, they were intubated, right? So roughly, in all the studies. So people were trying to find out that any intervention in the delivery room which actually efficiently distends the lung, which prevents the intubation. So sustained inflation in the first few studies, smaller studies, it comes out as a promising intervention. But then a very large study was done. It was by the name of sustained inflation of infant lung, that is the SAIL trial done by Dr. Harish Kriplani, and in which approximately 18 NICUs in 9 countries were enrolled. Very, very small babies, 23 to 26 plus 6 weeks were enrolled, and they were eligible if they require positive pressure ventilation because of inadequate effort or heart rate less than 100. So one was the standard resuscitation approach, which was intubating these babies. Second was providing them with the sustained inflation, and that in their study they defined that providing a peak pressure of 20 centimeter water for 15 seconds with the help of DPC resuscitator, and then second inflation of 15 seconds at a peak pressure even more than 20, that is 25 centimeters. So the primary outcome was whether there is a difference between the death and bronchopulmonary dysplasia. So primary outcome was the same. But in this study, they initially they initially thought of a sample size of 600 babies. So when they look at the intermediate analysis, when they looked at one outcome, that was death within the first 2 days. Death within first 2 days was more in the group in which sustained inflation was given. Although all the authors, they could not cite a reason, or they could not think that how physiologically this intervention can lead to death within the first 2 days. But since the number of babies in sustained inflation group were more, in which death within the first 2 days was there, so the trial was primarily prematurely halted. So at this stage, because they did the trial in approximately 460 babies, and in that also there was no difference in the primary outcome, that is death or BPD, and mortality within first 2 days was more in the sustained inflation group. So where we stand today is that it is no longer a standard of care. So in the delivery room, again we have simple interventions like either provide with a good CPAP, and the babies who are apneic or who are failing on the CPAP, just treat.
Right. So sustained inflation could not do its role, and this is example of one strategy which looked attractive but probably did not prove. Since there is shortage of time, I'm going to skip few of the questions with the permission of the panelists and the audience. But we're going to sort of rotate them. If we have time, we can come back to them. So non-invasive ventilation does work, but in some babies, especially very small babies, it may not. You may have failure to CPAP and you may have to intubate. You may have to intubate in the delivery room, or you may have to intubate later in the NICU. So what are the indications of intubation in the delivery room or the CPAP failure? And while you're on that, also let us know that do you use that opportunity to give surfactant in the delivery room? Because I know most of us don't give surfactant in the delivery rooms with some fear.
Well, there are two aspects in this question. One thing is decision for intubation in the delivery room, and next thing is while ongoing care, decision for baby in NICU during early hours of the day. So decision to intubate in the delivery room would largely be guided by baby's breathing efforts and stability overall. When I say stability overall, that is how the baby's heart rate is behaving. So this is a baby extremely preterm. If this baby might seem happening like that, but might not be breathing at all or breathing barely at all. So many of us might get panicked at that point of time. Oh, this baby is not breathing. I need to intubate this baby. But most of people feel like that they would give a fair trial of resuscitate this baby with a mask, with face mask device. They could resuscitate the baby with the help of PCs.
Right.
And would be giving the baby puffs or CPAP, and with close monitoring what is happening to baby's heart rate. If baby's heart rate is picking up over next minute or two, perhaps we would be waiting rather than intubating this baby. But if heart rate is going down, despite your quality resuscitation, that the baby would be a candidate for intubation. And if we go back to another aspect, that is intubation in NICU, perhaps guidelines are not very robust. Most of us.
Right. Something gone wrong. So, in nutshell, in the delivery room, if your CPAP fails or the baby is apneic or having bradycardia, you have to intubate. And if ever you intubate a preterm baby, you should use that opportunity for using surfactant. So let me ask the audience just a straight question. How many of you give surfactant in the delivery room? At least Amit must be giving in the delivery room, no? Yeah. So I think most of us are little shy of giving surfactant in the delivery room because we feel that we do not have the support of personnel, or we are more confident in giving surfactant in our own arena. And most of us are very close to the delivery place also, and we feel we go fast to the NICU and give. I'm going to switch the question. So Dr. Anoop's question, I'm going to ask Dr. Ankur. Yeah, please.
So for the delivery room surfactant, but like I don't have this published data, but I have seen is that for these very small babies, if we intubate them in the delivery room and we shift them to NICU, no matter how fast we try, but there is a time gap which is there. So at least in our unit for babies who are less than 26 weeks, when they are intubated in the delivery room, we are giving them delivery room surfactant.
Right.
Yeah, we can, but just yeah. For these very smaller babies, yes, we are.
No, actually the dictum is this only, that if you have a baby who's 27 or less than 27 weeks, even few minutes also make difference. Few minutes of positive pressure ventilation make difference. So you should give, and that is why we carry surfactant to the delivery room. So in that case, we should give surfactant in the delivery room.
But many a time we have to keep a vascular access first to prevent hypoglycemia rather than.
No, of course we should, and that is why one person is not sufficient when you are resuscitating. So probably you need to have the peripheral line because UV will take time. Once you set in your line, then probably I think, and if you have intubated the baby, then probably the best scenario would be to give surfactant. So Dr. Ankur, your question I'm going to ask Dr. Anup and Dr. Loops to you so that you speak less. So Dr. Anup, what are the current guidelines to give surfactant? Where do you use the early versus the late rescue therapy?
Yeah, so
and to the point.
Currently, we are using European guidelines to give surfactant. So all babies who have respiratory distress at birth should be given a fair trial of CPAP. You can start with 5 centimeters of water, 5 to 6 centimeters of water, and if the CPAP trial fails, which the European guidelines have defined as 6 to 8 centimeters of water and a FiO2 of more than 30%, then you should consider surfactant dose. So is that simple? And the second part is whether we should give early or late. Of course, we should give surfactant early. So less than 2 hours is something which Dr. Abhi is telling, because that is what been taken as a cutoff in most of the studies to define early rescue. So we give surfactant early, less than 2 hours, that's for early rescue, and that can that is beneficial in terms of preventing respiratory failure and so on. So that is one thing which should be.
So Dr. Ankur, we have different modes of non-invasive ventilation. We have the most popular humidified high flow nasal cannula, through which we give CPAP also, and we give high flow oxygen also with some PEEP. And we have those sophisticated non-invasive NIV delivering ventilators also, where you can provide them non-invasively positive pressure breaths also. So between these, if you have to choose what is better, what is best, in reducing the risk of intubation and mechanical ventilation.
Broadly speaking, we have
without evidence,
three modality. One is heated humidified high flow nasal cannula, second is CPAP, and third is NIV, where you want to prevent the intubation. So broadly speaking, if your infant is more than 28 weeks, you can give a fair trial of heated humidified high flow cannula. If the FiO2 requirement is generally less than 30%. If the work of breathing is high, because you quantify the respiratory distress on the basis of Silverman-Anderson score or Downey score. If the score is high, especially in the preterm more than 3 or equal to 3, you give a fair trial of HHFNC. Or if it fails, like in 25% case it can fail, then you can give again a fair trial of CPAP. And if CPAP fail, as Januk told, that after 30% of requirement and the peak requirement is more than 6 centimeter, then we call it as a CPAP failure. As far as NIV is concerned, recently we are giving a different way of surfactant, like LISA technique. It's a less invasive way of giving surfactant. What studies have found?
We need LISA for
I'm just talking about not LISA. Just for giving LISA, you try to put the baby on nasal IV rather than giving CPAP, because the predictors of failure of LISA is more if you give an IV. I mean, if you are giving CPAP and continue giving surfactant through that too. So third, if you have already intubated the baby and given the surfactant, so post-intubation you should give a trial of NIV, because again you can prevent the re-intubation rate of in the range of 30 to 40%. So preferably gold standard would be CPAP, HFNC if the more than 28 week FiO2 requirement less, and NIV post-intubations or before giving LISA.
So as a primary mode, CPAP to prevent in the labor room or in the delivery room. Post-extubation,
NIV. NIV is better than CPAP and CPAP is better than the dehumidifier.
And if you're giving long term, then probably high flow is our best bet because everybody loves that.
Yeah,
The
that's
nurses
true.
love that,
Yeah,
probably
so
the
they are
babies
patient-friendly
love that, and we are very happy that babies on just humidified high flow nasal cannula. It goes on and on for a long time. Right. So anybody in the audience differ or has different views or would like to express their views? Otherwise, we'll go to, as we said that, we want to give surfactant. It's the babies less than 28 weeks where we want to give them the benefit of surfactant. But at the same time, we don't want to put them on mechanical ventilation. So we are trying to find a modality where we can non-invasively or least invasively, without intubating for a long time or without intubating, we can provide them with the surfactant also, and we can get the advantage of not intubating them also. So could you elaborate, Lisa? And Lisa sounds like a film star screen. We have very little time, so you just
30 seconds.
yeah, 30 seconds, and we have the buzzer going on.
So Lisa is less invasive.
After the buzzer, we can take 5 minutes.
Lisa is less invasive surfactant administration. So CPAP is very good, but there is a proportion of babies who on CPAP will eventually require intubation and surfactant. Surfactant is another medication in neonatology which has been extensively studied, and nobody doubts that surfactant is very, very good. The problem is with the delivery of surfactant, that when we intubate the baby, a lot of inflammatory markers are released and mechanical ventilation is continued, and that doesn't lead to decreased bronchopulmonary dysplasia. So that's the thought process. So first comes the ensure, in which you intubate the baby, give surfactant, and you rapidly extubate the baby. But there also, for the Pcni airway, you are intubating suppose with a 2.5 millimeter tube, and the outer diameter of that is 4.1 millimeter. So it's a lot of and you have to provide positive pressure ventilation. So Lisa is some technique in which you allow the baby to breathe spontaneously. The child is on CPAP and he is breathing spontaneously, first 4. Second is to deliver surfactant through a very, very thin catheter. What are the types we can discuss? And third is we can avoid the mechanical ventilation. That's what everybody wants. Nobody wants himself or nobody wants the baby to get tube. So these are the things. So Lisa has come up in the last 15 years. It originated from Germany, and then the trials were done. And now when we look at the whole meta-analysis, Lisa has again come up with a strategy which decreases the bronchopulmonary dysplasia in the very, what we are talking of, these are very, very small babies, 25 to 28 weeks.
And breathing.
And spontaneously breathing baby who are on CPAP. So this is not the technique that for 34, 36 weeks baby who is very fighting and we try to struggling and we try to give Lisa. So that's why, so these are very small babies who struggle very less. So 25 to 28 weeks baby, they have come up that bronchopulmonary dysplasia is less and intracranial hemorrhage is less. Now there are certain unanswered questions. One is that what is the long-term outcome? Second is how much analgesia and sedation is required, but because what we are afraid of is, like before Ensure, we used to give that, okay, we will give fentanyl, or some people will give ketamine or propofol. Mostly they'll give fentanyl, but the problem is that may take away the breathing drive of the baby. So there is a role for this. The problem while doing the Lisa procedure is that 10 to 30% of the kids, they may desaturate, they may get into bradycardic, they may get apneic also. So when you are giving Lisa, so in Lisa what we are doing is that a thin catheter, it is under the direct laryngoscopy, it is being passed through the vocal cords 1 to 2 centimeters beyond the vocal cord, and then surfactant is given. Right. So majority of the people, they take out the laryngoscope because it's not so good that the scope is there only. But there have been few people who have done it under direct video laryngoscope also. The problem which we encounter is that the surfactant may reflux, the surfactant may come back, or the baby may get apneic bradycardia. So these are the problems which we need to take care of. So in a nutshell, this is Lisa. So if we are doing with a soft tube like the feeding tube or the umbilical catheter, we have to get used with the Magel forceps. But if we are doing like there are commercially available catheters now, Lisa Cath in Germany or in India, it is the Surf Cap. Wagon is making it, in which there is a last end is stiffer and it can be angulated also.
So
Right.
depending upon
So
your
Lisa is different. Though the name is very fancy, it's difficult and it can be used in very small babies for breathing, but don't struggle too much. And you require a skill. Dr. Manoj, are there some easier ways? We are very good at nebulizing. We nebulize our bronchiolitis patient. Can we nebulize the surfactant? Along with that, give some steroids also. Nebulization has anybody done? Is there any future for that modality?
Well, ma'am, there have been a couple of other different way of giving surfactant non-specific. One was giving interferentially, but carrying more of a historical interest. There is not much of data on that. Not even stand to start. Another was nebulization, and third is LMA. With LMA also, like there is not much data available. Very few or three small studies available. So that concept is still immature. But has matured little more is nebulization surfactant. And there have been 2 or 3 studies, RCTs.
There's one very interesting study by Dr. Ye, I think more than one, and there is one which is undergoing, giving both surfactant as well as giving 2 doses or more if required, and giving butyronicide by nebulization, and the effect on the mechanical ventilation, based on mechanical ventilation and CLD have been seen to be. So maybe in future we'll have some other modalities. Now, once the baby is on the mechanical ventilator and is receiving mechanical ventilation, we usually struggle that, which is the best way of ventilating, volume targeted, high frequency ventilator and others. But we come to a crux, which like over the years now we have sort of gathered that, no matter which mode of ventilation you use, what is important is to ventilate our babies gently and accept some degree of hypocapnia because that is safe and is not bad for our babies. So this is probably the last question to Dr. Anup. That just give us I know it's a huge topic, but just give us in 2 lines that what do you think about the concept of, so that everybody goes home with the concept of gentle ventilation and accepting hypocapnia.
So, obviously, hypercapnia allows us to deliver lesser pressure, and that is why it's been so popular, so that it can cause less lung injury. Now, as per practice, yes, it is practice, and most trials accept a CO2 up to 65 milligrams, support trial, CON trial, all the trials. As per evidence, the largest trial, the LV trial, in extremely low birth weight babies was actually stopped because there was high mortality in the higher CO2 group, and there was grade 3 and grade 4 IPH. Although it was not statistically significant, but the trends were in those particular direction. So yes, more of the practice right now. I mean, we practice progressive hypercapnia, but the evidence right now suggests that it might be harmful, especially if the CO2 levels are very high.
What is the
These are the cutoffs which were taken in the LV trial. So if you look at first 3 days, they have taken a cutoff of 65. Beyond in 2 weeks, they have taken a cutoff of 75 millimeter of mercury. So with this kind of CO2s, they found there was increased mortality and increased grade 3, grade 4 IPH in the high target. And there was no reduction in BPD, rather the reduction in BPD favored the control group. If you look at the targets of the control group, even their CO2s are actually pervasive hypercapnia, which is more than 45 millimeter of mercury. But still they have kept the higher range below 60.
So if you have to give a range, safe range, what is it? Because like in older time, we used to say that up to 10 kPa is safe, which is I think around 65.
Yeah, so most trials support point, they have taken up to 65. So that would what we also accept in our union, that 45 to 65 is fine.
65 is a safe range.
Probably.
Yeah. So I have to just ask the organizer, can we take just one question or we can? Yeah. Organizers are very kind. So Dr. Ankur, there are 2 more, there are not many drugs used in neonatology actually. We have either steroids or caffeine, nothing else, or antibiotics of course, tons and tons of antibiotics. So 2 more things which really help in prevention of intubation or decreasing the days on mechanical ventilation or reducing the chronic lung disease are caffeine. And caffeine became very popular after the CAP trial. So don't tell us the full CAP trial, but some excerpts of CAP trial. And just tell us that how caffeine and postnatal steroids help in cutting down the days on ventilator, extubation,
and the risk of chronic lung disease. I mean, these are the three things we are looking at.
So, when we are talking about the infants who are less than 29 weeks, or especially those who are less than 1,000 grams, where they have the risk of developing chronic lung disease. So, CAP trial is one of the landmark trials where they have found that the caffeine is important to prevent the apnea of prematurity, but they don't have the direct effect on the lungs or the brain. But they have found that those people who received caffeine, they required lesser ventilator pressure, they required lesser intubation rate, they require lesser duration of oxygen. We know that all these can lead to chronic lung disease and ultimately neurodevelopmental impairment. So AAP has concluded that yes, caffeine is the drug of choice for the apnea of prematurity, especially.
You're a little behind, Alpha, because you're
Especially the infant is less than 29 weeks and required some invasive ventilations. And if the baby is already on some non-invasive ventilation, we can also continue on caffeine. But there is no rule of prophylactic caffeine, especially if the baby is no more than 29 weeks. So we should have a consensus of starting caffeine, but we don't know when to stop. So there are a few trials going on. We did also one study at our place. We found that there was no difference, but the sample size was small. The second is postnatal steroids. We have already discussed about the antenatal steroids. Postnatal steroid everyone hits, but all of us are using, especially 10 to 15% of the very low birth weight infant may require postnatal steroids. Because if your baby is required ventilation for longer period, we use especially late steroid treatment. Late means if you are using beyond 7 days, and especially those who are evolving, having a risk of evolving BPD. So we can use steroid in a lower dose as a DART regimen to prevent intubation rate and long-term established BPD. I think we have to stop there, Dr. Pankaj is moving
right.
on. So. Yeah,
Right. So, sorry for the and thank you for the patience. So, just to wind up that. We can prevent intubation prophylactically. We use antenatal corticosteroids. We use early CPAP. We use early surfactant, whether invasive or less invasive methodologies, and we reduce the days of mechanical ventilation by use of gentle ventilation or by use of drugs like caffeine and if we are pushed against the wall, then postnatal steroids. But also we should not forget that we have to provide them adequate hydration, temperature within the thermoneutral range, and we have to provide them with antibiotics in case they develop infection. So with that, thank you very much for giving us the opportunity. Thank you very much to the panelists for excellent discussion. And I'm sorry for the next speaker. But thank you very much for your patience, sir.
Thank you, Dr. Neela. Next talk is on live hepatitis A vaccine. And speaker is Dr. Upendra. And to chair the session, I invite Dr. Ravinder Gaba and Dr. Naveen Rana. Dr. Gaba is a senior pediatrician from West End. He has been executive board member of Central Health for 2 terms, and he is the president-elect of West End, and he is owner and director of Genesis Hospital, West End. And Dr. Naveen Rana, he is the president of IFP North Delhi and IFP Rohini Zone, and he is the owner director of Savitri Hospital. So over to you, Chairperson.
Good afternoon, everybody. I invite Dr. Upendra. He comes from Navi Mumbai. Excellent orator, excellent academician. Everybody knows that. And today he is going to discuss about live hepatitis A vaccine. Dr. Rana.
Sir, please proceed.
Okay. Thank you very much. Good afternoon, everybody. At the outset, let me thank the local organizers for the kind invitation. And friends, if we talk about so many negatives about COVID pandemic, everybody knows the negatives. But every dark cloud has a silver lining. So similarly, COVID has given one positive, that is awareness about vaccination. I'm sure respected chairpersons would agree with me that awareness about vaccination, acceptance, not only from medical professionals, but also Aam Janta. Everybody knows about vaccines and the importance of vaccination. So here we talk about live hepatitis A vaccine. So the question which comes in everyone's mind, is it really required? Do we really need it? Is the disease that bad? Do we really need to prevent that kind of disease? So let's, in next 15-20 minutes, answer some of the important questions. But before that, let me declare that there is no conflict of interest when I'm delivering this talk. This is completely a science-based talk. So all of us know hepatitis A, B, C, D, E, so on and so forth. But the commonest day-to-day our OPD practice, what we get is hepatitis A. The number of cases, the millions, the zeros you put after one doesn't make any difference. But we know, especially in monsoon season, but in fact, all over the complete year wise, we have number of hepatitis A patients coming to us are a lot of, the number increases, especially in monsoon or during vacation times when the eating outside habits go on increasing. We know the mode of transmission also essentially a fecal-oral, meaning thereby usually when there is not a single index case, but some other members in the family also are affected by it. So it's basically inflammation of the liver, usually self-limiting, doesn't cause much problems, but if it can, then it is really devastating. So the incubation period is so important. When I say up to 50 days, whenever you want a vaccine preventable disease, you need to have a little bit longer incubation period. If I tell you the incubation period is 1 or 2 days, that doesn't give you a chance to protect somebody from the vaccine. So that's why this gives you sufficient chance to protect from the infection. We also know that the clinical outcome is closely correlated with the age. Younger the baby, smaller the infants, they have hepatitis A, they don't even realize, they may not even come to us, and they become all right. But the adolescents, as the age advances, and can you afford to get jaundice when your child is in 10th standard? Can you afford to get chickenpox infection when your child is in 12th standard? Or for that matter, during MBBS days, could we afford to have jaundice and down with it? Not at all. So it is essential to understand a disease which is preventable should be prevented with a good vaccine. If you talk about complications, we know that the fulminant hepatitis is so bad. In fact, the commonest cause of fulminant hepatic failure, infective cause, if you ask me, is nothing but hepatitis A. Though the figures are not very high, but if that index child goes into it, then you have it. Having said that, let me share a couple of my personal experiences of these children going into fulminant hepatic failure. Now, this child, Rohit, came to me previously absolutely normal, fever and nausea for 1 day, a typical hepatitis A history. Had taken only paracetamol somewhere outside, came to me. Next day, this child had severe epigastric pain, then we had persistent vomiting, fever continued, urine BSBP positive, then we had liver, which was tender, and the prothrombin time was very high with a PT-INR of 3.97, and the HIV IgM was positive. So this was a confirmed case of hepatitis A. And this child, under my care in my hospital, developed altered sensorium by evening. What business this child had to go downhill so fast. So this child, jaundice to encephalopathy interval, friends, was only 36 hours. So it didn't even give me a chance. And by the second PT-INR was 11. So this child had hepatic failure, had to be transferred to a tertiary care hospital. He fulfilled all the criteria of liver transplant, the King's College criteria, and he was to be, the parents called me that they are talking about liver transplant on the second day. I was shocked. So this is what happened to this Rohit. But fortunately, later on, Rohit's story ended well. He came out well without a liver transplant. Similar, another child came with fever, jaundice, typical hepatitis A story. No contact with tuberculosis, but this child had cough and mild breathlessness. Again, I said, why a hepatitis A child should have cough and breathlessness? I have never seen that. The rest of the findings also suggested that the air entry was induced in right axillary region. The rest of the systemic examination normal, typical jaundice finding, and this child had X like this. So this child has, along with hepatitis A, pleural effusion. Another known finding, but when it comes, when we talk about words like कुछ नहीं होता है, ये तो jaundice है, 4 दिन में ठीक हो जाओगे. let's never use such kind of words when we are counseling, because you never know that the next child sitting in front of you can come back with this kind of complication. So let's be careful when counseling these patients. So similar stories, I'm sure each one of you have something like this to share. Let's know that endemicity matters the most when we are talking about vaccines. When you and I were young and during our UG days, probably high endemicity in India because poor sanitation, high circulation of virus. Swachh Bharat Abhiyan, toilets at every home, good, we are progressing. But at the same time, let's see, the prevalence of HIV antibodies has gone down by 50%. So at 30-year age, less than 50% are positive. So they have not even got any exposure to hepatitis A virus. So that's why we have extreme low intensity. So we have India, Hindustan and Bharat happening at the same place, in same city, in same country. So that is why even if your index child is protected, the moment he steps out of the house, he's surrounded by the people who are not actually having so much of hygienic standards and sanitation may be poor. So we belong to intermediate. And then prevalence of hepatitis A, if you ask me, Dr. Upendra, why vaccine? Because it is a common infection. Do we actually do HIV, IgM every patient? No. Just BSBP, maybe OTPT, that's all people wait at that stage. We don't even report, so we don't have nationwide data about hepatitis C. Forget doing the seronology. So that is how the stories stand, but fortunately we do. And look at the changing epidemiological pattern which has established in this country. Fortunately, these studies come to our help. Look at this. For the first 5 years, the prevalence has gone down 30%. When I was a school student or maybe young college student, it was almost 70% less than 5 years. And by adolescent, we never heard of jaundice. But now the story is completely reversed. There is no exposure, so that's why the young babies do not get infected. And I don't want my adolescent and young adults to have this 50, which can go to 60, 70. So let's prevent hepatitis A if it is possible by a wonderful vaccine. So what does WHO say when I talk about this? So WHO position paper is extremely clear that if your country belongs to endemic zones, you must have it. No endemicity, no. So America does not have probably a vaccination program which is in place, which needs to be continuously carried out. Maybe of Japan may not have it. But in India, when the problem is so much and then we have the intermediate zone, we better have it. So what WHO finally says, India currently has pockets of high endemicity and low endemicity. So we are in between. Beach may. So we better protect our children, young adolescents by a vaccine preventable disease like hepatitis A by giving the vaccines. So up till now what is understood, hepatitis A can throw some surprises to us. Hepatitis A can come back with complications and it is preventable. So we have understood all that. Now what are the choices once I have decided that to give a vaccine? Two choices, a live attenuated and a killed. What is the difference between two? Basically, shall I tell you one thing? The nucleotide and amino acid sequence of both these vaccines, it's 95% same. So there is no difference in the antigenic configuration of most of them as far as the basic antigenic structure is concerned. But rest of the 5% differ and the method is different. One is inactivated, one is live attenuated. So that is how one should differentiate. But as far as safety, efficacy, immunogenicity, tolerability, everything is concerned, both are at par. Talking about this first, let's talk about inactivated. As I said, excellent vaccine, no points against it. But the only problem is this, the double dose that is required, different doses for pediatrics, adults, and an intramuscular route has its own disadvantages. So it's a killed vaccine, and we'll talk about live vaccine a little while later. So this is what a live vaccine we are going to talk about. Basically, it contains what is known as the H2 strain. So it was first started off in China. So first studies in 92. Number of the million and billion doses have been given there and rest of the places also. So periodic safety update report comes, PUSR, has established safety beyond doubt. And apart from China and India, there are so many other countries like Philippines to Nepal, Bangladesh, Chile. They also use different drug names, but they also use a live attenuated vaccine. So this is the beautiful slide which can explain the importance of vaccination for anybody, everybody, for Aam Janata, for elite class, everybody. Look at the incidence of hepatitis A prevalence and look at the vaccination program when it started in 92. The moment your vaccination program goes up, look at the disease coming down. So this is to explain to anybody why a good vaccination program is always effective in controlling the spread of the disease in the community. So this is the beauty that is explained by this. So now what is this actually the difference between live attenuated? So it stimulates, we know that the live attenuated, so not harmful. So human diploid cell cultured vaccine. So it gives something like a natural infection, produces a complex immune response. Now COVID, all of us know, doctors, people are asking me so many phone calls, doctor साहब 2 डोज हो गए, तीसरा ले कि नहीं? अरे क्यों? नहीं डॉक्टर साहब, न्यूट्रलाइजिंग एंटीबॉडी करना डिफिकल्ट होता है. But we are only talking about the humoral antibody response. भैया सेल मेडिएटेड इम्यूनिटी भी नाम की कोई चीज होती है, वो आप भूल रहे हो. उसका मेजरमेंट नहीं आज तक. So we have something called as cell mediated immune memory, which is so important, so crucial for the body. So this is the advantage of a live attenuated vaccine over inactivated vaccine. So both arms of immune system are used. If you use only single arm, it will have some limitation. So this is same dose. This is another advantage. So we do not have for live attenuated something different for adults, something different for children. So this is the study which we was first published, a multi-centric study when hepatitis A first trial started in India. And this was followed up almost now 11 years completed when the first cohort was studied. And look at the seroprotection. It persistently remains same. Look at this. It has not dipped down. And the geometric mean titers. What is the protection I am looking forward to? At 20 milli international units per ml is good enough. So when my vaccine gives that kind of protection for such a long time, I'm happy. I don't want anything more. So if 20 is protective, if the vaccine makes 40, 80, 120,000, that is not required. अगर 3 रोटी खा के आपका पेट भरता है, तो some hospital offers you 25 rotis, your pet does not need it in fact. So that is how one should understand. The higher the level does not make any vaccine better. What is important is persistence of seroprevalence for a longer period of time and giving you particularly immunoprotection. So this is how good seroprotection and GMT titers. And this was the wonderful paper published in our own Indian Pediatrics in this very year 2021, which is a 15-year follow-up. Friends, all of us know we never accept studies done internationally unless Indian data is there. Most of the vaccines it is not there, but fortunately one vaccine where our own data which was done for follow-up for 15 years, and what does it show? Let us see. That this study began in 2004 when about 143 children were given this vaccine, and they were followed up, and they were followed up regularly in 2007, 10, 17, 14. There were antibody studies were also done. What was happening to them? And those who came for follow-up, some of them had levels going down less than 20, and 7 plus 4. This, look at this. 4 had received 2 doses of licensed hepatitis A inactivated for vaccine, and 7 others received the second dose. कि भाई इनका 20 से कम हो गया तो एक dose दे देते. So this one actually now retrospectively, company on the study doing group has also felt that this was probably not required. Look at this, what this vaccine shows. So look at 2019. Forget that initially it was perfect. 86.2% sample size is 109. Corrected to those 11. So that means this is 98 patients if you consider. This was given a protection of 95%. But इसमें से उन्होंने वो लेवल निकाल दिए जिनको सेकंड डोज दिया था या उनको इनएक्टिवेटेड वैक्सीन भी मिला था. तो still it is showing you persistence of 86.2%. What more do I need? So this is the comparison of GMT values at 15 years with previous assessment year. पहले तो उसको 100 के ऊपर जाता था, but there is no ways to quantify this kind of titers. And what is the titer which I told you that we needed? 20 million international units. 20 से कितना ज्यादा है कोई मायने नहीं रखता है. मुझे 20 चाहिए, मुझे persistently 20 चाहिए. These are the only 2 messages. So 7, 10, 14, 19 आप देखिए वो कभी कम नहीं हुआ. But then this is a very interesting part of the study. When it showed that when this cohort was studied in 2010 there was a dip, and then again it came up. That means without doing anything, a subclinical infection acts like a booster and it zooms up again. So your child or whoever index patient remains protected. So all 98 always, because 20 यहाँ पे whatever dips are happening ऊपर हो रहा है यार. आपके पास 100 करोड़ है, कभी कभार वो 95 करोड़ होते हैं, कभी 80 करोड़ होते हैं. जरूरत कितनी है खाने पीने के लिए? मुझे 20 की जरूरत है. वो ऊपर कितना 100 से 95 होता है, मुझे कोई फर्क नहीं पड़ता. And look at those patients who had low titers, Even those studies, low titers in 2010, look at this part. 2010 में deep आ गया, but after that it has come up on its own without any booster. So this is the best part, that even if the titers drop down for a while, they come out due to the subclinical infection and your child does not need a booster. And this was the conclusion drawn, that it compares well with other Indian and Chinese studies and even the Chinese seroprotection. And finally, a last study about this 17-year follow-up data of the original Chinese cohort. This vaccine is basically Chinese. So immune memory. So this is the difference between an inactivated and a live vaccine, because this is an immune memory. Look at this, what happened. So what they did is, the arm which took hepatitis A vaccine, now I'm talking about the Chinese data. So single dose of hepatitis versus एक लोगों को दिया, दूसरे बी को किसी कोई वैक्सीन नहीं दिया. जिनको दिया, उनको again they were seeing whether they had any infection, whether they did any receive any boosters. So इनको study को ले लिया. And then what happened? A challenge of hepatitis A, कि चलो देख के देखते हैं कि क्या होता है इनको. What happens to their titers? And look at this. This is what is beauty. That anti-HIV negative. So suppose you were given a vaccine and you will study it. And when do I call you negative? You know the level 20 I said. So 20 ke niche 18 people had such, and there were HIV positive 29. So to compare between two arms, they took some, those who had protective levels, still unko ek booster de diya, and those who did not have, unko bhi ek booster de diya. And then what happened when these children were followed up? Those who were HIV positive, the titers went from 65 to 1,832, and those who were negative, in fact, it was less than 28. We felt that they are not protected. Even if once they were given, it came up to 663. So rise of level of anti-HIV serum IgG before and after booster was significant. So GMC increased from 67 to 1,018 in positive. So in fact, the height is 83 times higher in the GMTs for those who were seronegative for anti-HIV. So point is, you did not, so this study showed that probably you did not need a booster, even if your titers go down over the period of time, which happens with every vaccine. A pneumococcal vaccine, H flu vaccine, or सबसे बुरा तो कौन सा है? Which is the worst? A pertussis containing vaccine. You know, this sophisticated acellular pertussis vaccine, every year it drops. In fact, every pregnancy it is recommended to give a Tdap booster. Why? Because nobody is sure after 8 months or a बार. 2 साल बाद pregnant or एक dose ले लो, because they are not sure about the protection. That's the worst vaccine as far as long-term protection is concerned. But at least this is the best part about hepatitis A vaccine. So this clearly shows that even after 17 years, subjects who were below required level also produced more than what was required GMC titers to get exposed to the infection. And why did all this happen? It's just because of the memory cell activation. The cellular immunity is amazing arm of immunity. Once it gets stimulated, it never forgets. याद रखूंगा तुझे याद रखूंगा. The typical Gabbar Singh dialogue, the memory cells also, and that infection may happen after 10 years, 15 years, but then the body protects. And let's hope, keep our fingers crossed, same thing happens with our Covishield and Covaxin. So this is what is the best part, that this is why does it happen, is because of the significant increase in secretion of interferon by CD3 plus cells. So these are the ones, they mobilize rapid response, antagonistic antibody response. So final outcome is the child or the index patient who has taken the vaccine remains protected. So that is what one should remember. So which satisfy the characteristics of live attenuated. So all of us know all live attenuated vaccines give this long-term protection just because of simply activating the memory response. So single dose has good cellular as well as humoral arm, which gives us a long-term protection. All of us know this part, and this is the differentiation. Now let me come to your practice point, which vaccine to choose. If I tell you both vaccines are equally well, nothing to differentiate as far as immunogenicity, long-term protection, safety, efficacy, everything, the most important difference is single dose versus 2 doses. Right? 2 बार देना है कि 1 बार देना है. So why that advantage should be ignored? Not only look at this, let's compare this part. So even our IIP also recommends that single dose is more than enough. And finally, this is a final part of my presentation, which I talk about number of doses. क्या मायने रखता है? Look at the study Nelson et al. Did in 2009. And mind you, these are done in Western countries. So 40 to 50% only, whenever 2-dose vaccine schedule was given, 40 to 50, that means almost remaining part, 60% do not come for the dose. So there is a dropout of 550 to 60%, remember that. So whenever a single dose vaccination schedule has a high success rate. Second part, needle fear. हमने वो थाईलैंड का हेल्थ मिनिस्टर का वीडियो सब तो देखा रहेगा व्हाट्सएप फॉरवर्ड में. When he was given vaccination, he fainted and the kind of reaction he had because in spite of being a health minister of Thailand, he had a needle fear. Fellow could not overcome. So why to give a fear for second dose when there is a single dose? Convenience. मेरे फ्रिज में जगह करने भाई किसी का एक डोज ही रखना is better rather than keeping 2 doses. And for somebody, we are telling them भाई कम आओ, appointment लेके आ जाओ, दूर से आ रहे हो. So why to call them twice for some disease protection which can be protected by only a single dose? Isn't it? So convenience for both patients as well as for doctors. Risk of adverse effects. You would say, Dr. Upendra, आपने तो कहा दोनों same है. So why no risk? Because the risk of adverse effects by giving 2 times versus giving 1 time, you are thereby reducing by 50% itself. You're getting my point? So that is how it scores over there. The risk of bleeding for those with underlying bleeding disorders. We recommend भाई उनको subcutaneous दे दो, IM1 दे दो. ये vaccine ही subcutaneous देना है. So that's an advantage. So bleeding, all those who are on anticoagulants, all those are also having a great advantage. Immune response is the basic scientific advantage that cellular and humoral response. And cost effectiveness, vaccine की cost कम हो जाती है. 2 doses of inactivated plus 1 dose of live cannot be matched, and plus you add the other costs like travel and everything and consultation fees, everything. You don't usually quality of life lesson करते हैं. School absenteeism के days भी count करना चाहिए. Similarly, travel costs also we should count it. So friends, finally, this is the last slide. What I would say, hepatitis A case mortality increases with age, complications come with advancing age. Fulminant hepatitis failure is also known, so we should be careful. India moved from high to intermediate zone. When we were high, none of us talked about hepatitis C vaccine. Our priorities were entirely different. Now the time has come, India has to go to developed nation category with an intermediate zone of hepatitis A. Let's protect our generation. Single dose of live hepatitis A is adequate in our country and in our endemic zone. So single dose is more than enough. Live hepatitis A provides both humoral and cellular immunity. Though required level of protection is 20, the GMT titers are very high for 5, 10, and even 17 years. They have proved beyond doubt. The only hepatitis A vaccine which is backed up with Indian trials, mind you, rest of the inactivated vaccines, fortunately or unfortunately, do not have Indian backup data. So once we say, yeah, हमारे देश में data है, fine. Otherwise, अरे फिनलैंड की बात छोड़ो, अरे यूएस कनाडा की बात बोलो, हमारा बोलो, या पाकिस्तान बोलो, फिलीपींस बोलो, जो हमारे देश से देते, भाई हमारे देश में स्टडी हुआ है, so why not give attention to that? An advantage of longer protection to advantage to memory cells, proved with this 17-year booster dose challenge. So I think the scientific facts which I have tried to place in front of you, go through it and you have to final decision. But the final message is give vaccine. That is what it is. So it is not vaccine that protects, it is the vaccination. So ensure that every child who comes to your OPD receives a hepatitis A vaccine. Very important. Thank you very much.
Very nicely summarized, sir, and excellent presentation. As you have said that it is a self-limiting disease, but I was attending one lecture on liver transplant. In India, the commonest cause of liver transplant is fulminant hepatic failure post hepatitis A. As in Western countries, it is paracetamol toxicity. We have hepatitis A as the most common cause of liver transplant in India. Fulminant hepatic failure.
That's it.
Secondly, cell-mediated immunity, the major advantage of this vaccine, and cost effectivity and abundance.
Perfect. Well said. Well said, well said.
Excellent advocacy, sir.
Thank you, sir. Thank you. Any questions? Anybody? Yeah, please.
The audience.
Sir, so for GM factors, as you were mentioning, so when you were talking about the cell protection for any vaccine per se, if it's there or approved, for example, so they will have to achieve some kind of correlative protection which is there, which is maintain the threshold which has to be attained. But for GM titers, the advantages what I have read and also WHO has also like mentioned in the guidelines as well that if the higher the titers, then definitely the waning of the immunity, like the antibodies will take a longer duration of
Yeah.
Because
This is one part. So remember, serologic correlate of protection is not available for many of the other vaccines also. So like for example, pertussis, when I talk about, there is no particular level. So it is only the outcome as far as disease prevention is concerned. Now talking about COVID, what do I expect from a COVID vaccine? There are a number of protective levels that serologic protection that COVID vaccine gives. So do I aim to prevent a subclinical infection? Do I aim to prevent an infection? Do I aim to prevent a disease? Or do I not want a patient to suffer from complications, hospitalization and death? So each one of us present over here would say, Dr. Upendra, the last part, we don't mind because sardi, khasi, bukhar, 2 दिन हो गया, ठीक हो गया, fine. None of our COVID patients to land up in hospital, to get oxygen, to get ventilation and to die. That's good enough. So we are extremely happy if a vaccine tells us that this is what we are offering. Fine, it's a great vaccine and give me that shot. Similarly here, madam, even if you say that the GMT titers go up, say 100, 2000, but वहां से नीचे आने में कितना कम लगेगा या 100 से आने में, it doesn't make any difference as long as they are about 20. And this study, 17-year-old, which I showed, Indian study, there are two studies, Chinese as well as Indian, both have shown, even if they tip, they come back. So you do not have to worry, 17 ka aur aage jayega, we'll have 25-year-old, 30-year-old studies also will come up. So as the time passes by. And as of now, those who are into practice, I want to ask you also a question. How many of you have had an experience that those who had given inactivated vaccine versus a live vaccine, and no, Dr. Sahab, unko ho gaya, fir bhi hepatitis से हो गया. No. So practice protection, what is ultimately in field trial, what I call field efficacy, that also proves our point. So the GMT titers, higher titers, remaining longer time, it's one part, fine, scientific. But as far as day-to-day protection is concerned, these protection matters the most rather than just scientifically talking about the titers.
Excuse me, inactivated vaccine we can give in old age people 40, 50 like that.
Sir, cannot hear.
Inactivated hepatitis A vaccine you can give in old age people 40 years, 50 years like that.
Yes. So the vaccines inactivated is absolutely nothing wrong again or no negatives about it except there are 2 dose schedules. That's it. And then it can be given in an immunocompromised. This being a live vaccine, pregnancy, no. Immunocompromised, no. Extremes of ages, no. So all these outbreak response when it happens, no. So there, killed vaccine, inactivated vaccine will be a wonderful choice, and then those advantages need to be kept in mind. But then these are very few patients that would actually require. Our regular 1 to 18-year-old, we need not worry, and we can very well go ahead with a single dose of live.
Thank you, sir.
Thank you.
Thank you, Dr. Ben. Nice.
Thank you.
Moving to our next session, which is on common pediatric ENT issues. I now invite Dr. Dinesh Goyal, Senior Pediatrician, and he is currently the President of IUP Janakpuri, Secretary IMP West Delhi, and he is Executive Board Member Delhi University. Over to Dr. Dinesh.
Thank you, ma'am. May I now invite Dr. Alok sir for common ENT issues in pediatric children. Dr. Alok sir. Dr. Alok Gurwar is a senior ENT consultant at Sir Gangaram Hospital, New Delhi. Vedanta ENT Superspecialty Clinic, East Patel, New Delhi. Sir is having a special interest in pediatric otorhinolaryngology, pediatric cochlear implantations, laser and population of ENT surgeries, endoscopic skull-based surgeries. Sir is ex-secretary and president of Delhi AOI, Association of Otorhinolaryngology
neurologist, member of AOI India, member of All India Radiological Societies, member of CICI, member of ESP. I welcome Dr. Alok Agrawal for this session, sir.
Hello. So, good afternoon. Thank you, organizers, Dr. Pankaj and Dr. Manish. And the topic for today's discussion is common pediatric ENT issues. So, pediatric ENT is developed from 16th century to till date, and there are very much perceived needs and development of acceptable interventions in the child care, which leads to sophisticated diagnostic and therapeutic procedures. And otolaryngology is specifically the biggest pediatric surgical workload. So there is a very close communication between the ENT specialist and the pediatrician. Sometimes the pediatricians require our help, and in some complex cases we go and help in the form of securing the airways, doing the tracheostomies and the other procedures. But our procedures, usually ENT procedures, are elective ones. These are the common diseases. These are the list of common diagnoses which we deal as far as the pediatric ENT is concerned. So first we will talk about the foreign body, which is most common thing. And there are various types of foreign bodies which the children put inside ear, nose and throat, and they inhale sometimes also. And self-infected foreign bodies occur more frequently in attention deficit or hyperactive disorders and children with the neurological disorders. So ear foreign bodies are the various types of ear foreign bodies, and they are nowadays be removed with under the microscope, with special instruments, or with the endoscope. We have in our department 2.7 millimeter endoscope, and with that we remove the foreign body with a precision without disrupting the tympanic membrane. Likewise, the nasal foreign bodies, these nasal foreign bodies are cause usually the nasal discharges, and the more important nasal foreign bodies or these type of foreign bodies are the button cell, which is basically alkaline, and that should be removed as early as possible. Otherwise, there is no urgency in removing. That can be removed. And as far as you can see, this is the foreign body in the nose, and when the foreign body is removed, that is the cannulation, which you can see is there. And removal is done by the Johnson horn probe or a special technique which is known as the mother's kiss. Gentle going into the mouth while closing the unaffected nostril, or using the Fogarty's catheter, which is passed beyond the foreign body and gently withdrawn. This is one of my patients, which have, you can see they have, he has put, he is mentally challenged boy, and he has put these two screws inside the nose. And they seem to be inside the sinuses, but they are actually not inside the sinuses, they are inside the nose. And we have removed successfully without tearing anything. Likewise, the inhaled foreign bodies, which is very common and the commonest cause of accidental death in children under 3 years of age. During the winters, and the most common foreign body is the peanut. And during the winters, we removed at least 40 to 50 foreign bodies. This is the number of patients we do in our department, because in our hospital there is a very good pediatric department which gets these patients and they diagnose usually by the history, and if there is a little bit of doubt, they do the fiber optic laryngoscopy and then they refer the patient to us. So, you must be knowing very well that the hyperinflation of the bone wall effect is the main radiological finding. Foreign body, sometimes metallic may be radioactive, otherwise usually the foreign body are not seen. And this is mediastinal shift pneumonia and the pneumothorax are the other common things. These are this is the foreign body which is radioactive. And we have this nowadays optical forceps. We put the endoscopes, we see the foreign body, and you can see we can remove it with the optical forceps without damaging and without leaving the foreign body. This is just to show that this is a bronchial cast we have removed from a child, which has completely obstructed the lumen of bronchus. And this is a bead which we have removed, and we have published this in the one of the papers, that we have removed this bead. It's large slippery bead which cannot be held with a forceps. We have passed the provided catheter to the bead, inflated it, and removed it. So this is the bronchial cast, and this is the bead. So CT virtual bronchoscopy is seldom done when the history is not very clear. Otherwise, we do the flexible bronchoscopy followed by the rigid bronchoscopy. By and large, we remove the foreign body by the rigid bronchoscopy. So the next most common thing is otitis media, also known as the blue ear. And the cause is cleft palate allergy, GERD, infection, and most common which we see in our practice is adenoid hypertrophy. So clinical features are hearing loss, hearing, diagnosis is based on otoscopy, tympanometry, or audiometry. And if it is not treated in time, that can progress to cholestoma, internal sclerosis, hearing impairment, poor academic performance, and sometimes balance disturbances, because ear is also having the balance organ of the body. So management of the OAB, when the management of the OAB comes, then the parents should be counseled to the benign nature of the disease. Teachers will be made aware that the child's hearing disability, and hearing disability will be minimized by the methods of get the child attention before starting to talk. Reduce the background noise, if the child speak in a normal voice and volume, and the medical management as far as concerned is the nasal topical steroids, systemic steroids, decongestants, antibiotics, mucolytics, and automation. Sometimes surgery is required in the form of the laryngotomy, insertion of the ventilation tube, and adenoidectomy. Reduces the need for reinsertion of the ventilation tubes, and nowadays we also do the eustachian tuboplasties in the cases which are recurrent type and with different resolve for the one-time ventilation tubes, we do the eustachian tuboplasty also. And hearing aid also can be given, but nowadays we don't give usually hearing aid unless and until the TM is totally plastered on the middle ear bone, and there is no scope of coming in there. The next condition is microtia. Just to complete the list, the incidence is 1 in 10,000, and they are usually associated with the sensorineural hearing loss and the conductive hearing loss. And if it is conductive hearing loss, PAHA can be given if the patient wants. Next condition is the corneal atresia. This is also a very 1 in 7,000 live births, and bilateral corneal presents as an acute respiratory distress, and the sign is the sinuses that improve from crying. So it has to be diagnosed simply by the passing the nasogastric tube. You are not able to pass the nasogastric tube, means it is totally closed, and the treatment is surgical repair, depending on one side or bilateral. Unilateral can be wait for 1 year, but bilateral should be done as early as possible. Now, cleft lip and palate. I will not, I will just go through it that we do the 3 to 6 month primary lip and nose repair and hard palate, 9 to 12 months palate repair and ventilation tube is required, 4 to 5 years secondary speech therapy, 8 to 10 years alveolar bone graft is required, 15 to 18 years secondary rhinoplasty and 16 years onwards orthodontic surgery is required. So next is the congenital subglottic stenosis, third most common congenital anomaly in the larynx. So the congenital subglottic stenosis, these are the two pictures. This is divided by the coordinate grading, 0 to 50%, 51 to 70%, 71 to 99%, and 100% obstruction. And accordingly, the treatment is chosen. The treatment is based on the stenosis. If the airway is not severely compromised, surgery may not be required. And the congenital cartilage stenosis, strict contraindication to the dilatation in the laser section. Approximately, if airway is severely compromised, should be done. Surgical techniques depending on the grades, laser resection, balloon dilatation, submucosal resection, LTR or PCTR as of the grades. So, a word about how to avoid the subglottic stenosis. Soft endotracheal tubes should be used. Balloon of the endotracheal tube should be deflated periodically in the ICUs, pediatric ICUs. And decision of the tracheostomy should be taken earlier. If prolonged intubation is required, preferably the second week of the intubation of the cast. Good communication is required between the ENT and the pediatrician that when to go for the trachea. And earlier trachea can solve the problem of tracheal subglottic stenosis. Likewise, the subglottic hemangioma, where you can, the medicine, the majorly treatment is a medicinal, rarely the surgery is required. Nowadays, propofol is the first line of the treatment. We start with the 1 milligram per kg per day from first week and 2 to 3 milligram per kg as the tolerated. And there is a laryngeal cleft, is another thing. So these are the different varieties, type 1, type 2, type 3 and type 4. Usually type 1 doesn't require surgery and with the mild aspiration may be managed with the thickening of the feet. And type 2, 3 and 4 always require surgery in some form or other. Respiratory regions I have already talked. Next is the preauricular sinuses. Again, it should be diagnosed and treatment is definitely excision. It should be done as early as possible depending on the discharge of the patient. Otherwise, usually preauricular abscess forms and then the surgery becomes difficult and the outcome of the surgery is also not very good. Now we come to the hearing impairment part. Permanent childhood hearing impairment is defined as a confirmed permanent bilateral hearing impairment more than 40 decibels. Average over the frequency of 0.5, 1, 2 and 4 kb, which is the speech range in the better hearing. Can be conductive, sensory or mixed. Onset may be prenatal, natal or postnatal, and etiology may be congenital and acquired. So hearing loss can occur prelingual or postlingual. So earlier the identification, less is the problem of the speech development. So and as far as this treating the hearing loss is concerned, nowadays people, as you know, are doing the cochlear implants. There is more than 70%, 70 decibel of hearing loss. then cochlear implant is twice, and we are doing it on a regular basis. Proof is acute laryngobronchitis, classically caused by the parafunction type 1. You people must be seeing these patients very much, and rarely we do see these patients. The best sign on the X-ray is capable of the pancreatic sign, where the tracheal nerving you can diagnose on X-ray. Treatment is corticosteroids, nebulizations, definitely. Acute pulmonary once the diagnosis is confirmed, secure the airway and before the further investigation, and simple treatment with the antibiotics is what which is required in the form of Pcni, clindamycin, or chlorpheniramine. Now we talk about something of the bronchial anomalies. This is the sinus of cyst. So, as for the first bronchial cleft sinuses, that is the pulmonary fistula, that opens one opening in the aspirated canal, and the second opening is passing between the facial nerves, going up to the mandible. Surgical excision is done via modified Bell's incision. Second bronchial cleft is the bronchial sinuses and bronchial fistula. This thing again has to be treated with the surgically. Hypoglossal cyst, most common congenital anomaly in the head and neck region, and this should be diagnosed that this hypoglossal cyst may contain the thyroid tissue, which one might have to remove and implant in the forearm. Sometimes, but otherwise the patient has to be put on the lifelong thyroid replacement therapy. Lingual thyroid is another thing which comes into the domain of ENT, and we seldom do surgery for the lingual thyroid unless and until it is causing obstruction, significant obstructive symptoms. Now coming to the adenoid, which is very important part of the valvular filling of the pharynx, and we all see the patients of the adenoiditis, chronic adenoid hypertrophy, and these are the four types of the grades of the adenoids: grade 1, 2, and 3, and 4. One is up to the 1/3. The second is from 1/3 to 2/3 of the pcni, and grade 3 is 2/3 to total obstruction, and grade 4 is to complete obstruction. That is the pulmonary adenoids. So, as far as the treatment is concerned, grade 1 and grade 2, you can treat with the anti-allergics and the local nasal corticosteroids. But grade 3 and grade 4 pulmonary adenoids should be removed by the surgery. These are the clinical features: adenoid, classical adenoid species. So complete adenoidectomy is done with the almost no blood loss nowadays with the coagulation technique, where we remove completely the adenoids and barely 2 to 5 ml of the blood loss. You can see that much is required for testing of other things. Now we come to the tonsillitis. The tonsils. This is the acute tonsillitis, which we do see on a day-to-day basis, caused by the group A beta amyloidotic streptococci. This is a bacterial tonsillitis and the biotonsillitis. One should differentiate. And tonsillectomy we do if there is 7 or more well-documented clinically significant adequately treated 4 throats in the preceding year, or 5 or more in the preceding 2 years, 3 or more throats in the 3 years. These are the guidelines, but usually depends on the patient and the severity and how much they are worried about it. Peritonsillar abscess and quinsy, selection of puff lateral to the tonsil, which nowadays we see quite rarely because of good antibiotics, but whenever it is there, it should be aspirated, such as S50 has to be done, and it has to be trained. Retropharyngeal access, also nowadays we see quite a few patients, but there is definitely the thickening of the retropharyngeal space. If we put the needle by the ultrasound guided needle through the neck, we can put, or we can put directly from the oropharynx, aspirate it, and sometimes drainage is required, otherwise aspiration with a higher antibiotics sufficient enough. And if there is too much of air compromise, and tracheostomy is sometimes required. So epistaxis again is a very common thing in children. They usually put the finger inside the nose and nasal practice is disturbed. So these are the different causes of epistaxis. So what we do nowadays, which we are going to talk, that simple thing is just to pinch the nose and wait for 5 to 10 minutes. 90% of the epistaxis stops. But if it persists, then we have to do the bipolar electrocautery inside the operation theatre, minority or minority, and which is these type of things. Rarely the topical fibrin glue or the matrix sealant and other brand, but bipolar cautery is sufficient enough. And this is gold standard nowadays. No patch after that. Juvenile angiofibroma is another thing which should be suspected when there is a unilateral excessive bleeding and which doesn't stop like a pressure and all. So profuse or proposed recurrent spontaneous bleeding. This is angiofibroma, which you can see by the nasal endoscopy. So carotid angiographic visualization has to be done, and when it is confirmed, then surgical excision endoscopically is possible nowadays. So preseptal cellulitis is again another condition where there is edema of the eyelids and ptosis, edema and eye pain, but no proptosis or ophthalmoplegia or vision loss. So it should be differentiated with the orbital cellulitis, and usually the antibiotics are sufficient enough. So likewise the pediatric rhinosinusitis, and again the treatment is, if there is sinusitis, we have to remove the disease from the sinuses endoscopically and followed by the good treatment. Medical therapy is absolutely essential to prevent or delay the recurrence of the disease, directed towards suppressing the inflammation, preventing the accumulation of erythropoietin, and maintaining the sinus health. Saline irrigations or topical steroid sprays are benefits of the treatment. Owing to the extra mucosal nature of the disease, sometimes infiltration dewashing are required, but rarely. Thank you very much for the patient listening.
Thank you so much, sir. Very nice presentation, and common ENT problems are our day-to-day practice. And sir has nicely covered this topic very well. Any questions from the audience side? Thank you, sir. Thank you so much.
Common problem, that is the common dental issues in the children we all as a general practitioner deal with. And to chair this session, we have with us Dr. Yogesh Parekh. Sir is a professor and head of the department at the Rajkot Medical College. He is also the convener of the IAP NRP FGM program, and he has held and still holding a lot of important positions at the IAP NRP and the thorough academician. Even on the e-Gurukul program, you see the Saturday for the PG course is being his idea, and he's the founder of that. Along with him, we have with us Dr. Rakesh Dogra. He is a senior specialist at Hindurao Hospital and is also the in charge of the pediatric pulmonology. We welcome the chairpersons for the session. Over to you. Thank you.
Hello. Thank you, Dr. Shobna, for the introduction. Hello. Yeah, good evening. So we have with us Dr. Hito Agarwal, and we will be discussing the common dental problems in children. Dr. Hito is the practicing pediatric dentist at Sun Permanent Hospital, and she also practices at Dr. Hito's Kids Dental Clinic, and she is interested in everything related to child oral health. Welcome, Dr. Hito. Please.
Good afternoon, one and all. I'm highly obliged that I've given the chance to express what all are the major common problems that as a kids face. And as pediatricians, you are also being asked many questions related to the oral hygiene. The most common problem is tooth decay, which is the most common chronic disease. It is more common than asthma, diabetes, and even obesity. But the awareness that it exists and its treatment exists is very less. 1 out of 2 children in India is affected by dental caries. The recent survey also showed that 70% of children have dental caries under the age of 15 years. In Delhi itself, 52.3% school children had dental caries. But the thought is कि दूध का दांत है निकल जाएगा तो treatment क्यों करें? But dental health in children also impacts mental health. There's a continuous chronic pain and the chewing is difficult for the kids, which leads to malnutrition and disturbed sleep, which results in turn to the delayed or insufficient growth. Because there are many missing teeth due to caries, the speech articulation is very poor. Kids do not want to smile or get their photograph clicked. Because of this, there's a social rejection and very low self-esteem. As per the survey says, there are many kids who do not go to school because of the pain, continuous pain. They are not able to study for the exam, and thus there is a poor school performance. But ये जो thinking है कि दूध का दांत है निकल जाएगा is very bad. The milk teeth are equally important. Kई बार dentists also they advise to get the root canal filled, get them saved, but still parents and even certain doctors ignore. Why the milk teeth are important? Milk teeth are important because they give way to the permanent teeth. As you can see in the picture, that is a 5 to 6 year old kid's dentition. The permanent teeth are right underlying the primary teeth. So if there is an infection in the primary teeth, and it goes deeper and deeper in the roots, it is affecting the permanent tooth. So the permanent tooth is growing in the unhealthy environment. So it's going to be brittle. It is not going to be carious, but it's going to be brittle when it comes out. दूध का दांत है निकाल देते ट्रीटमेंट की क्या जरूरत है? It is not कि treatment की क्या जरूरत है. Yes, we also extract many times, but it is important that if we can save, please save the tooth. The reason behind is if the tooth is extracted before its age, there will be a space loss. Adjacent teeth will bend, it will close the space, and so the eruption of the permanent teeth will get blocked. If in case we are advising to extract the primary tooth before their age erupts, it is necessary to put space maintenance. So the space is maintained for the permanent tooth to erupt. The main reasons for these tooth decay are chocolates. Birthday hai, chocolate aa gayi. Koi bhi ghar aaya, chocolate de do. The easiest way, because kids will never say no. But these chocolates, certain chocolates are good. Dark chocolates are very good. But sticky gums, candies, lollipops, they are very bad. They stick on the tooth for a longer time of period. Also, if the chocolates are taken in between meals, like in between lunch and dinner, they are more harmful. Chocolates taken within the meal, within the lunch time only, with the meal, then they are much better and they do not stay for longer on the teeth. I always recommend chocolate bank to the parents, which helps the child to motivate and collect all the chocolates and advise them to have it on Sunday or on some holidays. Basically, it is the idea that during the एक lunch पर ही सब मीठा खा लो instead of कि हर रोज थोड़ा थोड़ा every time खा रहे हो. The reason behind this is आप जब भी one piece of sugar you are having, the bacteria in the sugar make your mouth acidic. And this acid is there for 20, this acidic environment is there for 20 minutes in your mouth, which leads to enamel demineralization and risk for decay. अब जब भी पेरेंट्स की हैबिट होती है कि आधी चॉकलेट अभी दे दो आधी बाद में देना, which is very wrong because you are increasing those 20 minutes, you are adding 20 plus 20 minutes. My advice is कि एक बार में 2 चॉकलेट दे दो. At least you are saving those 20 minutes. Psychologically बच्चे को शांति है कि मेरे पेरेंट्स चॉकलेट्स दे रहे हैं मुझे. They are not stopping me from chocolate. That is very important. Common medicines also like amoxicillin, cough syrups, they have very high pH values which leads to the erosion. There is because kids are very fussy about the medicines, वो लोग मीठा बनाते हैं or they put some flavors like strawberry, so they are high in concentration of sucrose. Even the viscosity, for example, protein viscosity is very thick, so it stays in your oral cavity for longer time. And generally the medicines are given at night कि बच्चा खाते ही सो जाए, vomit ना कर दे medicine, which also during the night the saliva flow reduces, leading to the retention of these medicines and in turn they are ketogenic. Also, I would like to focus on the iron syrup. जब iron syrup देते हैं, there are black stains who are continuously on iron syrup. I would just recommend by my personal experience कि अगर आप आयरन सिरप दे रहे हैं तो एक सिप ऑफ वाटर साथ में दे दें, तो the black stains wouldn't stay. I have a 4-year-old kid and I did the same with him and he doesn't have any stain. And if the one bottle is over of the iron syrup, then wait for 10 days to start another bottle. This gap is sufficient to remove अगर थोड़ा बहुत भी कुछ stains आया है. But it is very important कि एक sip water चला जाए उसके बाद. Again, the main reason, one more reason for the cavities in children is nursing bottle cavities. बच्चा सो जाए तो हम बॉटल मुंह में दे देते हैं कि जितने टाइम तक सो सकता है उतने टाइम तक बॉटल ले. But one by one drop going from the bottle or the mother's milk, it is the most basic reason for cavities in children from 1.5 to 2.5 years. So the bottle should be filled like बच्चे को उठाया, आपने गोद में पकड़ा, feed किया, and then remove. Do not keep it for longer hours. Even even if you are feeding him, रात को उठा कर दे रहे हैं, तभी भी just clean the gums with a gauze or finger. How to stop this bottle feeding? Ideally, it should be stopped by the age of 2, maximum by the age of 2.5. But I have seen kids drinking from the bottle even at the age of 5 and 6. How to stop this? Gradual dilution of the liquid. In the first week, dilute the milk with 1/3 of the bottle should be diluted with water. In the second week, 2/3 bottle should be diluted with water. And in the third week, only water should be there with a drop of milk so the child sees there is only a tinge of white color. But the best way is to stop suddenly. 2 दिन बच्चा रोएगा, third day he'll be okay, he'll be ठीक है, दूध पी रहा है, नहीं पी रहा है, but he won't ask you for the bottle. And milk is not important. Stopping the bottle feed is very important. The most common question I think all आप सबको ही every parent is asking is when to start brushing teeth, or the child has only one tooth, should we even brush them? Is the milk teeth important? Should we brush them? Yes, you can start brushing your teeth or gums as early as first week of birth. अगर teeth नहीं भी हैं तो gums clean करने हैं. How to clean them? You can clean your baby's gums with moist gauze piece wrapped around the finger. And as soon as the teeth starts erupting, you can use finger brush or the brushes with smaller heads. You don't have to use complicated techniques. Only the Phone's technique, which is to move the toothbrush in circular motion, is enough. But the circle should end till the last of the tooth. सिर्फ आगे के ही दांत में करना है ब्रश इज नो लॉजिक या बहुत हार्ड ब्रशिंग करनी है एंड माय टीथ विल बी क्लीनर नो you should just do it gently and do not harm the first layer of your tooth by brushing very harshly. Which toothpaste to use? Fluoridated toothpaste use करें नहीं करें? First of all, toothpaste is not at all important. It is just for your freshness. Brush reaching each surface is very important. I missed one point in the last slide. Night brushing is very important than the morning brush. Because आप दिन भर कुछ खा रहे हैं, you're sleeping with the same thing, where the saliva flow has reduced already, then you will surely get cavities. Morning brushing is only important for your freshness. Again, coming back to toothpaste, the most common brands is Pcni, Pepsodent, Colgate, Kidodent. All have different flavors like strawberry flavor, mixed fruit flavors. Any flavor that kid likes, they can use it. But again, if they are fussy about the toothpaste, do not use the toothpaste. Just concentrate on brushing. And if the kid doesn't know how to spit, at that time also please avoid using toothpaste. When you can start using fluoridated toothpaste? For children below 3 years, it is not necessary at all to use fluoridated toothpaste. For the children between the age 3 to 7 years, you have to use only once at night fluoridated toothpaste. And for the children who are more prone to caries and they are above 7 years, you can use twice in the morning and at night as well. सब क्लीन करने के बाद भी ब्रशिंग 2 बार करने के बाद भी there is bad odor. Halitosis है. Why? The reason is you are not cleaning your tongue. The tongue should be cleaned at least once in a day. Empty stomach is much better. But please be gentle. If you do it harshly, you are going to destroy the taste buds. Again, the common question is there is no sign of teeth eruption at the age of 1 year or the sequence has been altered. अगर किसी और का दांत 6 months पर आ रहा है, it is not compulsory that every child gets the same thing. It is okay if the tooth has not erupted till the age of 18 months. Yes, if till then it has not erupted, you need to show to the dentist and get the X-rays done. But it is okay कि अगर पहला दांत नीचे का आया है, पीछे का आया है, that is absolutely fine. Sequence alteration doesn't matter. Main problem in kids is teething pain. Teething pain, yes, it makes kids cranky. So what I suggest is, पहले से ही just give them massage on the gums with normal finger without using any kind of medicine. The only thing is your nails should be cut and the fingers should be washed properly. आप पहले से if you give them massage for 3 to 4 days in a day, the child will be okay with it. He won't have any problem. Or what you can do is you can give unsweetened rusk or unsweetened teethers are there. Even you can give frozen carrots, frozen anything that is frozen but long, not very short because they might choke on it. But the best thing is to give them massage with your own finger. If still the pain exists and if still the kid is cranky, then only use any gels like Dolo Gel C2, which will relieve the pain. Certain kids are born with the teeth or within the first month of the birth, the child gets teeth. Those are natal and neonatal teeth. They are very mobile and they move easily, which might create a problem. The child might aspirate it and get choked on it. It can be a hindrance during feeding also. So it is necessary that we should remove them as early as possible before the child aspirates and creates a problem. Another common thing is thumb sucking or finger sucking. Thumb sucking is very normal till the age of 3.5 years because it is a gesture that kids do in the phase of security. So it is very common till the age of 3.5 years. After that, you can explain to the kid that it is a bad habit, and after 5, if still the habit exists, then the dentist needs to intervene. When we should start the treatment of malaligned teeth? Braces are in fashion right now कि हर किसी को braces लगवानी है, but it is not necessary that हर जन को braces की जरूरत है. And please, you should always advise कि braces should be done after 14 or 15 years when all the permanent teeth have come. What to do if the permanent incisors appear to be very big relative to the adjacent teeth? Generally, what happens is permanent incisors come during the mixed dentition, where the milk teeth are also there and the permanent teeth are also there. So parents tend to compare the permanent teeth and the milk teeth. Milk teeth are always smaller in size and brighter and white in color. Where permanent incisors, they will be always bigger in size and will have yellowish tint. So we cannot compare the both. What to do if permanent teeth start erupting behind the milk teeth? This is again very common in only the upper incisors and the lower incisors in the front teeth. So you need to get the milk teeth removed as early as possible because it will change the position of the permanent teeth if you do not get it removed. When should be my child's first dental visit? Child's first dental visit should be planned as soon as the child turns 1 or the first tooth gets erupted. Is pediatric dentist different? Why pediatric dentist over general dentist? The reason is they are willing to patiently devote more time to each patient as usual it is required with all the kids. They are specially trained to handle a child's behavior during the treatment. We use specialized instruments, materials, and technology specifically designed for the kids. A child's dental needs are very different from that of an adult, which are better understood by pedodontists. Last, my favorite question, do you know any pedodontists? Thank you.
Now we know. Thank you, Dr. Hitu. That's very informative talk. One my special I want to ask. We are a pediatrician institute especially challenge the children like we have children having the dental problem during if they are having this cleft lip or palate or the cerebral palsy child. So what are the advice for Mike.
Cleft lip and cleft palate has to be treated with 3 or 4 of us pedodontists, orthodontists, and the cleft palate surgeons, oral surgeons. So initially the part role is of oral surgeon, which is then transferred to us for the checking of if the during the surgery if the tooth buds have been moved or they have been destroyed. That time we have to check. If they have been destroyed, then we are supposed to give them artificial tooth, and it has to be continuously changed as per the age, as per the jaw grows. So that is for the pedodontists.
Yeah, thank you, Dr. It was extensive. What I learned from this that everything boils down to the quality of life. And the dental issues, dealing with dental issues, time dealing with dental issues, is definitely going to affect the quality of life. चाहे बच्चा हो या बड़ा हो. If any questions from the audience? Madam, please.
Dr. Hitu, you very rightly said the bottle is the main culprit. And we pediatrician also know the bottle is the main culprit. And we have stopped telling the patient, started telling the patient not to use bottle ever. I hope we all agree with it. Thank you.
Definitely, madam. We pediatrician should emphasize on the exclusive breastfeeding and not the bottle feeding.
I would just like to add on ma'am's point. Ma'am, sometimes it is necessary to give bottle. As a mother, I had to give bottle. It was not feasible for me to feed him. But there are possibilities.
Dr. Hitu, mic please.
Sorry, so sorry. Ma'am, sometimes it is necessary to feed with the bottle. But you should be very careful when to stop it and how to feed. If you are feeding with bottle, it is necessary कि आप 10 minutes feed करें, 15 minutes feed करें, overnight bottle नहीं छोड़ रहे. या during the time जब child is sleeping तब तक ये आप bottles नहीं दे रहे उनसे, because drop by drop going through the bottle is very harmful, and stopping the bottle at the right age, that is at the age of 2, you should stop. My child stopped the bottle, he was about to turn 2, he stopped right there and then. But some certain parents, they go on with the bottle feeding till the age of 5 and 6, which is very, very negative because it changes the shape of the maxilla, the upper jaw. That is wrong.
No.
Yes, ma'am.
Yeah.
Yes, ma'am. Absolutely. Yes, ma'am. Absolutely.
So, Dr. Hindu, we differ here with you because we pediatrician only emphasize on the exclusive breastfeeding and not means encourage the bottle feeding first. We are emphasizing more on the katori feeding, spoon and katori. So whatever the situation, we can give the instead of the bottle, we can give milk or even express breast milk by the bottle, without the bottle, and with the katori and the spoon.
Yes.
In the special circumstances also, like left lip palate or the specially challenged children, we can use the katori.
Yes.
So this is the message from our care side.
Thank you so much. Thank you, Dr. Hindu.
Thank you. And thank you organizers for the giving us opportunity to chair the session. Thank you so much.
For the valedictory, we all can join in hall A. And we can all collect your coupons for the dinner that from the registration counter where it's not collected. सर कराएंगे ना वो तो वेरिफिकेशन आइए आइए
फोटो लगाएंगे फोटो वाला को बुलाएंगे चलो कोई फोटो ले लीजिए आपको